Good morning, and I welcome you all on behalf of Sepsis Forum of India and ISSM Pune branch. Uh, Today we are going to go through Sepsicon 2022. As we all know that sepsis is an ongoing burden, and what we can do to control the sepsis and the healthcare facility burden. For going ahead with the conference, I welcome Dr. Yatin Mehta sir to take us through the journey. Dr. Yatin Mehta sir, as we are all aware, he is the chairman at Institute of Critical Care Medicine at Medanta Hospital, and he is the president of Simulation Society of India. He has been a past president of ISCCM from in 2018-19, and he has headed Research Society of Anesthesia and Clinical Pharmacology in 2016. He has area of medicine and cardiac anesthesia. With this short introduction, I invite Dr. Yatin Mehta sir to take us to the with the journey and sepsis. Over to you, sir.
Thank you all. Thank you very much.
Hello, everybody.
Sepsis Forum, the concept began a few years back, along with Kapil Zerpe and Subal Dikshit and many other seniors who are the members of the executive committee. It's a non-political organization we made primarily to improve research and academic activity related to sepsis in India. And I think we had several conferences in the past during the difficult COVID times, and we had great success with them. They were scientifically highly appreciated and very well attended also. And this year also we have a large number of registrants. So I think we are now involved in a couple of research projects also, multi-center studies involving different parts of India. And primary objective is only academic activity. In addition to the annual conferences, we are going to have regional conferences also. And all of you will feel at some point of time involved with the and touched by the Sepsis Forum. So I would thank all the attendees and all the faculty members, international as well as national, who have contributed to success. Dr. Govil has worked very hard for the scientific content. And I would like to ask Kapil to say a few words, and then we can get on with the first presentation.
Yeah, good morning to everyone, and welcome you all. Thanks, sir, for a very brief and very apt introduction of the Sepsis Forum. As you rightly said, the Sepsis Forum is a non-profitable academic forum. We intended to spread the word about sepsis. And it's not only related with the medical fraternity, we'd like to do awareness in a common public. So in future, we are coming up with a few projects which will involve the common public awareness about the sepsis. And this is a third annual conference of Sepsis Forum, which is running smoothly. Last two conferences were online, and we have decided to have an annual event as an online platform. And all of us know that this particular month is a sepsis month. So we deliberately kept our annual conference or plan our annual conference during the September to just celebrate or just create awareness regarding the sepsis in a September sepsis month. And I take this opportunity to thank Dr. Deepak Goyal, who wholeheartedly agreed to take the responsibility of the scientific program. And he has come up with the excellent scientific program and selection of the faculty nationally as well as internationally. And I'm sure next 2 days we will enjoy and will enlighten us with various faculties with their experience. So with this short introduction, I hand over this thing to the Dr. Abhijit Deshmukh for the further proceeding. Deepak, in quick time, would you like to speak? Abhijit?
I think Dr. Mehta sir and you have already spoken about the Sepsis Forum, and I am sure that the current program will highlight the current issues in the management of the sepsis, and it will increase the knowledge to everybody. Thank you.
Thank you, Yatin Mehta sir. Thank you, Zirpe sir, and thank you, Deepak Goyal sir, for the brief introduction. And I hand over back to Yatin Mehta sir to take us through the journey about the surviving sepsis guidelines. Over to you, sir.
Sepsis Forum annual event. And thank you for inviting me. The previous meetings have been great success, so I hope you enjoy this one also. So I'm going to talk about surviving sepsis, what has happened in the journey so far. So the journey began with 1860s when Louis Pasteur talked about the germ theory, and then Robert Koch's theory in 1890. And the first definition of sepsis came in as late as 1992 in chest by Robert Bone. Then classic paper, early goal-directed therapy by Rivers et al. From 2001 from the US. And same time, there was a consensus conference on sepsis 2, which defined sepsis. Then Philip Dellinger gave us the first version of the Surviving Sepsis campaign. The goal was to reduce the mortality in 2004. 2008, we had the Corticus trial, and then with the TRIS trial in 2013, the VAST trial in 2014-15, and in 15, we had the PROMISE, PROCESS, and ARISE trials about early goal-directed therapy and fluid therapy. So sepsis 3 definition came out in 2016, and in 2021 the new guidelines for surviving sepsis were published. And this was the group which wrote the guidelines. We had several meetings, physical as well as virtual, and all the representatives of different major countries in the world were there and their societies. So I was lucky enough to represent ISCCM and India in this meeting. So where do we stand in India? I think particularly if you look at the incidence of global burden of disease, you can see that I think we are probably better only than Central Africa and West Africa. So the incidence of MDR is also increasing, and I think we are the leaders of the world. Now, this was a 5 years experience by Dr. Subhash Todi, and this was a prospective study in Calcutta, and they compared the mortality with ANZIC study, where the mortality ICU 28-day and hospital mortality was 26, 32, and 37%, while in India it was significantly higher. Now, this was an INDICAP study. Again, I think many of the faculty members and the audience would have participated in that by Jigidivetia. And this also showed that almost 25%, this was over the point prevalence of 4 different time points. And this also found that about 25% of the patients were admitted with sepsis in the Indian intensive care units, and 25% roughly developed it while they were there. So almost more than half the patients had sepsis in the intensive care in India. So where we can do better, part of it is that if the bundles help. So this was a paper from All India Institute, 6-hour sepsis bundle, and they found that hospital mortality showed a decreasing trend, 18%, when people were compliant with the bundles. So this was the Surviving Sepsis campaign guidelines, which are published in 2021. Bring you greetings from Vedanta, the Medicity, where I work. So to understand this, the rest of this talk, I think it is important to have the key in your mind. So the blue sign is the best practice statement. Gray query is no recommendation. Single recommendation is weak recommendation. Green, double green is strong recommendation. Single red is weak recommendation against. Don't do it. 2 exclamation marks is a strong recommendation against. And greener the evidence, greener the symbol, better the evidence. The more yellow it is, less the evidence. And if it is a blue oval sign, that means there's a change from the previous one. Upward is an upgrade, and D is downwards a downgrade. So coming to the performance improvement, the recommendations were that we recommend using a performance improvement program. Now, this in India particularly we need to implement because this has been shown to significant. There were 50 observational studies where the 30% almost reduction in mortality because of that. So I think we need to get on with it in the emergency rooms. Now, how do we suspect sepsis? Well, the recommendation is against QSOFA because QSOFA has not been validated in the hospitalized patients. It's only in the emergency room. So recommendation is not for diagnosis of sepsis for QSOFA. Also, a lot of AI is coming into medical practice. And this meta-analysis of 7 studies of 42,000 patients showed that it did improve the outcomes by machine learning. So how does it help? Well, it addresses the drawbacks of a QSOFA over SOFA and indicates the usefulness of AI. Coming to the initial resuscitation, so the recommendation is the best practice statement. We recommend the treatment begin immediately. Obviously, this is a no-brainer. And also for patients with sepsis or septic shock, we recommend using 30 ml per kilo of crystalloids within the first 3 hours. This is a weak recommendation, yellow sign. This is a little change from the previous one. Now, why it was based, this was basically mostly based on observational studies. But if you look at the average consumption of crystalloids in process, arise, and promise trials, all were, the average was about 30 ml per kilo. And also this one study, retrospective analysis, if less than 30 ml per kilo were administered within 3 hours, then hospital mortality was higher and resolution was took longer time. Then how do you assess how much fluid to give, whether the patient is responding, responder, non-responder? So we recommend dynamic assessment of organ perfusion and intravascular volume resuscitation. How does one do that? We can use PLR for non-intubated patients, or you can use SVV or PPV or SPV in intubated patients. There are limitations to that. I can't get into details of that. And there was a meta-analysis which showed the dynamic assessment, reduced hospital mortality, reduced ICU length of stay, and reduced duration of mechanical ventilation. Coming to serum lactate, there is a little weaker recommendation. Serum lactate should be monitored for guiding therapy, but there is no stringent guidelines regarding the goals of lactate. And in fact, I'll come to that in the next slide, that we recommend using capillary refill time because it was based on the Andromed shock CRT trial, and where CRT was better than the other monitoring tools. So I think this is a very simple tool which costs nothing. The refilling is within 2 seconds. The perfusion, peripheral perfusion is good. If it is not, it is not good. Okay. Now, how much is the target for mean arterial pressure? Well, the recommendation is a MAP of 65. Previous studies have tried to show the differences between 65 and 85, but there was no difference between the two. In fact, the cardiac morbidity was a little higher in patients where the MAP was kept at 85. So there is no particular advantage. So 65 is what is recommended. How does all this helps? Well, it recognizes the potential detrimental effects of excessive fluid administration, stresses use of dynamic hemodynamic parameters, capillary refill time, and device MAP targets. How soon do you admit? Well, we recommend within 6 hours. Weak recommendation, weak evidence. And several studies. There's a retrospective study of 15,000 patients where it was more than 3.7 hours per trial, then the morbidity was higher. And there was every hour of delay leads to 1.5% in this 400 patients database. Which anti-infective to give? When to give? We recommend that we should evaluate the patient and continuously re-evaluate for non-septic causes if there are any. This is a best practice statement. And look at the likelihood of investigate the likelihood of septic causes also. This is because unnecessary antibiotics are administered too many times, and almost 1/3 of the patients do not have sepsis who are treated as sepsis. Antimicrobial should be administered immediately, particularly more so in septic shock, but also in patients without septic shock. Early administration does help. This is a large series of 50,000 patients in 150 New York hospitals, where every hour of delay added to the mortality. Then, for adults with possible sepsis or septic shock, we suggest a time-limited course of rapid investigations within 3 hours. This is a change from the previous one. Again, if there is a doubt the patient may not be having sepsis, then defer the antimicrobials. Weak recommendation, weak evidence. Procalcitonin is being extensively used over the last 2 years in India, particularly during the COVID times, and many physicians do believe in doing a procalcitonin to decide whether it is antimicrobial therapy, antibacterial therapy is required or not. But that may not be correct. So we recommend against using procalcitonin plus clinical evaluation for administration of antimicrobials. So those are the 3 RCTs, 1769 patients, PCT versus no PCT, and they found no difference in mortality, length of ICU stay, and length of hospitalization. Since there were no apparent benefit and there were costs involved, particularly in the low-income countries, so we recommended against procalcitonin for administration of antibiotics. Summarizing this, the shock is timing, the shock is present, then shock is probable, administer immediately within 1 hour. If shock is absent, then rapid assessment for non-infectious causes, and you can administer up to 3 hours. If sepsis is possible, within 1 hour. Then there's a best practice statement regarding how broad spectrum to give, because earlier recommendation was you give both gram-positive and gram-negative with MRSA cover, but now the recommendation is if the MRSA incidence is high in your hospital institution, then you should give MRSA cover. Otherwise, you do not give unnecessary MRSA cover. If the incidence of MDR is high in your environment, which I suppose most of us would have it, and you are suspecting gram-negative sepsis, we suggest using 2 antimicrobials to give a broader gram-negative cover. If it is low, then do not use 2 gram-negative cover. And once you know the susceptibility, then you can de-escalate. So do not use gram-negative dual cover once you have the cultures. Most of the beta-lactam should be administered as an infusion so that your area over the MIC is higher. So we recommend, now depending on which antibiotics you're using, and we also best practice statement that you must administer antibiotics according to the PKPD principles. So we must understand the PKPD of each antibiotic which you are using. When to de-escalate once you started? Well, we suggest daily assessment for de-escalation. Weak recommendation. We suggest shorter duration of therapy or longer duration of empiric therapy. Again, weak recommendation. And if you're not sure, then you can use procalcitonin for de-escalation. Again, weak recommendation, no evidence. Now, regarding de-escalation, so we are worried about your environment, your anti-myograms in your hospital, of excessive antibiotic use, and the incidence of obviously MDR. But this also, in addition to that, there are collateral benefits. Meta-analysis about de-escalation showed improved short-term mortality, a shorter course, shorter hospital length of stay. And also regarding short duration versus longer duration, full spectrum of sepsis, pneumonia, bacteremia, intra-abdominal infection, and urinary tract infection. There were no differences between short duration and long duration. So short duration is preferred. So we recommend using procalcitonin for de-escalation, but source control is a must. Again, weak recommendation. How do these guidelines help? Well, from point of view of timing of antimicrobial therapy, it differentiates into sepsis with septic shock, sepsis without shock, and no likelihood of or low likelihood of sepsis. It recommends judicious use of microbials, support use of beta-lactams infusion, and de-escalation depending on procalcitonin. Anatomical diagnosis is important. This is a best practice statement. Remove the source of sepsis, including your PICC lines and so on. Again, best practice statement. There are several randomized studies which showed advantages if it is done within 6 hours. Coming to the hemodynamic management, the 3 questions which I'm going to address is fluid resuscitation, vasopressor therapy, and hemodynamic monitoring. So crystalloids are recommended as the first line of therapy. Strong recommendation, moderate evidence. Again, a change from the previous one. Weak recommendation, weak evidence. We suggest using balanced crystalloid compared to normal saline. And this is an improvement from the previous guidelines, 2016 guidelines. And this is based primarily on the SMART trial, which compared balanced solution with 30-day mortality normal saline. And the secondary analysis, they found the primary analysis mortality was reduced, but also 30-day hospital mortality was reduced. MIG 30 was lesser, and increased RRT and vasopressor-free days in patients who received balanced salt solution. Use of albumin, so we have to be sensible. But yes, if you use excessive fluids, crystalloids, then it is recommended that you add albumin. Now, this was a paper, albumin replacement, multi-center open-label RCT, 1,800 patients, and they found higher mean arterial pressure and lower fluid balance when albumin was administered. So again, a meta-analysis of 55 RCTs, 27,000 patients, comparing albumin versus no albumin. They found a higher CVP, higher MAP, higher cardiac index with albumin addition to the crystalloids. Now, what is the cutoff value at which you would administer albumin has not been specified, so we can't comment on that. Regarding starches, I think that's the last we are going to hear about starches in septic shock. Several meta-analyses have shown increased RRT, increased mortality with starches. So starches should not be used in septic shock. Gelatin again is recommended against. This is changed from the previous one because RRT requirement was higher. It's an animal derived source of the gelatin. So anaphylactic reactions are also higher with gelatin. Coming to which inotropes to use or vasopressors to use, well, the first line we recommend norepinephrine. Meta-analysis of 11 RCTs showed lower mortality and lower risk of arrhythmias compared with dopamine. If norepinephrine is not available, then epinephrine or dopamine may be used. In India, some centers are still using dopamine. So, inadequate arterial pressure, despite norepinephrine, vasopressin should be added. This is based on Vanish trial as well as VAS trial, where vasopressin was compared with no vasopressin, and they both demonstrated a catecholamine sparing effect of vasopressin. So normally you start with vasopressin with norepinephrine doses, dose crosses 0.2 mics per kilo per minute. Coming to if the norepinephrine levels and despite norepinephrine and vaso, the arterial pressure still remains low, you can add epi. Weak recommendation, weak evidence. Terlipressin evidence is against, so don't use it. If there's a persistent hypoperfusion and cardiac dysfunction in these patients, then dobutamine may be added. Mind you, from the practical point of view, it's not in the recommendation. Whenever you use dobutamine, there is some vasodilatory effect, so you may need to increase your vasopressor doses. Levosimendan, even if this cardiac dysfunction is not recommended, this is primarily based on Leopard's trial of 515 patients. They have found higher supraventricular arrhythmias and longer mechanical ventilation in patients administered levosimendan. And it does make sense. They had lots of pro and con debates in the previous conferences regarding use of levosimendan in septic shock. Well, it's a potent vasodilator. Although it bypasses the beta receptors for inotropic effect, but that is not relevant. So, not recommended. The meta-analysis of 7 RCTs comparing levosimendan with dobutamine was not superior. So, coming to summarizing, vasoactive agent management, use norepinephrine as a first line of treatment. For patient with septic shock or vasopressors, target mean arterial pressure of 65. Consider invasive monitoring of arterial pressure. If central access is not available, you can start it with the peripheral line in a large cubital vein above the elbow and in a diluted form, and then later on, once you have a central line, then convert it there. Mean arterial pressure remains low, then you can add vasopressin and consider dobutamine or switching to epinephrine if the perfusion remains low. Invasive monitoring, as I said, is recommended. Start vasopressor peripherally, I've already covered that. So summarizing, it clearly suggests the recommendation suggests preference for balanced crystalloids. Clear mandate is against gelatins and starches. Suggests role of albumin in large volume resuscitation. Advocates restricted fluid strategy and takes into consideration Venetian West trial for vasopressin and Leopard trial for levosimendan. Coming to oxygenation and ventilation, these are the things which I'll quickly discuss. So for hypoxemic respiratory failure, we recommend HFNC over NIV. Weak recommendation, weak evidence. And NIV compared to invasive mechanical ventilation, there is no recommendation. And in this study, HFNC was compared with NIV. It improved in 90-day survival, significant mechanical ventilation-free days in HFNC. Also, in this meta-analysis of 2 RCTs, HFNC reduced the intubation compared with conventional oxygen therapy. Now, patient with sepsis-induced ARDS, recommendation is 6 mL per kilo, based on the ARDS network studies, compared to 10 mL per kilo. Strong recommendation. Again, strong recommendation, we keep the plateau pressure under 30. Weak recommendation, using higher PEEP over lower PEEP. This was based on the study, and it showed a higher PEEP reduced the mortality when PF ratio was less than 200. We suggest using low tidal volume compared to high tidal volume ventilation. Recruitment maneuvers, which one to use? Well, we recommend weak recommendation. We recommend traditional recruiting maneuvers and not increasing sort of incremental PEEP. Because the negative studies on incremental PEEP, they increase the 28-day mortality in moderate to severe ARDS. Prone ventilation, a lot of it we have used during the COVID times. So we recommend prone ventilation if patient is refractory, hypoxemic, for more than 12 hours daily. This is a strong recommendation, moderate evidence. Neuromuscular blocking agents, we recommend boluses over NMDA continuous infusion. Again, this is based on few studies. If the patient has refractory hypoxemia, despite all this, then obviously there is no choice left. We recommend VV ECMO in centers which are equipped enough to do the VV ECMO. Obviously, this will be based on several trials, including Caesar trial and Eolia trial. This is one of our own patients on VV ECMO. So how do this help? Well, it recommends on the role of high flow nasal cannula. It suggests high PEEP versus low PEEP. It mentions the duration of prone ventilation. It mentions the NMBA bolus doses and certain statement on VV ECMO. Coming to additional or adjunctive therapies, IV corticosteroids are recommended in 200 milligram per day, either boluses divided doses or continuous infusion. And this was based on several studies, adrenal trial, approaches trial, and Vanish trial. Coming to the adsorbent therapies, the recommendation is against poly-B filter. This was based on a large multi-center trial in the US. So recommendation is against use of poly-B filter. Other blood purification techniques like cytosorb, there are no comments on this because there's insufficient evidence to comment on that. We recommend strong recommendations, restrictive transfusion therapy, against using IG. Stress ulcer prophylaxis is recommended, and strong recommendation, pharmacological VTE prophylaxis unless a contraindication to it exists. Strong recommendation, low molecular weight heparin over unfractionated heparin, use against both combination of pharmacological and mechanical prophylaxis. Renal replacement therapy, well, there is no recommendation really, depending on whatever the indication is. Don't use renal replacement therapy just for sepsis. It should meet the criteria for renal replacement. And insulin therapy, moderate recommendation, strong recommendation, moderate evidence to keep sugar below 180. Now, this combined prophylaxis, mechanical as well as pharmacological, was based on this study of which I was one of the authors, published in NEJM, randomized control trial. Vitamin C, the recommendation is against. Bicarbonate, his recommendation is against. Only in extreme cases you'll use bicarb. Enteral nutrition should be begin within 72 hours. And also don't forget, we must have the clear picture of goals of care, family counseling, palliative care, hands-on situation, discharge criteria and planning for discharge, drug reconciliation, post-discharge care, and most important, rehabilitation. But summarizing, Surviving Sepsis Guidelines brings together the most contemporary knowledge in refinement and treatment of sepsis, but a tool is as good as the user. So thank you very much for your attention.
Thank you, sir. Thank you. There's a question for you, sir. Does low partial pressure of oxygen and raised procalcitonin levels require escalation of antibiotics?
That's a very good question. It is difficult. There is no real evidence for that. But if the patient has, say, ARDS, he is on a ventilator, and his oxygen requirement is going up, that may be considered as worsening of the ARDS. And if it is the etiology of ARDS is sepsis, yes, in that case situation, you may consider escalating.
Right, sir. Right. Thank you, sir. Thanks. Thanks for your valuable inputs. And I now invite all the esteemed faculties. I invite Dr. Yatin Mehta, sir, Jirpe sir, Deepak Goyal sir, and Dr. Subal Dikshit sir for inauguration ceremony, for a small lamp lighting ceremony. And
yeah, Bijit, please go ahead.
yes, sir.
Thank you, both.
Thank you, sir. Thank you. As we are all aware about the present scenario of using
Thank you, Vimal.
chemicals. Pardon, sir?
Please go ahead, Abhijit.
Yes, sir. Yes, sir. As we are all aware about the uses of antifungals, and in the present scenario, because of increasing number of immunocompromised patients, the use of antifungal definitely has increased. Where we can put in coordination and get better clinical outcomes. I invite Dr. Prakash Shastri sir for telling us about antifungal stewardship and its usefulness. Dr. Prakash Shastri sir is a senior consultant and vice chairman at Sir Gangaram Hospital, New Delhi. And his area of expertise has been antimicrobial resistance, fungal infections, and in critical care nephrology. So I invite Dr. Prakash Shastri sir. Over to you, sir.
I want to thank the organizers of this sepsis workshop. Not very common, and it hasn't drawn the attention of not many people, and obviously doesn't have too much of sponsors' participation in it. The topic is antifungal stewardship, and I would like to give my opinion, my ideas about this condition as an intensive care practitioner and not as a microbiologist. So why was the need to introduce this topic to this erstwhile audience? There has been a dramatic increase in fungal infections. We are becoming more and more sensitized to the fact that something or the other happens in the intensive care unit, and people who are otherwise immunocompetent tend to behave as immunocompromised patients, and that's why they become a prey to fungal infection, especially if they stay in the ICU for a long period of time. Yes, we do get immunosuppressed patients. There are so many more post-transplant patients, patients with hematopoietic malignancies, and multiple comorbidities come to the ICU. And we tend to do a lot of invasive procedures. We tend to give total parenteral nutrition. And of course, we bombard the patient with antimicrobial therapy that sets the stage for fungal infection. If you ask me, the diagnosis and treatment of fungal infection is not a bit of a challenge, it's a huge challenge. The diagnosis is very difficult because the presentation is non-specific, and the treatment has a lot of financial toxicity attached to it. And this goes across the board to clinical microbiologists, other clinicians, including intensive care physicians, and including the ID physicians. Now, let me share this data from Sir Gangaram Hospital. And this is the bloodstream infection from our ICU. And you can see that coagulase negative staph is the most common microorganism which is grown in blood culture. So lots of time the coagulase negative staph tends to be a contaminant. We tend to ignore it unless the patient has got some artificial valve or some kind of prosthesis put in him. But to see the second most common bloodstream infection is the Candida species. And this has really brought the people to sit up and take notice that Candida species tend to come into the ICU. And unfortunately, even though this data is relatively old, we did not have much information about the spread of Candida infections. Yes, the Klebsiella, the Acinetobacter, Enterococcus, Pseudomonas, they're all there. But Candida ranks above them in the bloodstream infection. So this has really sensitized the intensive care physicians to become a bit more proficient in the treatment of Candida infections. The threats that have been perceived and now been well recognized is that there is a rise in number of patients with invasive fungal infection. And if you want to get some success in the management of this condition, then the early diagnosis is imperative, like bacterial infection. Every hour delay in sepsis, for example, tends to increase the mortality by 7 to 8%. Similarly, here, every day in delay in the treatment, starting of the treatment, would increase the mortality by 20 to 25%. And the conventional diagnostic procedures like cultures, blood cultures and all, they generally, we know that even otherwise, that when we send off cultures, 50% of the cultures tend to be negative. And of course, as I mentioned earlier, there is non-specific clinical presentation of invasive fungal infection. And since they are so afraid of missing the bus when it comes to starting therapy, 50% of antifungal use is inappropriate. Now that the doctors have become sensitized to the possibility of fungal infection, they tend to throw antifungal drugs to almost every patient who comes into the ICU. And having said that, appropriate use of antifungal is difficult even by expert clinicians. They tend to err towards the side of caution and tend to give prophylactic and even empirical antifungal drugs, especially in patients of ICU who has got fever, who is very sick, and who has not responded in the first 4-5 days or first 2-3 days to conventional broad spectrum antibiotics. So there is a pressure to start antifungal early due to the high morbidity and mortality associated with fungal infections. But there are issues in antifungal use, and that leads to variability in the practice of different physicians in different walks of life in different towns and cities, whether it is metropolitan cities and the hinterland. The high cost, the toxicity, and of course, the drug interaction, especially with the azole class of antifungals. There is genetic variability governing difference in the pharmacokinetics of antifungal. We have read about slow acetylators and fast acetylators when we were taught about the antitubercular therapy. Similarly, when it comes to voriconazole and other azoles, there are people who have got difference in the way they metabolize the drug. There are some in whom the metabolism is slow and in some the metabolism is high. And the presence of voriconazole itself tends to inhibit the metabolism of other drugs. So there is a likelihood that if the patients are on immunosuppressants, especially post-transplant patients, that their effect can become magnified. And then on top of it, if that was not enough, there is definite increase in the antifungal resistance. Now, 10% is the cutoff figure. If the number is below 10%, is the number of antifungal resistance is less than 10%, then we are quite okay. But when it crosses 10%, and believe me, it is really crossing. In my hospital, the resistance to fluconazole in Candida tropicalis, the most common Candida that we grow in my ICU, is in the region of 10 to 15%. And that is a cause of concern. And that is why you would see in the slides that I mentioned show later on, there has been an increased use of echinocandins and even amphotericin B in our patients. So always there was a problem with convincing other people as to whether our data is correct or not. So finally, it came down to Professor Anulok Chakravarti from PGI Chandigarh to do a landmark study, which was published in 2015. He actually did it in 2013. He just got together all the ICUs of the country. It was a multi-centric ICU-based study in which they studied the incidence, characteristics, and outcome of ICU-acquired candidemia in India. So this is the very most authentic data from the Indian characteristic. And what was the findings of this particular study? That yes, we were reasonably good in managing this patient, but then candidemia was cleared microbiologically only in 27.5% of cases. The 30-day crude mortality was 45%, and the attributable mortality due to Candida was to the tune of around 20%. And the independent predictors for mortality were admission to a public sector hospital. The private sector hospitals tended to do slightly better than that. Apache 2 score and admission, we know that sicker the patient, the more the chances of fungal infection. Underlying organ failure, including renal and liver failure, uses of central line and steroid therapy. The study revealed high prevalence of Candida tropicalis, 40% and above, while Candida albicans and Candida paracillosis, they came next in order with only 21% and 10% of cases. So there is a difference. In the Western world, if you contrast it, Candida tropicalis is uniformly less common. We have around 5 to 10% of Candida tropicalis. The majority of Candida that are grown in the Western world in the intensive care unit settings is Candida albicans. So it's around 50 to 70% of Candida are Candida albicans. It's so different from Indian setup. And Candida glabrata is the second most prevalent Candida to be grown. We encounter Candida glabrata only in 7 to 8% of patients. And the rise in Candida glabrata in the Western world is attributed to the increased use of azole prophylaxis. So as you can know that unless we learn from the mistakes, it is likely that we will also follow the same path and we'll end up with azole resistance in our ICU also. As we move on, what about the molds? invasive aspergillosis is the second most common invasive fungal infections in our ICU. But then the incidence of invasive mucormycosis is also increasing. And we learned that to our chagrin in the COVID epidemic, where there was literally a flood of mucormycosis cases in the post-COVID period. And before that also, autopsy data from a tertiary care center in North India, that's Chandigarh, found evidence of invasive fungal infection or invasive mold infections in almost 22.4% of cases, with majority being aspergillosis and less common being mucormycosis. So there is difference in epidemiology. In the developed countries, the most common the risk factors are diabetes, hypertension, and hematopoietic malignancies and stem cell transplant. In the developing country, mostly it is diabetes, trauma, but we don't have much of systemic data on trauma, but we do come across apophysis in patients who have had trauma and they come later. So when it comes to molds in my hospital, the major molds are aspergillus, fumicatus, and flavus, almost in the same proportion. And then the rest is a huge number of mucor species which are present, which account for around 25% of cases. But we have our own share of fusarium. And yes, Cladophora bantiana, the classical black fungus, and Scedosporium apiospermum, which is seen most commonly in our setup in the post-transplant patients. In the site of infections, as far as mucormycosis is concerned, rhinocerebral obviously is the maximum, but then we have seen quite a lot of pulmonary cases also. And that by and large, the diagnosis of these pulmonary cases have been when the operation has been done and the sample has been sent for histopathological examination. And when I did a study on mucormycosis, I had to take the help of the regional fungal study WHO center to actually extract the DNA from the histopathological specimen and retrospectively find out what the species were. So as I have to mention here, that it is more easy to find out broad spectrum aseptate hyphae in the nasal sphere. Very, very difficult to actually grow them in the culture. And that is why it becomes very difficult to actually label the patient, because you're going to give amphotericin B to this patient. And we know that amphotericin B and chemotherapy are somehow or other almost parallel to each other. Culture positive, as I said, very few cases, but then the most common mucor that is grown in our ICU is Rhizopus erisis. The rest of it come much later. Cunningham mela and apophysis, I said just now, that they are occasional cases that we come across. So what are the reasons to introspect and work towards antifungal stewardship? So what is expected? So let us define what is expected if we are to embark upon the program of fungal stewardship. So it basically envisages the optimal use of antifungal through careful selection of agents based on, number one, patient profile, target organisms. Obviously, you can't treat mucormycosis with fluconazole. Toxicity, yes, toxicity when the patient is already having fungal organ dysfunction. We can't really give drugs which are likely to have organ-specific toxicity. The cost is involved. Fluconazole comes cheap, but anything other than that is expensive. And then the likelihood of emergence and spread of antifungal resistance has to be kept in the back of our mind, because we don't want to go the Western way, where the increased use of fluconazole prophylaxis has led to the rising number of Candida glabrata. So the objective is to educate the clinicians, the microbiologists, the radiologists, the pathologists, and pharmacologists on antifungal stewardship program. One of the first things that we can do is you can document the amount of antifungal that you use in the hospital and its rationale for the use. So the antifungal drug consumption is measured on the basis of defined daily dose per 1,000 patient days. That is one denominator that we can use because that is the one which is prevalent all over the world. And we can also do therapeutic drug monitoring for azoles. So as you can know, fluconazole is one drug which we doesn't need it, but other azoles would really be better managed and better utilized if we had therapeutic drug monitoring. Posaconazole and voriconazole drug monitoring has become relatively common, still not available in my hospital, but yes, it is being used in quite a few centers and we can get it done from outside. But again, that is not so commonly available. And most importantly, at an institution levels, develop guidelines for the initiation of antifungal use in different patient populations, whether it is empirical therapy, whether it is preemptive therapy, or it is a targeted therapy. As the guidelines are important for starting the antifungal use, so are they important for stopping the antifungal. So stop the empirical therapy when negative tests come in. Use the biomarkers like galactomannan are used when I'm treating aspergillus to monitor the response and guide duration of treatment in proven or probable cases. De-escalate broad spectrum antifungal to narrow spectrum antifungal after specific diagnosis, and maybe move from intravenous compounds to oral compounds. The newly available azoles nowadays, the gastroproductive tablets which have become available now, have become a big pool to allow us to switch from intravenous formulation to oral formulation. The implementation of effective antifungal stewardship program monitors the antifungal use, generates local epidemiology data, antifungal policy for the institution to follow, and make sure that there is implementation of this antifungal policy by doing periodic audits, and obviously based upon the findings of the audit, review the antifungal policy, and then if these things are taken together at the national level, we can formulate a national guideline. So what we have done in our hospital, that we have charted the annual incidence of candidemia. As you can see that the levels in the intensive care unit have gone up, though in the wards, they are sort of, staying there plateaued. And this is the candida that has grown in my ICU in the year 2020. That was the year when COVID was rampant all over the country. And lo and behold, what do we see? That the most common candida that we have grown in the period after 2020 was Candida auris. And there is something came as a big shock to us, because we know Candida auris. Number one, it doesn't come from the community. It is obviously acquired from the hospital. So we are dealing with something. We were dealing with some kind of an outbreak at that time, and this Candida auris, by and large, were resistant to not only to azoles but also resistant to amphotericin B. It was only sensitive to the echinocandins. And surprisingly, 37, the second most common that we grew at that time was Candida albicans, much like we are following the Western pathway now. And the third most common is Candida tropicalis, unlike what was shown in the Arulog's paper. Sensitivity. So just look at Candida auris here. Candida auris, fluconazole sensitivity is 0% there. Absolutely zero. And what is the sensitivity to echinocandins? Almost 100%. And then we have others, by and large, amphotericin does well, except for Candida auris, where the sensitivity is a bit less. But all the other candidas, by and large, are sensitive to an extent to fluconazole. Of course, Candida krusei and Candida glabrata are something which are intrinsically resistant to fluconazole, and that's why it is you are better off if you are growing a lot of Candida glabrata and Candida cruis, which is rare in Indian setup, you'll be better off to start with either an echinocandin or amphotericin B. When it comes to filamentous fungi, again, as I've showed you in the previous slide, Aspergillus of fumigatus and flavus, they are the most common. Aspergillus niger is much less. TDS is almost negligible. But rhizopus, various forms of rhizopus, they are quite common. And we do grow Cladiophora bantiana in our ICU also. Antifungal consumption. When it comes to all antifungal consumption in this period, you can see that antifungal consumption has gone up dramatically. And that is not surprising that we are getting so much of azole resistance in our ICU. And see how much is fluconazole. Fluconazole is down below. But the fluconazole consumption is also going up. But there down below is all the other antifungals, especially the echinocandins, which are also creeping up, but not as much as the fluconazole use. Antifungal use, which is a recent one, January to December 2020, as when it comes to defined daily doses per 1,000 population, fluconazole was the highest, followed by voriconazole. Liposomal amphotericin B and all the echinocandins put together are generally in the region of 1, but voriconazole is 2.2 and fluconazole is 6.7. So still we can say that we are giving a lot of fluconazole prophylaxis to our patients. So we are setting the stage for possible azole resistance in the coming future, very near future. And it is very common practice nowadays that if the patient has had a previous azole exposure, then we tend to go on to echinocandins in the intensive care unit. So finally, the key messages that I have for you is though antimicrobial stewardship includes optimization of antifungal use, antifungal stewardship is usually neglected. The high cost and toxicity of antifungals and several challenging issues in the management of fungal disease justify separate stress in antifungal stewardship program. And I'm glad that this forum has given me the opportunity to sensitize the speakers and the listeners to the antifungal stewardship issue. There is emergence of antifungal resistance, which is under-recognized. It's a matter of concern as development of new antifungal is very slow and the scope of finding new site of activity is limited. Local epidemiology with continuous surveillance is important to develop management guidelines and choice of antifungal agents. And obviously, you have to develop institution-specific guidelines depending upon your local epidemiology. Experts together should develop the guideline and it should be available at point of care for all clinicians. Nowadays, everybody has a smartphone, so it should be downloadable onto the smartphone. Withdrawal or de-escalation of antifungals, especially during the therapy, should receive special attention. It is one thing to start it, and it's a different mentality you need to have to stop it. And that's why we have to grow up, get into that kind of mentality that your responsibility doesn't end only by starting it. Your responsibility only stops when you actually stop it. Biomarkers like galactomannan, beta-glucan, PCR, CT imaging should be available in all tertiary care centers. There are a lot of studies which have shown that a biomarker and corresponding finding in a patient whom you are suspecting a fungal infection, you can almost preemptively start antifungal therapy before a microbiological diagnosis is made. Therapeutic drug monitoring, I have to make a big case about it. India is a long way away from therapeutic drug monitoring, and we need to really have this TDM in most of the bigger centers where at least the other hospitals can take help from them and use them as and when they need. Regular auditing of the total amount of antifungal use, which tells us that we are possibly driving resistance in our patient, the cost involved, the toxicity of the drugs. This is something that we need to audit and maybe take corrective measures depending upon the findings of the audit. So I really thank you very much for having listened to me patiently. This is not a topic that is your daily bread and butter. This is something which is different from the usual cup of tea. And I'm glad that we have been able to bring up this topic and bring it to the attention of the people who matter in the management of our patients in the intensive care unit. I thank you again very much.
Abhijit, you are around?
There was some technical problem.
Okay.
Thank you, Prakash Asti, sir. There was a question, but I think he has answered in the summary also about use of the markers for starting antifungal therapy. As we have seen, the utility of available antifungals is limited, and their toxicity and drug interactions, and because of emergence resistance, we need some newer antifungals which can be utilized very cautiously and correctly for better outcomes. I invite Dr. Subhash Todi sir for delivering a talk. Todi sir is a medical advisor and director critical care medicine at Ambry Hospitals, and he is a medical advisor for Ambry Group of Hospitals also. He is the head of the department and Department of Academics and Research, and his area expertise is critical care. Over to you, sir.
Hello, friends. Welcome to this online session on newer antifungal agents organized by Sepsis Forum India on Sepsiscon 2022 on the World Sepsis Day. I am Dr. S.K. Todi from Calcutta. You know, fungal sepsis is a very important cause of morbidity and mortality in intensive care unit, and it is usually missed and the treatment started late. Now, the present armamentarium that we have of antifungal agents are azoles. They target the ergosterol pathway in the endoplasmic reticulum and ultimately which disrupts the cell membrane. And because they are working through the reticulum, which has got a lot of metabolizing enzymes like CYP354, there is a lot of drug interaction with azoles. Polyenes like amphotericin binds to ergosterol and directly disrupts the cell membrane. Flucytosine inhibits the nucleic acid synthesis. Fungi are eukaryotic organisms and they have a lot of similarity with the human cells. So the cell membrane, the endoplasmic reticulum and nucleus, they have a similarity in the human cells. So all the molecules which work through these sites usually have toxicities on the host cells or drug interactions where the drugs also use the same site of mechanism. The second is the cell wall, echinocandins. Echinocandins are the ones which directly disrupts the cell wall by inhibiting the 1,3-beta-D glucan synthase. Now, cell wall is usually not present in the human cells, and that's why echinocandins are very safe antifungals because they do not share the same site of action which are present in the human cells. So this is, in summary, the present armamentarium we have. So why there is a need of new antifungals? First of all, the mortality from invasive fungal infection still remains very high, around 30-40%. Most of the drugs like azoles and flucytosine, they don't have very rapid fungicidal activity. Echinocandins do have, but most of the others don't. And as you are aware, the current therapy needs a very prolonged course, almost for a 2 weeks course of antifungals, where most of the antibiotics are usually given for 5-7 days. In fact, their courses are getting shorter. So can we have a drug which can be given for a shorter course? Just like bacteria, even the fungal resistance is gradually growing. We have a lot of this new species of Candida like Candida auris, which is very resistant to many drugs with higher MIC. Another reason for new antifungals is, as you know, the fungal world is yeasts and molds. And especially in immunosuppressed individual, when we suspect a fungal sepsis, we are not sure are we dealing with yeast or mold. Even in mold, we are not very sure are we dealing with aspergillus or mucor. So just like antibiotic to cover many gram-negative organisms, both fermenter and not fermenters, even antifungals, we require newer antifungals which can cover yeast and molds, and in molds probably to cover both aspergillus and mucor. And as I mentioned, many of the antifungals, they have the same site of action as is present in the human cells. So there are very toxic, especially like amphotericin and nephrotoxicity. Azoles have a lot of drug-drug interactions. And we do not have much of an oral formulation of echinocandins, which are the workhorse. So it becomes almost 2-3 weeks of intravenous therapy in the hospital. So we definitely require oral de-escalation therapy. So these are the basic reasons for which we require a new antifungal. So a lot of research is nowadays being done on this new antifungals, and a lot of new sites have been discovered within the cells of fungi where the different molecules would work. if we look at the pyramid of research, the first generation are the ones which were already present, like amphotericin, flucytosine, azoles, and echinocandins. The second generation have already been used for the last 8-10 years is the lipid formulation with reduced toxicity of polyenes like amphotericin. There are structural changes in azoles like voriconazole have come with increased activity against molds. There are other azoles with PKPD changes, which we will discuss. And the completely new formulations like polyenes having nanoparticles, oral formulation. Can we have azoles which have got a longer half-life, or echinocandins which can be given orally? So these are the future generation where we need to, a lot of work is going on in this direction. And that is what we are going to discuss in the coming 15-20 minutes. Now, there are a lot of drugs in the pipeline for antifungal agent. I will concentrate only on these 3 drugs which are in the phase 3 development and will be given application very soon for commercial use. And I will also highlight one of the newer azoles which are already being used over the last 3-4 years. Plus, I am going to discuss about these 3 molecules. So the first molecule is isovuconazole. So just to discuss about the pharmacology and PKPD of isovuconazole, it was approved by FDA in 2015. It is available as a prodrug, isovuconazonium, which is converted by plasma esterase. And it is available both as an IV and oral. The most important thing, it doesn't have cyclodextrin in IV formulation, which voriconazole has. So the problem of accumulation of cyclodextrin in patient with renal impairment and thereby having side effects is not there. So it is very safe to give even in renal failure. Even the oral capsules, many patients in intensive care unit have a nasogastric tube and they have to be fed through that, and the drugs have to be given through that with less bioavailability. It has been found that isovuconazole capsules may be open and the product given through the feeding tube, and they have a very good absorption. Though there is some drug-drug interaction, because being an azole, they work through the ergosterol pathway in the endoplasmic reticulum. So there is some drug-drug interaction. As I mentioned, they are rapidly absorbed and there is no pH effect like other azoles. So, this newer formulation have a more friendly pharmacokinetics. They have a very large volume of distribution because they are lipid soluble. So in critically ill patient having a lot of intravenous volume resuscitation and all doesn't affect the plasma concentration of these azoles. They are very highly protein bound, and as I mentioned, they do interact with the cytochrome enzyme system. Most of them are metabolized and not excreted by the kidney, and they have usually metabolized in the liver. They have a very long half-life, and they can be given as a loading dose followed by a maintenance dose. And one can switch between IV and oral administration. And very importantly, routine therapeutic drug monitoring is not required as opposed to the voriconazole. These are the certain pharmacokinetic data regarding the standard dose, the route, the Cmax, and the AUC. This is the PKPD parameter, which is mostly required for azoles. And it can be given in mild to moderate liver disease. In very severe liver disease, one may need to reduce the dose. It doesn't need to be adjusted for renal impairment and in patient on dialysis, including CRRT. Now the spectrum of isovuconazole. That is where it scores over the other azoles. It is active against Aspergillus, mucorales. It is active against Candida. Unfortunately, the clinical trials against Candida has not been very good. It is active against Cryptococcus. It is active against almost all the species of Aspergillus, Rhizopus. It is active against Fusarium, Cryptococcus, both neoformans and Gattii. So it has got a very broad spectrum, and these are the clinical outcome studies which have been done on these. So the therapeutic indications of isovuconazole is invasive aspergillosis and in mucormycosis in whom amphotericin B is inappropriate. The only contraindications are the usual ones where there is an allergy to this drug. If patient is having strong CYP inhibitors like ketoconazole or inducers like rifampicin, anti-epileptics or anti-HIV drugs. And this is a very peculiar of this azole which shortens the QT syndrome, shortens the QT interval. So should be avoided in patient with short QT syndrome, which is very rare. Now, the guidelines have definitely recommended isovuconazole is as effective as voriconazole and better tolerated in invasive aspergillosis. Both the ECMID guideline also have endorsed the isovuconazole as an anti-aspergillus therapy. So both ECIL and ECMID are A1 recommendation to treat invasive aspergillosis. Now coming to mucormycosis, the guidelines have recommended, as you can see, this green one is for strongly recommended. So in by and large, once the cornerstone is obviously the surgical debridement. And after that, the pharmacotherapy is very high dose of amphotericin, and they want to avoid slow escalation of doses. So almost 5 to 10 milligram per kg per day. So many people cannot tolerate such a high dose of liposomal, but that is the first indication. If patient has renal compromise, then isovuconazole is very strongly indicated, or posaconazole. There is a moderate recommendation of iso and posa as a second line after liposomal amphotericin. Now, once a patient has been given the initial therapy, the response has to be assessed weekly. And if patient have a stable disease or partial response, isovuconazole orally is then recommended. If there is a progressive disease, isovuconazole IV is recommended. And if there is a toxicity of liposomal, then again isovuconazole IV is recommended. So you see, it looks like that isovuconazole is gradually taking over lipid preparation of amphotericin, mainly in the maintenance phase and also in the initiation phase for most of the patients, especially in our country. Now, phase 3 studies have been done on isovuconazole, mainly for invasive aspergillosis and some for mucormycosis. I will just run through these 3 studies, mainly the SECURE and the VITAL studies. The SECURE is for invasive aspergillosis. It is a phase 3 randomized double-blind trial evaluating isovuconazole versus voriconazole, 527 patients, to look at non-inferiority. And they did find that there is non-inferiority of isovuconazole to voriconazole in this study, with the mortality remains similar. So all-cause mortality from first dose of study drug to day 42 was non-inferior between these two, and the trend persisted till day 84. Then came the mucormycosis study, the vital study, a smaller study, and some patients were taken from Fungiscope registry for this patient. This was an open label trial in adults patient with renal impairment and having a mucormycosis, and they were given isovuconazole and see to look at the outcome and compared to matched controls as taken from Fungiscope registry who were treated with amphotericin. Again, they didn't find much difference. In fact, isovuconazole has a better outcome. All-cause mortality was less than the historical matched control from Fungiscope of amphotericin. So again, in mucormycosis, though a small study, and in a historical control, it was found to be better than amphotericin. So isovuconazole did demonstrate survival probability in patient with mucormycosis with a good safety profile. Very few adverse reactions apart from some GI involvement, some rashes. So by and large, a very safe drug to give both by intravenous and by oral route. The QTC interval, as I mentioned, it has got a very peculiar dose-related shortening of QTC interval, but usually it doesn't cause too much of a problem. In our experience, we haven't found this to be of much clinical relevance. But one should measure QTC, especially if in a prolonged course of isovuconazole. So isovuconazole has demonstrated efficacy against both invasive aspergillosis and mucormycosis with favorable safety profile, favorable pharmacokinetic profile. So looks like isovuconazole as a newer azole against aspergillus definitely, and possibly for mucormycosis. Unfortunately, the trial against candidemia for isovuconazole has not been successful. So it is only to be used for invasive mold infections. So that's on isovuconazole. I would put it as a newer antifungal because it has come to the market very recently in our country, and many physicians are not aware of this. Now, coming to some other molecules which are not yet commercially available, but have almost completed phase 3 studies and should be very be available for commercial use very soon. Now, rezafungin. Rezafungin is a new echinocandin, and just like any other echinocandin, it inhibits 1,3-beta glucan synthesis of the cell wall. And as we mentioned, the cell wall is not shared by human cells, and so the toxicity is much less. So one advantage of this new echinocandin is the broad spectrum, though the other echinocandins also have some anti-pneumocystis effect, but this new echinocandin is very potent against candida, including candida auris, because as has been shown that candida auris have increasing MICs, and there are mutations in the FKS mutation in many of the candida, especially candida glabrata and also candida auris, which makes them resistant or at least increased MIC requiring higher doses of candins. And that's why this rezafungin will be a welcome option against this resistant candida. It also works against aspergillus and pneumocystis. The other advantage is it's not hepatotoxic, and it is active against resistant strains, and it has got a very long half-life. One can use it once a week dose. That increases compliance, may decrease the hospital length of stay, and it has got a good penetration into intra-abdominal cavity. As you know, many of the azoles and echinocandins, they do not penetrate intra-abdominal cavity. and the risk of resistance would be low because high levels are maintained for a pretty long time, and both subcut and IV formulations are available. The second new antifungal in the echinocandin groups is the Ibrexafungerp. It is a glucan synthase inhibitor, just like any other echinocandin. And the peculiarity of this echinocandin is it is available in oral form. And as we mentioned, in order to de-escalate from IV echinocandin, this will be a very welcome molecule. It has got a very robust drug penetration for intra-abdominal candidiasis because many of the drugs, the azoles do penetrate, but they are fungistatic. So having a fungicidal drug which can penetrate intra-abdominal cavity and secretions is very important. It has been found that in the necrotic center of liver abscesses, deep-seated candidiasis is becoming a big problem. And we require drugs which can penetrate into these tissues. And this new echinocandins does penetrate into the liver much better. It has got in vitro and in vivo studies have demonstrated against most Candida species as well as resistant isolates for Candida auris and high MIC Candida. And just like the rezafungin, it also works against Aspergillus. It doesn't work against Mucor or Fusarium. And as I mentioned, Candida glabrata and auris have this FKS mutation, and these newer echinocandins would work against this mutant. So doing a sensitivity to echinocandins against glabrata and auris becomes very important. And since this is an oral drug, it may be a very viable option in many patients, including for pneumocystis in immunocompromised patient. So there is a phase 3 trial which have just been completed as a step-down therapy after 3 to 10 days of echinocandin compared with fluconazole, which is the usual practice. And the latest molecule, which is an azole, oteseconazole, which is again a very broad spectrum azole against Candida, coccidioides, rhizopus. So it is also in the phase 3 trial. Unlike the other azoles, which have got a very large drug-drug interaction, this azole do not have so much of drug-drug interaction. So in that way, it is more pharmacokinetically safe. So I've described in this 20-25 minutes the newer antifungal, emphasizing predominantly on isovuconazole, which is there in the market and which is useful against invasive aspergillosis and also against invasive mucor, but it should not be used against candidemias. Rezafungin is the newer IV echinocandin with a very long half-life and a much broader spectrum. Ibrex is a new oral echinocandin, again a very broader spectrum and useful against resistant Candida. And oteseconazole is a new azole, which has got less drug-drug interaction. Thank you very much for your listening.
Thank you, sir. Thanks for elaborating the many important drugs and the newer ones also. As we all know that knowing about the stewardship and the newer drugs, but time to diagnosis is one of the most important factors in about affecting the mortality in many of the fungal infections. So the role of rapid diagnosis and use of molecular tests becomes more important. So I request Dr. Vikram to take us through the rapid molecular test for fungal infections. Dr. Vikram is senior consultant and microbiology and infection control at Jahangir Hospital, and his area of expertise has been clinical microbiology, antimicrobial stewardship, and infection control. Over to Dr. Vikram.
I'm Dr. Vikram, and I will be talking about the rapid molecular diagnosis of fungal infections. Now, fungal infections are a cause of significant morbidity and mortality. especially in immunocompromised patients, either cancer patients who are on chemotherapy or hematopoietic stem cell transplant recipients, and other reasons also. The commonest fungi that we tend to encounter are Candida, invasive aspergillosis, mucormycosis, and pneumocystis. The other issue in fungal infections is that of the emerging resistance to the azoles, especially in Candida glabrata and Candida auris nowadays. And Aspergillus fumigatus also is known to be resistant to the azoles. An early diagnosis and treatment has been associated with better outcomes. And it remains to be seen whether the molecular tests can give us an early diagnosis and thereby an early treatment. Now, if you look at the flow of how samples are processed, initially the sample is collected. We do a direct smear, which takes about 4 or 5 hours. And then we put in the sample for culture on SDA medium. Now, this culture will take anywhere from about 2 to 3 days for the yeasts, sometimes maybe up to 5 days, and 4 to 5 days for the molds. And if it's a slow growing mold, it may even go up to 3 or 4 weeks. Now, once we have growth, we need to do certain phenotypic tests or put it onto an ID AST system for Candida, which will give us the identification and sensitivity in a day's time for the yeast, or maybe a week or 2 for the molds. So to get a diagnosis or an identification of a fungus, it may take anywhere between 1 week to about 4 or 5 weeks. But this time is very critical for patients who have got invasive fungal infections. The other issues with the current methods are that the smear or direct microscopy has a low sensitivity and is dependent on the observer and the type of stain also which is done. Though cultures are still the gold standard, they're extremely time consuming, and of course you need viable fungus in that tissue or that sample which has been collected. So can molecular tests fill the gap? Molecular tests are supposed to be faster, more sensitive. They can pick up non-viable fungi and they can pick up multiple fungi. But all these are pretty theoretical at the moment. So let's look at what these molecular tests are. First is, of course, the polymerase chain reaction, or the PCR for fungi, which can be of 2 types. One is called as a pan-fungal, which looks at detecting all the fungi that are known to us. And the other is, of course, looking for individual fungi like Candida or Aspergillus or Mucor and so on. The other approach is what is called as the syndromic approach, where you try to look at a particular sample for a host of pathogens which can cause an infection in that particular system. The commonest system that we know is the biofire. Another thing, new kid on the block, which is being used nowadays extensively, is the MALDI-TOF, which has definitely hastened our identification of various isolates. The other exciting initiative is the sequencing that is currently being done. And we look at how this is revolutionizing the diagnosis of fungal infections. And lastly, of course, we have 2 seromarkers, that's biomarkers, the beta-D-glucan and the galactoman. So coming back to our flowchart, once you collected the sample, you do a direct smear, you do the culture, and you get the identification sensitivity. We have seen that this takes about anywhere from few hours for the direct smear to about 2 to 4 weeks for the identification AST. Now here is where the molecular tests can help us. A direct PCR on the sample collected could probably give you the result in 4 or 5 hours with a much better sensitivity than the direct smear. A biofire might tell you about multiple organisms that are involved in, of course, a very niche group of infections. Once you have the culture, you can do a MALDI-TOF or a sequencing and get your identification and sensitivity much faster than it would otherwise come with the phenotypic tests. Now, coming to PCR for fungi, you have 2 types of PCR. One is, of course, the conventional PCR, which usually is done and you follow it up with a sequencing. Or there is another real-time quantitative PCR, which is nowadays giving you the cycle threshold values. And this seems to be more exciting. The pan-fungal PCR or the Candida or the individual PCRs for Candida, Aspergillus, and Pneumocystis and Mucorales is what we will shortly be looking at. So coming to the pan-fungal PCR, this detects all the fungal DNA that is present in the sample. The targets are usually those targets which are conserved in all the fungi. So this is typically from an rRNA clusters called as the internal transcribed spacers, or the ITS1, the ITS2, or the D1, D2 segment of the 28S rRNA gene. Nowadays, a lot of these pan-fungal PCRs also use the 18S rRNA. This amplification is usually followed by a DNA sequencing, which will then give you an exact identification of which fungus it is you are dealing with. Nowadays, a high-resolution MELT curve analysis is also being done, which can give you the same date information a little earlier. The samples that can be used for this pan-fungal PCR are fresh tissue, which has a better sensitivity than a formalin-fixed paraffin-embedded tissue, or sterile fluids like CSF, vitreous fluid, or blood. BAL also is a good sample. However, the pan-fungal PCR has better sensitivity on the sterile fluids. Another point to remark here is that this has good utility in tissues where hyphae are seen. Sometimes this pan-fungal PCR can detect an unusual fungus which is totally unexpected, like Fusarium or Scedosporium. So this is one advantage of the pan-fungal PCR. However, the interpretation from non-sterile samples like your bronchoalveolar lavage does become difficult sometimes because you're not sure whether this is a colonization or this is an invasion of the tissue. The sensitivity in BAL also becomes lower if the patient has taken any antifungal treatment. Again, like mentioned, this is more useful if yeast or hyphae are seen on the direct smear. Coming to the individual PCRs, the PCR for Aspergillus is one of the most exciting ones that have come about. Unfortunately, there is a lot of variability on which targets to use, the protocols to follow, and which sample is the most optimal. This can currently be done on whole blood, serum, plasma, or bronchoalveolar lavage, with plasma being the most effective or the most useful. Now, this test has a high positive predictive value if 2 positive results are considered, and this also has a good negative predictive value to rule out invasive aspergillosis. Again, this is not for patients who are taking antifungal therapy because the sensitivity goes down tremendously. Again, you can't differentiate between colonization or infection for BAL because Aspergillus is known to be a contaminant in respiratory samples. The result or the efficacy of this test is dependent on how much sample is processed. Usually more than 0.5 ml gives you a good yield, and the amount of elute that you get out, usually less than 100 microliter, is very critical to ensure a good PCR for Aspergillus. A review of various commercial assays that were available showed lesser sensitivity for serum than for respiratory samples. So PCR for Aspergillus in a bronchoalveolar lavage, taking into consideration all the colonization and the antifungal treatment issues, should be a good test to use. Coming to invasive candidiasis, usually this tends to be candidemia or a deep-seated candidiasis. For candidemia, the investigation of choice is the blood culture, which detects about 1 CFU per ml, but the overall sensitivity is only 50% and can have a lag time of up to 5 days. This is simply because once the blood culture flags positive, which usually happens in about 24 hours, unless it's a Candida glabrata, which might then go on to about 2 days, you then need another 1 or 2 days to do to plate it out and then do the identification and sensitivity. The PCR has a very good sensitivity of less than 5 CFU per ml and has reasonably fast results. And plus, these are good for those that are missed out by the blood culture. The issues with Candida PCRs are the lack of standardization, a variable analytical sensitivity among different kits, and the need for a nucleic acid extraction step. The targets that are used for Candida PCRs are the rDNA and the cytochrome P450L1A1 gene. The PCR performance has been good for blood, but less for others. However, one point to note is that for deep-seated candidiasis, PCR and beta-D-glucan on blood are much more sensitive than a blood culture. So to get the best yield out of this is to combine a blood culture with a PCR or a beta-D-glucan, which will give you the best sensitivity. Now, most of the commercial assays that are available, of course, not available as yet in India, but most of them target the 5 common candidas, that is Candida albicans, Candida glabrata, Candida krusei, Candida parapsilosis, and Candida tropicalis. So if there is any other Candida, it's a good chance that you're going to get a negative Candida PCR. Another panel called as the T2 Candida panel, which is a US FDA approved system for PCR for Candida, comes with the T2DX instrument, and this is for direct detection of Candida in whole blood. This mixes a nuclear magnetic resonance with PCR technology, which gives you a result in less than 3 hours and has a sensitivity of 1 to 3 CFU per ml. This again detects the 5 species that we had spoken about earlier. The advantage of this system is that it also has a Candida auris panel with a limit of detection of less than 5 CFU per ml, takes about 5 hours and can be done either on whole blood or on skin. So from an infection control perspective, for patients in the ICU, this could be a very important test. Unfortunately, as of now, the T2 Candida panel is still not available in India. Coming to mucormycosis, this is an invasive disease which is increasing day by day, especially in diabetics and of course post-COVID. I think the last 2 years, we've seen as many mucor as we've probably not seen in the last 10-15 years. The diagnosis of mucor is usually by KOH, where you see these broad aseptate hyphae in the sample. And when you grow it, of course, some of them do not grow. And if growth occurs, usually it grows in about a week or 5 days. And you get this kind of a growth, which is called as a lid lifter. An LPCP mount shows you the typical morphology of a mucor. There are no serological tests to diagnose mucor, which creates a big window for molecular tests to come in. Now, direct detection of mucorales DNA in fresh and formalin-fixed paraffin-embedded tissue is something which has been tried out. Again, we look for the ITS segments or the 18S or the 28S rDNA. Here, DNA extraction is the key because many times the quantity of fungus tends to be less in the sample that has been processed. Another test that is being done is a real-time quantitative PCR on serum. Now, this in initial trials has shown that it can detect DNA 8 days earlier than culture positive or a positive histopath, and 3 days before any CT signs like a halo sign or anything comes up. However, this decreases if any antifungal treatment has been given. Now, once you get a positive on the real-time qPCR, you need to do a sequencing if you want to find out which fungus of the mucorales this is. And silver stain or an immunofluorescence or on histopath. However, the PCR has shown to be more sensitive than staining. Unfortunately, we cannot differentiate between colonization or whether it's an asymptomatic infection or a subclinical infection or an active infection. A quantitative PCR in this case may be useful based on CT values if this can be validated. It has been shown to be better on a bronchoalveolar lavage or better than that on an induced sputum, which is further better than that on an oropharyngeal washing. This is also being tried out for a nasal aspirate or a nasal swab. Now coming to syndromic testing. Syndromic testing is a symptom-driven broad grouping of probable pathogens all put into one test. So instead of performing multiple PCRs for different organisms, one PCR followed by a multiplex PCR followed by an array system ensures that you integrate the sample preparation, the amplification, the detection, and analysis. So this is what is the BioFire system by bioMérieux, where they have this system which does everything in this one container like thing. There is a pouch or a BioFire pouch in which you have to inject the water to hydrate all the reagents and then the sample at this red end. And then in this pouch, you have all the processes of PCR which go on. The first being cell lysis, followed by a DNA and RNA purification, and the first round of PCR, after which the second round of PCR gives you all the specific organisms which are targeted. So this is the example of a BCID panel, that's the blood culture identification panel, which has these 43 targets, which encompasses gram-negative bacilli, gram-positive bacteria, yeasts, and antimicrobial resistance genes. So as you can see for the yeasts, the main ones are Candida albicans, auris, glabrata, krusei, parapsilosis, tropicalis, and cryptococcus, which of course does not differentiate between Cryptococcus neoformans and Cryptococcus cattleya. So this is a very simple system to use where you just load the sample, put it into the machine, and after about an hour or two, you get a straightforward printout which gives you the result of each of these 43 components. Now for fungi, the BioFire has two panels which can be used. One is the BCID panel, which can be used on a positive blood culture, and the other is the meningitis and encephalitis panel, which can be used, which can be used for a CSF, and which gives you identification of the Cryptococcus species, but it won't differentiate between whether it's Gattai or it is Neoformans. Now coming to MALDI-TOF, this is the matrix-assisted laser desorption ionization time of flight mass spectrometry. Though this comes under proteomics, this can probably be considered under a molecular test. Though this has a very intense or very expensive initial investment in the machine, this has a very low running cost, easy to use, fast, and has got very good or accurate results. So this is how the whole system looks like. It's one tower-like system. And this is used on culture isolates where you pick up the colony and dry it on this plate in one of these wells. You overlay it with a matrix to ionize the proteins, and you place this plate inside this machine. Then what happens is that a laser is projected onto that sample, which then causes ionization of all the ingredients of that. And this ionized molecules are further detected by the detector, and you get a graph like this. Now, this spectrum is like a signature for each organism. So each organism has a different kind of a spectrum. Now, once you get this spectrum is compared with all the other known spectra in the database, and you get your identification depending on which organism this spectrum matches with. So as you may have realized, everything depends on this database. If you have a strong database which includes most of the organisms, you will get a good identification. If you have a narrow database, then there's a good likelihood that you're not going to get a good identification. So currently, MALDI is used for both yeasts and for molds. The sample preparation is slightly different. When you extract the protein, this can be done on the plate for yeasts, but for molds, there is a small processing step that is required of the plate. Now, as mentioned earlier, you need a good database for the identification. Now, PGI Chandigarh is doing a very good work on this database, having identified a lot of Indian isolates, and they probably have the largest database in India. Coming to sequencing. Now, this is the new kid on the block and shows most promise. There are two types of sequencing. One is the Sanger sequencing, which is done, and the other is the next generation sequencing. Most of these are usually used for Pneumocystis jirovecii, Aspergillus, Candida, some for Cryptococcus, Rhizopus, Fusarium, Talanomyces, and so on. This is more sensitive than culture. Unfortunately, sometimes can be oversensitive. Another thing which is being used is something called as a DNA barcoding, which is extremely interesting, where you have an unknown organism, you extract the DNA, you look at the barcode fragment, which is nothing but one part of the DNA, which is known to be conserved only among those species and which is specific for that particular organism. So this acts more or less like the fingerprint or a barcode for that particular organism. You do a DNA sequencing, you compare it with the barcode database, you match it, and you identify. The common regions used are the ITS1 and 2 region. And of course, the problem right now, this is still in initial stages, is a lack of a database. However, sequencing of most of the organisms being done will help in the future in this DNA barcode. Coming to antifungal susceptibility, MIC and breakpoints which have been established by the CLSI or the UCAST are usually used for Candida and for Aspergillus. There are automated systems available for Candida antifungal susceptibility, but for Aspergillus and the other molds, you need to do a microbrod dilution, which is extremely slow, cumbersome, and they're very often affected by the growth rate of the molds, which in some cases can be very poor. So molecular methods may offer faster results if the resistance determinants or the genes which encounter resistance are known. So you have azole resistance in Candida, which can be detected by looking for these ERG11 and the ERG3 genes for Candida albicans. We can look for azole resistance in Aspergillus fumigatus, which looks at the TR34 and L98H in the cytochrome P51A gene. And we look for the echinocandin resistance in Candida through the FKS genes. Now, as more sequencing is done and we get to know of more resistance determinants, these methods will probably come in vogue in a few years' time. The other two markers, which I won't be dealing with in detail, are of course the beta-D glucan and the galactomannan, which are useful in their own right, but they may need to be measured in serial measurements, or they have to be interpreted with a lot of clinical correlation. So the issues with all these new technologies, one of course is the availability in India. The second is that all these techniques being new are expensive, and cost to outcome ratio is something that we really need to look at. How expensive will a test be, and is the outcome going to be as good or worth the cost that is being put in? Validation in real life scenario is something that is an absolute necessity. Plus, there has to be reproducibility across labs. So commercial availability of commercial assays would make things much, much simpler and life much easier. The other issue that remains is that fungi are all around us, and environmental contamination because of fungi can be a major issue, leading to a lot of false positives. The last point, of course, is the interpretation of the results. How do you interpret a positive result? Is it a colonization? Is it invasion? And where exactly do you position this test? At what point are you going to take this test seriously, and what point are you going to say that, no, this probably reflects contamination? So a lot of issues with all these new technologies, but hopefully with time, all these should be sorted out. So coming to the future scenario, we cannot fully replace all the phenotypic methods as yet. Currently, the most promising seems to be a pan-fungal PCR followed by sequencing instead of individual PCRs. Nowadays, with a lot of molecular labs coming up, this is something that is being done in a lot of labs, and probably at a cost of maybe 10,000 plus or minus, you would be getting valuable information. The only issue is that this still takes time of about a week or so. However, remember that clinical correlation can never be replaced. This will be required to know whether this is over-detection, colonization, or what is the relevance of a positive report. And of course, currently the high cost, which hopefully with time and more tests coming in should go down. So to conclude, this is an exciting time for molecular diagnostics, especially for fungal infections. But unfortunately, most kits are either for research use, or they are undergoing validation, or they are not available in India. But hopefully with time, these problems should be sorted out. The current available ones are the BioFire, the MultiTOF, and the sequencing. So that's it from me. Thank you for your patient listening.
Thank you, Dr. Vikram. Thanks for taking us through the newer rapid molecular test. Moving ahead, despite decades of research and work in the sepsis, we are still yet to have any specific treatment. We have a question whether we have still specific therapy for sepsis. I need to ask this question: who better than Dr. Professor J.V. Diwatia to take us through specific treatment for the sepsis? I invite Dr. Diwatia sir, who is the director at Homi Bhabha Cancer Hospital, Bulanpur and Sangrur, Punjab, and he is a professor and head Department of Anesthesiology, Critical Care and Pain at Tata Memorial Hospital, Mumbai. His area of expertise is hemodynamics, end-of-life care, and ventilation. Over to you, sir.
Thank you for asking me to speak in Sepsiscon 2022. And I will be speaking on a very intriguing topic on why we still do not have a specific therapy for sepsis. Now, many years back in the 90s, early 90s, we defined sepsis as a systemic inflammatory response syndrome, and a systemic inflammatory response syndrome, or SIRS, in response to infection, whether it was bacterial, viral, fungal, or some parasitic or other infection, was called sepsis. We did recognize that SIRS could be caused by many non-infectious conditions, but if it was caused by an infection, then we called it sepsis, right? And the pathophysiology, as we sort of understood it, was relatively simplistic. You had a bug or a microbe which initiated an infection, and this microbial infection would activate mononuclear cells, And these activated mononuclear cells would liberate large amounts of cytokines like tumor necrosis factor, interleukin 1, other cytokines, phospholipases, and other substances like oxygen free radicals, nitric oxide. And all this would be in an effect in an attempt to counter the infection and to allow the inflammation to kill the bugs and to start the healing of the body, right? So this was the inflammatory response, which was however, it was also theorized that along with the systemic inflammatory response syndrome or SIRS, there was also a counter inflammatory response or the counter anti-inflammatory response syndrome. And in health, the SIRS and the CARS was a counter anti-inflammatory response syndrome, would sort of balance each other out. And you had some inflammatory cytokines and you had anti-inflammatory agents like interleukin 1 receptor antagonists or interleukin 10, which were counter-inflammatory or anti-inflammatory. The inflammatory response overshot itself and overcame the counter anti-inflammatory mechanisms and became unbridled inflammation. In that case, the phenotype would shift towards inflammation and massive inflammation, and that would give rise to sepsis and in some cases even septic shock. Now, this response of the body is a very conserved response. It doesn't need a highly synthesized or a highly developed immune system, because this can happen even at a level before the traditional T cells and B cells of the immune mechanisms as we sort of know them. And this is by innate immunity, right? And essentially what happens for the innate immunity, there's a set of receptors called the toll-like receptors, which are present on some of the blood cells. And they recognize patterns. They recognize patterns from gram-negative bacteria, from gram-positive bacteria, and they bind to different types of toll-like receptors, which then activate the inflammatory response. Now, essentially what happens is, like I said, these are very basic mechanisms of defending the organism. And this is what we call as innate immunity. It does not depend on a highly evolved immune system. And essentially what these immune system, this innate immunity recognizes are pathogen-associated molecular patterns. These are not, they don't identify a particular bacteria. They don't have an antibody response to that particular bacteria, which is not recognized as an antigen. It is just recognized as something which does not belong to the body. So that's a pathogen-associated molecular pathogens. And that triggers an immune response, an inflammatory response. These inflammatory response, it sort of damages these pathogens. There is bacterial damage. There may be some damage to the host cells as well, some damage to the host. And this causes release of what we call as damage-associated molecular patterns, right? And these damage-associated molecular patterns are also recognized as not belonging to the host. And these damage-associated molecular patterns and the pathogen-associated molecular patterns both trigger an inflammatory response in the host. And this inflammation, again, if it becomes excessive, can cause damage, and then it can lead to organ failure. So essentially, sepsis has traditionally been recognized as a condition in which there is excessive inflammation, there is massive inflammation in the body, the activation of leukocytes, endothelial and epithelial cells, release of inflammatory mediators, for example, the ones which are most sort of talked about are tumor necrosis factor alpha, interleukin 1, interleukin 6, and some counter-inflammatory mediators like interleukin 10. And all these cause cellular and tissue damage and induce hemodynamic instability and multi-organ failure. And this outpouring of cytokines in response to an infection has been described as a cytokine storm. So the management of sepsis has traditionally revolved around restoring organ perfusion when there is hypoperfusion and hypotension and shock, of course, to controlling the source, that is, controlling the infection, usually with antimicrobials, but also at modulating this inflammatory host response. So modulating the host response is something which we probably need to do if we have to win the war against sepsis. And our understanding of the host response has been in the setting of massive inflammation, taming the cytokine storm. And the first drug that comes to mind when we think of massive inflammation is corticosteroids. Okay, So these have been tried. We've also looked at endotoxin, because endotoxin, which is released by gram-negative bacteria, is a trigger for the host response. So if we, and maybe we could neutralize the cytokines that have been released. So anti-cytokine therapies have been used. Immunoglobulins have been used in order both to boost immunity as well as to uh, have antibodies against a broad spectrum of antimicrobials and cytokines, and blood purification techniques where we try and remove the harmful cytokines from the body. All these have been sort of strategies which have been used to tame the cytokine storm and to control or modulate the host response. Now, when steroids were first used, and they were used way back in the 80s, because patients with septic shock had a very dramatic presentation with shock, hypotension, organ failure, it was assumed that the inflammation was massive, and therefore they were given massive doses of steroids, 30 milligrams per kilo of methylprednisolone, and so on, right? And there were a number of randomized controlled trials which were done. But at the end of the day, all these studies with big doses of steroids, what we call as a shock pack of steroid, they in fact did not take care of the problem. In fact, some of the studies found a worse, a higher mortality with steroids rather than a lower mortality. Okay, infections were tended to be higher in patients who got steroids, which is not very surprising. But many of the studies found absolutely no difference in the progression of shock or in progression to ARDS. And one study actually found a worsening of mortality. So clearly, high dose, short courses of steroids was not the way forward. And we have learned over the course of the years that if at all corticosteroids are to be used, they have to be given only in small doses, 200 milligrams per day of hydrocortisone in patients who are refractory to vasopressors and need ongoing vasopressor therapy. In all other forms of sepsis or septic shock, which have already responded to fluids and small doses of vasopressors, steroids are probably not very useful. So we've come a full circle from a big whack of steroids down to a small dose of steroids in a very small subgroup of patients with septic shock who are not responding to fluids and vasopressors. Right? What about endotoxin antibodies? So these were antibodies which were developed to endotoxin or to anti-lipopolysaccharide, right? And which was a component of the gram-negative bacterial cell wall. And again, a number of studies were done, randomized controlled trials, and none of them seemed to show any benefit. Next group of agents which was tried were antibodies directed against monoclonal antibodies directed against the cytokines, because the cytokines were thought to be the motor of endothelial dysfunction, hypotension, and shock, and organ failure. So maybe if you could neutralize some of the cytokines, then you might actually get a better outcome. And the cytokines that were targeted were largely anti-tumor necrosis factor alpha, interleukin-1 receptor antagonists were given, right? So they would sort of mop up the interleukin-1, which was circulating in all these patients. Now, overall, there seemed to be a small benefit with these agents, but the larger studies of anti-TNF and interleukin-1 receptor antagonists were actually negative. So in fact, the enthusiasm for these agents sort of died down. In fact, in one of the studies, there was a trend towards a higher mortality with anti-TNF agents. And that was understandable because, at some stage, you do need these cytokines, but at some stage they are harmful. And we do not yet have the tools or the biomarkers to decide when the inflammation is beneficial and when the inflammation is going haywire and harming the patient. So to determine that point where the shift goes, where the phenotype shifts from protective to harmful, we still don't have that yet. There was also a study of an toll-like receptor for an agent. Okay, and remember we said that these are the agents which are responsible, the toll-like receptors are responsible for the initiation of innate immunity. So and so even one step before the inflammatory cascade is set off by them. But even this agent, Eritoran, did not have any benefit in this phase 2 study. So again, trying to control or modulate the host response by either targeting the triggers of inflammation or the inflammatory cytokines does not seem to make a difference to survival. And from the 80s to the 2000s, there were a large number of studies on all sorts of agents, and none of them showed any benefit. So obviously there was something which we were missing out here, and something which looked theoretically very attractive did not make a difference or did not prove to be beneficial in randomized controlled trials. The focus then also was then on coagulation, because we did know that DIC was important event in many patients with multiple organ failure and septic shock, and it was postulated that microthrombi formed in the circulation, and these would sort of block the flow to the distal organs, so distal tissues, and that would give rise to organ failure. Now, the presence of thrombi meant that there was thrombin present, and this was a very interesting molecule. It, of course, is a procoagulant. It also stimulates anticoagulants, but more importantly, thrombin triggers inflammation. Okay, so inflammation or sepsis leads to thrombin formation and clotting in the microcirculation, and this thrombin further activates inflammation, which leads to more generation of thrombin. So there was a sort of nexus between coagulation and inflammation, and all this would sort of lead to one amplifying the other and leading further to worsening multi-organ failure and tissue hypoperfusion. Therefore, and at around this time, we also had a molecule called activated protein C. Now, this is a anticoagulant. It had mild fibrinolytic properties. It also had mild anti-inflammatory properties. And this study, called the PROVIS study on activated protein C, which was published in 2001, triggered a huge interest in coagulation and inflammation, and the potential for activated protein C to actually be an important modulator of the post response in sepsis. And in this study, they found that there was a significant difference in mortality between patients giving activated protein C, 25% versus 31% in controls, almost a 20% relative risk reduction in death, which was fantastic. This molecule made a big splash all over the world. There were a number of other trials after the initial PROVIS study, and I mean, virtually all of them did not show any difference in survival. And in fact, one or two studies found an increased incidence of bleeding, which is not surprising considering that it's an anticoagulant and it also has mild fibrinolytic properties. Okay, so activated protein C raised a lot of hope, but then it started with a bang, but it ended with a whimper. And activated protein C is no longer available for use. And not just activated protein C, many other molecules which were tested in the hope that targeting the coagulation cascade or targeting thrombosis could actually also benefit sepsis, starting from cheap drugs like heparin down to experimental agents like antithrombin 3, thrombomodulin, and tissue factor pathway inhibitor. None of these showed a benefit in randomized controlled trials. So again, we were at a dead end. We tried the anti-inflammatory, anti-cytokine agents. We tried the anti-thrombotic agents. And again, we did not seem to make a difference. The focus was also very much on extracorporeal blood purification therapies. And so you ran the blood through an extracorporeal circuit, and these removed the excessive inflammatory mediators and toxins from the blood, and it would modulate the post response. And there are a variety of blood purification techniques, including hemoperfusion or heme adsorption, high adsorption hemofiltration, high volume hemofiltration, high cutoff membranes like the Oxyrus, plasma exchange, and coupled plasma filtration absorption. And the most well-known and available to us in India are the polymyxin B immobilized fire column for endotoxin heat absorption. It's called torimyxin, and that has been reasonably well studied, and we'll talk about it. Cytosorb is a heme adsorptive device which has very limited data, and most of these other filters and molecules and techniques, they've had very little clinical experience, and most of them have not shown any great clinical benefit, including high volume hemofiltration, which is just a sort of extension of CVVH that we do, or high cutoff hemofiltration or hemodialysis using a special filter like the Oxyrus. Okay, so these are some familiar techniques, but again, not showing any benefit as far as mortality is concerned. Polymyxin B raised some hopes because there was a randomized controlled trial called the UFAS study in abdominal sepsis after perforation peritonitis, and it tended to show some difference in survival and some difference in organ failure in patients who were treated with polymyxin B hemoperfusion therapy, right? However, subsequent randomized controlled trials like the Abdomic study in France, a much bigger trial, a much larger trial, did not show difference. In fact, a trend towards a higher mortality with polymyxin hemoperfusion. Okay, so the benefit of him, and again, because it absorbs endotoxin, it has to be in gram-negative infection, but the clinical benefit is still unclear. Registry data is also not very supportive. Registry data from Japan and is not very supportive. There is a trial going on, but the conflicting data at the moment suggests that we have to have caution before we recommend this as a routine technique which is useful, and we need to know which patients to use it in and at what stage to. Was transient hemodynamic improvement, but did not improve mortality. And one of the guesses is that it removes the inflammatory cytokines, it possibly also removes the anti-inflammatory beneficial cytokines. And therefore, how they affect the balance between the pro-inflammatory and the anti-inflammatory cytokines is not really clear, and we don't know exactly how that is going to pan out. As supportive treatment, blood purifying techniques do not significantly affect mortality, and specific recommendations must wait for the evidence. So we have not had much success with modulation of the host response. The latest kid on the block has been vitamin C, and vitamin C had a whole lot of theoretical reasons, either alone or in combination with corticosteroids, to actually help in sepsis. And the whole thing was started with this retrospective study from a very well-known group of Paul Marek, where they did a before and after study in patients. They treated conservative patients with this cocktail of vitamin C, hydrocortisone, and thiamine, and they compared the outcomes to a control group which was not treated with this during the preceding 7 months, and a massive reduction in mortality, 40% versus 8.5%. So this was almost a magical therapy, virtually a magic bullet. Unfortunately, these two trials and many other trials that have come after subsequently, large randomized controlled trials, have not shown any benefit with vitamin C. So again, a promising agent, but not being shown to be effective when studied in randomized trials and subjected to scrutiny. What seems to work then? I mean, now, if you just look at the early goal-directed therapy study of Rivers, and this is data from that study. So these were patients who were treated by early goal-directed therapy or the standard therapy group, right? And they looked at some biomarkers and inflammatory markers in these two groups. And they also combined the groups and divided them into three groups. One who continued to have severe tissue global hypoxia, those who had moderate tissue global hypoxia, and those who had resolved tissue global hypoxia. And consistently what you saw is that in the early goal-directed therapy group with the solid bars, with the solid blocks, the inflammatory cytokine levels were lower. Also, if the tissue hypoxia resolved, the lactates were less than 2 and the SC was more than 70%, they had much lower anti-inflammatory cytokines as compared to patients in whom the lactate levels remained on the higher side. In other words, simple effective resuscitation not only restored organ perfusion, but also decreased inflammation, right? So effective resuscitation restores tissue perfusion, but also reduces inflammation and therefore may be beneficial in the management of sepsis. Now, all this was taken into account when the third sepsis 3 definition was coined. And one of the major limitations of the previous definitions that this consensus meeting identified was that previous definitions included an excessive focus on inflammation. We were hell bent on targeting and tackling the hyperinflammation or inflammation. Okay, and they defined therefore sepsis not as a hyperinflammatory condition, but as life-threatening organ dysfunction caused by dysregulated host response. And the key word is dysregulated. It is not necessarily hyper, it could be hypo. And we do know now that the host response in sepsis is not just hyperinflammation. There could be some patients who have a pure massive inflammation over here, and if it's not controlled, they die. But if you control the inflammation, they survive. But some patients have a mild inflammatory response, and then they go into a phase of prolonged immunosuppression. And here they get nosocomial infections, they get other late viral and other funny infections, and they could die. If their immune system, if their immunity is restored at some stage, the inflammatory response is restored at some stage, then they survive. But if it's not, then they can get prolonged complications and maybe even die. And some patients keep fluctuating between an inflammatory state and an immunosuppressed state, right? And if this immunosuppressed state persists, they could die. So the host response is quite complex. It is not just inflammatory, it is also anti-inflammatory or immunosuppressive. And if immunosuppression is not controlled, also the patients can have complications and even death. And they can fluctuate between a hyperimmune state and an immunosuppressed state, depending on many factors in the host, which we still do not understand, whether genetic, whether influenced by comorbidities, or whether they're influenced by the cytokine release itself, are still things we are working out. Okay, so host immunosuppression is a real problem in sepsis, and this is sometimes caused by prolonged release of cytokines. It's also caused by apoptosis of immune effector cells and loss of the active cells, decrease monocyte HLA-DR expressions, and essentially you have substances which cause, you have an immunosuppressive state where the cell immune system is exhausted, the T cells are ineffective, and the patients can actually die from more lethal infections. So this is a model where instead of taming the inflammatory response, you may have to actually stimulate the immune response. And so if you have sepsis, a subset of sepsis starts, and then they become immunosuppressed, if the immune system recovers, they'll do well. But if it doesn't recover, maybe you might have to stimulate the immune system so that it goes towards the blue side. Okay, and there are some potential therapies like interleukin-7 and anti-program death, an antibody against program cell death activator 1, so which actually restores the T cell function, restores the T cells, and allows the immune system to recover. It reduces the exhaustion of T cells, allows the immune system to recover, and maybe that might be the way forward, at least in a subset of patients with sepsis. When does a patient move from an inflammatory state to immunosuppressed state? What are the biomarkers? How do we identify the precise timing? We don't know. Giving steroid to someone who's in the immunosuppressed state will make matters worse. Giving immunostimulants to someone who's moving towards a hyperimmune state could also make matters worse. So we need to know, but as of now, we don't have all the right biomarkers or tools. So at the end of the day, there's an interplay between a large number of systems, between the complement system, endothelium, autophagy of the immune cells, and the microbiome, right? The gut microbiome. We're talking of proteomics, metabolomics. There's all sorts of things happening. There's hyperinflammation, of course, in many instances, but there's also immunosuppression. And all this can affect multiple organs of the body. And we need to figure out what is exactly happening when, at what stage. And we don't. So at the end of the day, I think it's back to basics. Good, simple, intensive care, right? So just to conclude, this is Donald Rumsfeld. He was the former Secretary of Defense in the United States during the Iraq War. And he said, there are known knowns, there are known unknowns, and there are unknown unknowns. Now, he was talking of the weapons of mass destruction, but this applies equally to sepsis as we know it today, right? So because of this, we still do not have an effective specific therapy to modulate the host response in sepsis. Research continues, and hopefully in a few years from now, we'll be a little better off than where we are today. So thank you for listening.
Thank you, sir. Thank you. Thanks for taking us through the dysregulated host response. As we are aware, and sir has specifically enlightened that there is no specific treatment, but do we have hope? Are we expecting any emerging therapies for the sepsis to treat the sepsis? For this, I invite Professor Mervyn Singer, who is a professor of intensive care medicine and director of the Center for Intensive Care Medicine at Wolfson Institute for Biomedical Research at University College London, UK. and his area of expertise is sepsis and multi-organ failure, infection, shock, antibiotic use and abuse, hemodynamic monitoring. Welcome, sir. I hand over to you.
Hello, my name's Mervyn Singer. I'm at University College London, and it's a great pleasure for me to talk about some potential therapies that may improve mitochondrial function and potentially outcomes in septic patients. This is a conflict of interest. I'll talk about a drug we're trying to develop in-house at the moment. So my focus is on mitochondria and metabolism, and from the very outset, I wish to stress that timing and dosing are crucial. Giving the drug, the intervention may cause benefit at the right time, provided the right dose is given, but it may have no effect or even cause harm if the timing is wrong and the dosing is wrong. This is a nice review article from Sebastian Pro and colleagues in France, where they highlight a significant literature showing energetic dysfunction in sepsis. And they go through the literature in animal models, cell models, in patients, where different organs have been shown to be dysfunctional. And there's a good, strong association with mitochondrial dysfunction. A few words on mitochondria. They're present in almost all cell types. They're the primary provider of ATP, energy substrate to the body, the major provider of body heat. They use more than 90% of the oxygen consumption the body utilizes. They're the major source in the body of free radicals, a major target of nitric oxide, carbon monoxide, and as I'll talk about later, hydrogen sulfide. These are endogenous gases formed by the body that can be used therapeutically. It has a major role in triggering cell death, in regulating intracellular calcium, and therefore much of the cell's metabolic activities. It's a major site of action of hormones, such as thyroid hormone. It's important in the production of hormones like cortisol, production of vitamin D. It plays a major role in lipid metabolism and in immune function. So as you can see, many different roles. And in septic patients, there's a literature covering most of these aspects, that there is modification of mitochondria and their function, such as thyroid hormone, cortisol, etc. A little bit of biochemistry revision for you. So in the cytosol, glucose is converted through glycolysis into pyruvate. Pyruvate crosses over into the mitochondria, and the pyruvate that's not utilized is in equilibrium with lactate. So that's where the lactate in our body comes from. The pyruvate enters the matrix of the mitochondria, where it's metabolized by pyruvate dehydrogenase into acetyl-CoA, and that feeds into the Krebs cycle, the tricarboxylic acid cycle. Alanine, the amino acid, can also be used as a substrate for energy production generation through conversion to pyruvate. The other major source of energy, apart from glucose, lactate as a fuel source, alanine, are fatty acids. So fatty acids either can enter directly as small chain fatty acids, or converted if they're larger chain, large chain fatty acids through the carnitine pathway, and then they undergo beta oxidation, which can either generate acetyl-CoA or feed down to ubiquinone or to succinate. As the Krebs cycle moves round, reduced NADH and FADH2, which are carriers of electrons, pass their electrons to the electron transport chain, NADH to complex 1, FADH2 to complex 2. And the electrons then pass down the chain via coenzyme Q, ubiquinone, to complex 3, and then via cytochrome C to complex 4. As the electrons pass down the chain, right at the very end, oxygen is the terminal acceptor of electrons at complex 4, and this is where most of the oxygen in our body is used. As the electrons pass down the chain, that creates a proton gradient across the inner mitochondrial membrane, and that proton gradient drives ATP synthase to generate ATP from ADP. And the ATP is transported out of the mitochondria into the cytosol via these adenine nucleotide transporters, ANTs. The final thing I want to mention here is that apart from oxygen being utilized for the electron transport chain for oxidative phosphorylation, it can also, at complex 1 and complex 3, be used to form the free radical superoxide. One other thing just to mention about the mitochondria is that the protons don't necessarily go back through complex 5, ATP synthase. It can be bypassed through uncoupling proteins. I'll talk about these later. And as a consequence, heat is generated. And perhaps much of the heat of our body comes from this mechanism. In terms of ATP production, for every mole of glucose, you get 2 ATPs from glycolysis, 2 from the Krebs cycle, and approximately 24 to 30 from ATP. In this little cartoon, just to recapture the situation, glucose, fatty acid predominantly are used and they feed into the Krebs cycle. Electrons are donated to the electron transport chain, and that creates a proton gradient with oxygen being used at the end of the transport chain. That proton gradient determines how much ATP is generated from ATP synthase. As I mentioned, a small amount of oxygen is used, about 1-2% in health is used to generate reactive oxygen species, in particular superoxide. Superoxide can actually cause damage to the electron transport chain, and clearly there are defenses within the mitochondria, very powerful antioxidant defenses, but if the amount of ROS generated is large, that can overwhelm the defenses. And so these antioxidants naturally occurring within the mitochondria, such as manganese superoxide dismutase, thyroidoxin, are very important protective agents. Uncoupling proteins, the famous one is uncoupling protein 1, UCP1 in brown fat, but also there's UCP2, which is in most organs in the body, and UCP3, which is predominantly found in striated muscle. And that potential across the inner mitochondrial membrane that drives ATP synthase may be reduced if the protons go back through UCP back into the matrix of the mitochondria, and heat is generated as a result. The advantage here, although you lose out in terms of phosphorylation efficacy, the advantage is by lowering the membrane potential, that lowers the amount of ROS being produced, and so it's another way of protecting the mitochondria. So can we protect mitochondria, aid recovery? There are different ways we can potentially protect the mitochondria, or maybe we can enhance recovery if they're damaged. So I'll briefly give a few examples from each of these different potential therapies. So in terms of substrate cofactor supply, as I mentioned earlier, small chain fatty acids can enter the mitochondria directly. Medium and long chain fatty acids go through the carnitine pathway. And people have looked at giving carnitine, and there was this study where they gave it to endotoxic mice given endotoxin, part of the cell wall of gram-negative bacteria, and there was this survival benefit. The thing I wish to point out is this was pre-treatment, and most of the time we get our patients when they're already ill. When they moved to a clinical trial, these investigators, unfortunately, it was an American study, unfortunately found there was no benefit from giving either low, medium, or high dose levocarnitine in septic shock patients. Another substrate that can be used is oleic acid. This is a long-chain fatty acid, and again, this study from Brazil, as pre-treatment in septic mice who underwent a peritonitis type insult, there was a clear survival benefit. There was an anti-inflammatory effect, so giving the oleic acid reduced interleukin-6. AMP kinase, which is a bioenergetic activator, was heavily stimulated by oleic acid. Uncoupling protein 2, which is ubiquitous in most tissues, also was stimulated, and there was less oxidative stress measured by malonyl-dialdehyde. I talked about antioxidants. If they are being overwhelmed, perhaps giving antioxidants may afford ongoing protection. This is a study we published a number of years ago using mitotempo. So this is an antioxidant that seems to be more selective for the mitochondria, and we gave it to our septic rats. They have peritonitis, whoopsie daisy, and there was no clear difference in oxygen consumption, although it was a bit better than in septic animals. However, in terms of, we looked at the kidney, in terms of renal function, creatinine was significantly lower in the treated animals, and urine isoprostanes, which is a marker of oxidative stress, was also reduced in the rats given mitotempo. This backs up an earlier study done in the United States, also using mitotempo, also showing protective effects on the kidney. And like we did in our trial, they didn't give it as pre-treatment, they gave it 6 hours after cecal ligation and puncture. Ubiquinone, I mentioned earlier, this is part of the electron transport chain. It's an electron carrier, and it's also an important antioxidant. This group, I think from Turkey, gave coenzyme Q10 to their animal model, a septic rat model, and they showed, again, significant benefit from giving coenzyme Q10. Malonyl-dialdehyde, this marker of oxidative stress, was significantly reduced, and it seemed to stimulate production of the reduced form of glutathione, which is a potent antioxidant. A small trial from Iran, 40 patients only, but a preliminary study showed that giving coenzyme Q10 to patients improved survival and reduced inflammatory markers. The interesting thing about fatty acid is it can work on brown fat to stimulate uncoupling. To remind you, uncoupling is where the electrons don't go through ATP synthase. Oh, sorry, the protons don't go through ATP synthase, and so that oxidative phosphorylation efficiency is diminished, but at the same time this reduces reactive oxygen species. As a consequence of uncoupling, you get heat, and that may be where the fever in sepsis comes from. There are a number of mechanisms this may be important. However, by reducing the mitochondrial membrane potential, the downside is there's reduced ATP production. The upside is that there's a decrease in reactive oxygen species formation. And talking about heat, this fascinating study recently got published in Critical Care Medicine from Richard Hotchkiss's group in St. Louis in the United States. They gave 56 patients who presented with normothermia. They were septic patients, but they did not have a high temperature, and half of the patients were randomized to being warmed. And there was a significant outcome benefit in those patients where the temperature was 1.5 degrees above the lowest temperature recorded. This reflects the findings that patients who present to emergency departments with sepsis do much better if they come in with a pyrexia compared to normothermia or even hypothermia. So we've talked about protection. Can we enhance recovery of the mitochondria? So potentially we could stimulate biogenesis, the formation of new mitochondria. And PGC1 alpha is a sort of coactivator, and that's called the master regulator. And that triggers a whole variety of different actions, for example, mitochondrial biogenesis and formation of antioxidants. And there are direct pharmacological stimuli, ACAR, and even metformin. This study from the United States gave treatment around either 24 hours before a septic insult or 1 hour after. So again, not really reflecting what happens in real life where the patient has many hours or even days before they present. But as you can see, there was an outcome benefit from either ACAR, especially if given early, or there was still a benefit if it was given at 1 hour after the insult. The same was seen with metformin. This study looked at ACAR given at 1 or 6 hours after cecal ligation and puncture to both young mice, 2 to 3 months, and mature animals. They're now adults in mice at the age of 11 to 13 months. And treatment with ACAR significantly improved cardiac function, reduced cardiac injury, and it worked not only in the it worked in the young mice only, not in the older mature mice. Finally, a quick few words about mitophagy. So mitophagy is the process of clearing away dead or dysfunctional mitochondria, so you have healthy mitochondria replacing it. And urolithin actually is an interesting molecule that comes from our own gut bacteria. And this study from a group in Switzerland induced mitophagy with this agent, urolithin A, and in a worm model, it prolonged their lifespan, a C. elegans model, and in a rodent septic model, a rodent healthy model, it increased muscle function. So oxygen consumption on activity increased. And this is an example of the improvement in grip strength and running distance with this drug, and a whole load of genes that are involved in mitophagy were upregulated. This group in China showed that mitophagy actually is anti-inflammatory. So they gave it again pre-treatment to their mice, and there was a significant improvement in heart function, left ventricular ejection fraction, and also a much lower troponin T level, which is obviously a marker of cardiac damage. The one quick thing I'd like to add, it's not really to do with sepsis, but we've used it in other instances, other conditions, is perhaps to try suspended animation. And the one that's aroused quite some interest is hydrogen sulfide. This group in Seattle found in 2005 that if you give hydrogen sulfide gas to mice, it reduces their core temperature dramatically within hours down to ambient room temperature, and at the same time it has a number of actions. It's anti-inflammatory, it has vasodilating actions, and it's an important inhibitor of the electron transport chain. It competes with oxygen for binding of complex 4. An offshoot of hydrogen sulfide we've been developing is ammonium tetrathiomolybdate. So this is a molybdenum core with 4 sulfur atoms, and importantly, as opposed to sulfide, which is given intravenously but released in a gas form very quickly in the circulation, is it seems to target cells and mitochondria in particular. 1 or 2 of the sulfide bonds are broken off and released. And we have been looking at it in healthy animals, and here you can see that it reduced baseline oxygen consumption over 24 hours by about 25%. It reduced core temperature, it also reduced heart rate, but the animals looked fine. We then went on to look at some reperfusion injury models, such as the heart, and you can see this is what a heart infarct looks like, and this is after about 30 minutes of clamping of the left coronary artery. And just at the time of reperfusion, the drug was administered, and there was a significant improvement in infarct size, in BNP as a marker of ventricular function. We also did it in a stroke model in the brain, and again saw similar findings. Improved histology, infarct size was reduced in the brain, and S100B, a marker of brain damage, was also significantly reduced. So in summary, there are multiple means of protecting mitochondrial function or encouraging recovery. These are promising, but none as yet have been shown to produce outcome benefit in human sepsis. Thank you very much indeed for listening, and it was a detailed talk, but I hope you followed it clearly.
Thank you, Professor Mervyn. As we have gone through the different topics and the recommendations which has been suggested by the experts, so the question arises for the extracorporeal therapies. Is it a end of road for its use in sepsis, or still we can use it? I like to invite Dr. Abdul Ansari, who's the Director of Critical Care Services at Nanavati Max Super Specialty Hospital, Mumbai, and his area of expertise is critical care medicine. And along with that, Dr. Deepak Goyal sir, about the pros and cons for end of road for extracorporeal therapies. Dr. Deepak Goyal sir is an Director Critical Care Medicine at Medanta Medicity Hospital at Gurugram, and his area of expertise is ventilation, hemodynamic monitoring, ultrasound, and sepsis management. Over to you, sir.
Friends, it's a pleasure to be a part of Sepsiscon 2022, and thank you for inviting me over here for this wonderful session on end of the road for extracorporeal therapies in sepsis. So I would say this is far away from the end of the road. In fact, I would say that there is a long way to go, and the most important part in extracorporeal therapy is probably understanding the reason for these extracorporeal therapies in sepsis. So, as Robert Frost said, the woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. And that's what I say is all the story about sepsis. The saga of sepsis is still unfolding, and we don't have an idea about where we are heading, but still we have to keep walking. Sepsis is a major and growing global healthcare challenge. While the reasons for increasing impact of sepsis are due to an aging population, increasing antibiotic resistance, more invasive devices, and people who are presenting with multiple comorbidities and immunosuppressive medications. So with this background, the clinical criteria for sepsis is well defined as a life-threatening organ dysfunction in a dysregulated host response to infection, which is amounted by a rising SOFA score or delta SOFA more than 2 in ED or wards. Or when we talk about quick SOFA, it is about major alteration of one of the 3 functions of disordered, breathing, falling blood pressure, as well as a disorientation. With this, we all know that when the vasopressor requirement is there, and we talk about immune responses in infection, the important thing to understand is if the lactate is rising and the vasopressor requirement is there, despite adequate fluid resuscitation, we are talking about septic shock, which is a subset of sepsis, which is due to profound circulatory, cellular, and metabolic abnormalities. We will focus in our talk in this subset of septic shock, where we have to understand, apart from the source control and other supportive measures, is there a role of extracorporeal therapies? So to understand a normal immune response and dysregulated immune response, which is at the heart of a response to sepsis, we must know that a dysregulated immune response is due to an excessive release of these pro or anti-inflammatory cytokines, which trigger a series of reactions that can lead to cellular and tissue injury, leading to pathological failure of one or more organs. And this has to be contrasted from a normal immune response, where these excessive release of chemokines as well as organ failures don't take place. So with this background, when we look at the impact of excessive release of cytokines on the one hand, and the excessive release of endotoxins from the gram-negative bacteria or the pathogens, the central kind of common point is the pattern recognition receptor, where once these pathogen or damage-associated molecular patterns are activating an excessive release of cytokines and immune cell activation. And this is at the heart of all the problem, where a cacophony of release of IL-6, IL-8, IL-10, and a massive release of endotoxin causing a burden which can overwhelm an immune response and cause multiple target organ damage and distant organ dysfunction with cellular and tissue damages. With this background, the multifaceted approach to sepsis, as we spoke about in the Surviving Sepsis campaign, is very clear that fluid resuscitation and hemodynamic support, infection control, appropriate antibiotics, general supportive care, and management of organ dysfunctions with kidney, lung, and cardiac support is essential. But despite this, we know a big number of people who are in septic shock don't do well. And it is that subset of the people where we talk about extracorporeal therapies, which is defined as an adjuvant therapy for sepsis for removal of harmful inflammatory mediators of endotoxemia. This is the definition which was given as early as 2009. When we look at where we move through the extracorporeal therapy, these are the 2 parts. Restoration of physiology by removing of toxins, decreasing fluid overload, and restoring dyselectrolytemias, while contributing to resolution of inflammation by removal of endotoxins, chemokines, and cytokines is highly important. And this is the aspect which we need to focus for that highest sick individual, where the maximum benefit of these therapies can be achieved. When we talk that the absolute indications for commencing renal replacement therapy, which is one of the simplest form of RRT or extracorporeal therapy, is severe hyperkalemia, acidosis, organ dysfunction, uremic complication, life-threatening complications. All of these can cause absolute indication for starting CRRT, while futile therapies or patient who is not having clinically important fluid overload, or the kidney function is very slowly deteriorating, and probably there are harmful effects of RRT by removing of antibiotics, or probably who have responded well to a furosemide stress test. Those are the reasons where you don't think about an extracorporeal therapy in the form of RRT. But taking further, when we talk about the continuous renal replacement therapy, it provides an essential metabolic platform on which you can support and provide homeostasis for this dysregulated host response. When we talk about organ dysfunction, the use of CRRT is one of the simplest extracorporeal therapy, which even in stable patients, it can provide a technical advantage of better solute control, better acid-base hemostasis, better fluid control, and reducing organ edema and avoiding fluid shifts. And this has been shown to be consistently better, provided the timing is taken into account, and most important, organ crosstalk is looked after. The common indications in CRRT for in the ICU, as we know, is either for acute kidney injury, severe acute pancreatitis, fulminant hepatic failure, while extension of that could be plasma exchange or direct hemoperfusion, which we do in forms of fulminant hepatic failure, TTP, or in drug intoxications and endotoxic shock, where we can use polymyxin immobilized filters and other heme adsorption filters, which we will be talking about soon. With this, in sepsis, why are we talking about CRRT? Because it's not just a treatment to deal with water and metabolic balance, but also something which can regulate the inflammation. As we all know that the inflammatory cytokines or the middle molecules are better recovered or better removed with a continuous veno-venous hemodiafiltration. And in addition to the benefits of organ recovery, when we talk about immunodysregulation in sepsis, the pro and anti-inflammatory mediators are more consistently removed by CRRT, allowing the organs to have immunohomeostasis, which was shown as early as 2003 by Ronco et al. In its classical study, that CRRT causes a balance of these pro and anti-inflammatory mediators, allowing the immunohomeostasis to take place. With this background of importance, the extracorporeal removal of inflammatory mediators can be used to address the effects of unbalanced immune system by both endotoxin and cytokine removals with various devices over a period of time. Yes, so this was one of the study where very high EA levels, more than 0.6, versus intermediate levels were very clearly shown that higher circulating levels of endotoxin can have a very high mortality, and this was correlated with 107 patients over a large database, very clearly showing that higher EA levels are directly proportional to mortality. And with this background, Andalus et al. In cytokine have shown that combined scores of pro and anti-inflammatory interleukins also give a kind of mortality prediction in serious sepsis. And they showed that elevated plasma IL-6 levels were also associated with an increasing risk of mortality, and cytokine profiling would be very important to categorize these patients into high risk or low risk septic patients. And another filter which has been shown to have a 3-in-1 blood purification process, which can provide with an AN69 base membrane, which is a normal RRT membrane, which is coated with polyethylenamine, which can absorb endotoxin, and also a heparin coating, which can allow the membrane to last longer and remove both cytokine as well as endotoxins. So this has been shown to be beneficial as an adjunctive therapy for sepsis while delivering CRRT at the simultaneously. And this study, which was done by Mellard et al. And published in Intensive Care in 2018, very clearly showed that this filter, Oxiris, when compared with another two heme adsorption filters, cytosorb and toremixin, had shown that there was an effective removal of both cytokine and endotoxins by Oxiris. And toremixin was removing very good amounts of endotoxins, while cytosorb was very specifically associated with removal of high levels of IL-6 and other inflammatory mediators. This had very clearly shown that these three things, which Oxiris can specifically remove endotoxin along with cytokines, can be a very, very important game changer over a period of time. And another study, Turani et al. Showed that the various adsorption actions of Oxiris in septic patients in a case series showed that there was an improvement in MAP, increasing PF ratios, decreasing norepinephrine requirement, and there were decrease in SOFA scores. Although the mortality benefits were not to be shown in a smaller number, but majority of them had a trend towards improving other functional parameters, and there was a parallel decline in both pro and anti-inflammatory mediators like IL-6, IL-10, and other markers of infection like endotoxin activity. and even procal levels. This was the continuation of the study, which very clearly showed that there was a change from the baseline to immunological parameters to the end of treatment with Oxaris after 74 plus minus 36 hours. And this was a proof of concept that majority of these cytokines and endotoxins, as they can be manipulated in severe septic patients, there could be a trend towards better and early physiological stabilization. So various studies have shown by multiple observers have shown that the organ function and hemodynamic improvement in septic shock patients can happen by utility of Oxaris, which is a balanced kind of a hemoadsorption along with CRRT in these septic patients. And this was another study with Cytosorb, where hemadsorption was showing an improving mortality over 28 days in ICU patients with a propensity score weighted retrospective matching. And this was also a proof of concept that majority of these patients would improve and have a better outcome over 28 days. And another study which was published in Artificial Organs in 2020 showed that this retrospective case series, that a combination of CRRT and Cytosorb is a safe potential rescue therapy in critically ill COVID-19 patients with AKI, ARDS, septic shock and hyperinflammation. And the majority of these critically ill COVID patients who underwent CRRT with Cytosorb survived, while non-responders had increased prevalence of organ dysfunction and moving into multi-organ failure. So in a summary, this was another study by Burns et al. Which showed that CRRT effect was very effective in endotoxin removal. And this was another study by Claudio Ronco, where he had propensated about the role of extracorporeal various therapies in sepsis, which is an interesting article to go through. Next. We showed that the improvement in cells and the CARS response is important, and we cannot undermine the effect of fluid balance in these people, and CRRT helps. And this has been very clearly shown that apart from removal of the mediators and fluid control, which is consistent along with, would be very beneficial. So in conclusion, when we talk about CRRT, there is a preferred method for sepsis control with middle molecule removal. Timing is important, has a greater impact on the negative fluid balances, and it can reduce downtime and improve outcome. And coupled with other heme adsorption therapies, we can have a great handle in controlling septic shock with other organ dysfunctions. This was actually a case report which I thought I will end up with. This is a gentleman who is right now with me, 78-year-old, who has underlying hypertension, ischemic heart disease, presented with history of fever and cough, and was positive for SARS-CoV-2. And this kind of a bad lung where he went on ventilator, his PF ratio was 74. He could not be prone because he had renal dysfunction, metabolic acidosis, and abdominal dysfunction. He was initially on NIV support and had to be put on ventilator. And after intubation, if you look at these are just 4 days back, from 11th to 15th as we talk today, over the last 4 days, from fever with cough and NIV support with 50% FiO2 and requirement of Lasix, where the first day WBC count was only 1,390 with an absolute lymphocyte count of 300, a creat of 2.3, a procal of 18.6, and a PF ratio was only 67. He was on antibiotics, which were escalated to meropenem and other, continued with remdesivir. But what was important is in the next 48 hours, he had to be on a ventilator. He went on CRRT, and we realized his IL-6 levels were more than 5,000. His procal went up to 100. His creatinine went up to 3.2. There was a mild improvement in WBC response, but that was in attendance to the kind of severe organ dysfunction. And at this point of time, with maximal ventilatory support, ongoing hypotension, CRRT, Cytosorb, and he was moved on to a VV ECMO for hypoxia control. We continued with the meropenem, levodopa-fluoxetine and remdesivir. And today, after 48 hours, he is still on ventilatory support, CRRT ongoing with VV ECMO. Procal has come down from 100 to 30. And look at the decline in IL-6 from more than 5,000 to 694. The PF ratio has moved up to 142. But he is also on ECMO with a flow of 4 liters. His pressure control and the oxygenation requirement has come down to 50%. The PEEP is 8. He's on lung protective ventilation. And this is the current scenario. So I understand, I can always argue that for the last 4 days, this bad patient who would not have survived, he's still hanging on with CRRT and ECMO and Cytosorb. His inotropic requirements are improving. It is work in progress. And I cannot say that we are at the end of the road of extracorporeal therapy. What we need to understand is this complexity has to be unified, and we need to find better ways to control And in the absence of understanding, we must know that there is a major role for the most sickest of the population to have a unified extracorporeal platform where we can buy some time to get these people the best of the therapies. Thank you very much.
Good afternoon, dear friends. So you have already heard Dr. Ansari. He talked about the use of extracorporeal therapy in sepsis, and I am sure that he is able to put his word very effectively that they are the future. But I'm talking about these extracorporeal therapies in sepsis. What I feel that there is a end of the road for these therapies. I would like to start with few quotes. No one can stop a bad idea whose time has come. So I feel that their time has already come. However beautiful the strategy, you should occasionally look at the result. This quote is by famous person Winston Churchill, and that stands true for these therapies as well, because these therapies, they look very logical, they look very fancy, they are costly. People feel that they are the Sanjeevani booty, they can save the life, but one has to see at the end what are the results, whether they are able to do the miracles, to they able to save the life, or just spending money. Sepsis is a complex clinical and biological syndrome. It is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. That is not a new thing. All of you know this thing, but there is an interaction between the resistance, that is the inflammatory response, and resilience. There is a limiting inflammation by adaptive immunity, and the balance is key to the survival. But in some circumstances, not completely understood, this complex and delicate balance is lost, and sepsis syndrome may develop. Extracorporeal therapy have the potential to remove both injurious and protective substances involved in the pathophysiology of sepsis. Extraction of protective factors diminishes beneficial physiological response such as immune hemostasis, restoration of immune hemostasis, endothelial integrity re-establishment, as well as reduction of coagulopathy. So they can be harmful as well. These are the different extracorporeal immunomodulation strategies which are being used in the sepsis. One is a toremixin column, another is LPS column, another is oxalis column, then cytosol column, and there are so many other filtration techniques as well. What is the evidence? Dr. Ansari has showed a very good evidence, but we have to take that evidence with a pinch of salt. I'll tell you why. This is one paper published way back in 2013 where they have compared the high volume versus standard volume hemofiltration for septic shock patients. Trial is a multi-center randomized controlled trial, and as you can see here, is a hardly any difference in the survival population. Another study published last year only in intensive care medicine is comparing the high dose coupled plasma filtration and adsorption in a septic shock patient. So it was known as a compact 2 study. In this study, they studied around the coupled plasma filtration in treating with the septic shock patients. 115 patients were randomized. They look for the safety and efficacy of coupled plasma filtration, and as you can see, the survival is almost same. There is hardly any difference. Coming back to the columns which we discussed earlier, I'm talking about, in this slide, I'm talking about two columns. One is the polymyxin B impregnated filter and another is a LPS adsorber. Both are adsorbers, both work for a gram-negative sepsis. So let us see what is the evidence. I am sure this UFAST trial was discussed by Dr. Sari, and it was about the early use of polymyxin B hemoperfusion in abdominal septic shock patients. And as you see here, it showed a good benefit in the mortality, but don't believe everything you hear. Don't believe what he's saying can be everything true. If you twist the data, things can be different. Don't believe everything you read, only believe half of what you see. I'll tell you why. There are so many limitations in this study. This study was highly targeted on a certain patient population where source control was already done. physicians were not blinded, so results could be biased. A trial was stopped early and had a very small sample size. Smaller studies and early stopping tend to overestimate the true magnitude of clinical effect. And there is an inability of the trial to provide definitive answers on the effect of dose, duration, and number of required polymyxin B treatments. Another study known as a Abdominix trial, which again failed to show any mortality benefit. Rather, the mortality was little higher in the PMX column patients than the standard. Another study which published few years back only, which probably put a death nail to these type of filters or these therapies, was the Euphrates randomized control trial. It was a big clinical trial in which the 921 patients were screened and 450 patients were randomized. After second interim analysis, where the multi-organ dysfunction score of more than 9 group become a primary analysis of interest for FDA. And as you can see here, there is hardly any difference in the mortality. Thus, extracorporeal hemoperfusion with polymyxin B has shown improvement in organ dysfunction and a survival benefit in a small study, including a small randomized trial, while larger trial failed to confirm these findings. That is the biggest thing. A high-cost therapy should have a clear prognostic effect before generalization. We cannot put that type of therapy to each and every sepsis patient, believing that it is going to work and my patient will survive. There is no trial till date has shown any benefit in the mortality in last 2 years. This PMX filter is available in the market in last 20 years, but no trial has shown any great benefit. Coming to another filter which is gained popularity during the COVID era is the cytosol. Although there is a significant body of experimental studies supporting the potential use of cytokine removal in septic shock, there is a far less evidence from the human studies. So experimental evidence is there, but real evidence is missing. Over 100 case studies describing the use of cytokine removal in many clinical scenarios are there, but clinical studies in general are a small case series, not our big randomized controlled trials. These are different studies, few randomized control trial also, but the study size is very small. The 43 patients, 25 patients, 97 patients, 16 patients or so. Okay. The main study describing these are the main studies. This is another study, the PLOS-1 study. This study published in a PLOS-1 journal is the effect of novel extracorporeal cytokine heme absorption device on IL-6 elimination in septic patients. So mechanically ventilated patients with severe sepsis or septic shock and acute lung injury or acute respiratory distress syndrome were eligible for this study. This was randomly assigned to cytosorb hemoperfusion for 6 hours per day up to 7 consecutive days or no hemoperfusion. And you can see the results. After adjustment for patient morbidity and baseline imbalances, no association of hemoperfusion with mortality was found. So again, this is a negative study. Another study published in AJRCCM in 2021 is the longitudinal cytokine profiling in the patients of severe COVID-19 on extracorporeal membrane oxygenation with heme adsorption. So they compared the cytokine profile in the patients with ECMO and cytosorb and ECMO alone. So as you can see, the findings suggest that ECMO itself does not exacerbate the cytokine release in the patient with COVID-19, contrary to what was previously suggested. Results also question the actual impact of the cytosorb treatment to decrease serum concentrations of IL-10, interleukin alpha, and interferon alpha and IL-6 in this context. So has the obituary already been written? Yes, of course. These therapies are dying therapies. They don't have got much space in a clinical medicine except for experimental and the clinical trials, experimental studies and the clinical trial scenario. This was published, this commentary was published in Critical Care Medicine in June, 1 month, 2 months back only. Is this the beginning of end of cytokine adsorption? So here the authors have narrated a small story about the Churchill's daughter, Marigold. She died with the septicemia in 1921. 100 years later, we aim to save as many lives as possible midst of the pandemic health crisis. But does this justify using untested device like cytosol? In the era of evidence-based medicine, we need new strategies to build a solid database of new intervention and devices rather than using them indiscriminately. In 2020, insurance company in the Germany paid for cytosol treatment in at least 6,600 patients without increasing the evidence level to today's standard. So just imagine, in 6,600 patients it was used, but there is hardly any evidence today which can justify its use. So to conclude my discussion, no matter how intriguing the mechanism behind a proposed therapeutic strategy might be, the intervention must still be substantiated by positive results of well-designed and adequately powered clinical trial. We can't prescribe these filters just at the heck of prescribing that if nothing is working, try this. But again, believe me, they are not going to work. Unselected drug clearance in the patients with sepsis is an under-researched area. We still do not know how early and how long the treatment session should be. So they are all limited to a experimental state, not for a clinical setting. Thank you very much.
Thank you, sir. Thank you, Ansari sir, and thank you, Deepak sir. So depends upon the clinical condition of the patient, whether to go with the evidence-based medicine or try newer strategies for extracorporeal therapies. That depends upon the clinician and with the help of the expertise. I hope there are no questions for this pro-con debate.
I would like, Dr. Abhijit, I would like to make a comment here.
Yes, sir.
As pro-con is there and Dr. Ansari put his points forward, I also put my point of view forward. The thing is that for these extracorporeal therapy, we need to identify the right person, right dose, right time. And sometimes it becomes very difficult and challenging in clinical practice to correctly identify those patients. And if we are not able to identify those patients, then of course, people feels that therapy is ineffective. I'm sure Dr. Ansari will agree.
I completely agree, sir. I completely agree. My apologies. I had to catch a flight, but I completely agree with what Dr. Govil had very clearly elucidated, that the evidence is still significantly lacking. We are only relying on case series, but definitely what I only wanted to say, that a small subset of patients in the right timing, we may be able to extract benefit out of them in conjunction as adjuvant therapy along with standard cares for sepsis. Thank you very much.
Thank you very much. Bye-bye.
Thank you, sir.
Have a nice flight, Dr. Ansari.
Happy journey, sir. Thank you. Thank you, sir. Thank you for the valuable inputs. Moving ahead, as we all know, the critical step in early diagnosis of sepsis and the time limits and the diagnosis, uncertainties of the diagnosis. We would have some biomarkers to be used for that. The role of procalcitonin has been discussed widely. So let's have an panel discussion on that, whether the procalcitonin is used carefully or misused in the critical care areas. For that, we have a moderator, Dr. G.C. Kilnani, sir, who is the chairman at PCRI Institute of Pulmonary in New Delhi. And the panelist will be Dr. Pawan Tiwari, who's a consultant at All India Institute of Medical Sciences. Dr. Zirpe sir, at the director of neurotrauma unit at Ruby Hall Clinic, Pune. Professor Dhruv Chaudhary sir, who's director at PGIMS Rohtak, and Dr. YP Singh, who's consultant at Max Super Specialty Hospital, New Delhi, and Dr. Srinivas Samavedam, Director of Critical Care at Virenchi Hospital, Hyderabad. So I welcome you all for a panel discussion.
Hello, everybody. I welcome you all to this panel discussion on rational use of procalcitonin in critical care, a case-based discussion. So why we are discussing today the procalcitonin critically ill? This all boils down to antibiotic stewardship. The stewardship is a coordinated intervention designed to improve and measure appropriate use of antibiotic agents by promoting selection of the optimal drug regimen, dosing, duration of therapy, and the route of administration. A burning issue is antibiotic resistance, which is growing, and then pipeline for new antibiotics is running dry, especially for MDR gram-negative bacilli. And two main approaches have been suggested. One is the new antibiotics, which are not coming because the research and invention of new antibiotic is too expensive and the yield is very low. So what we are left with is a better use of what we already have, that is the existing antibiotic, and practice antibiotic stewardship. Now 30 to 60% of antibiotics prescribed are unnecessary or inappropriate or suboptimal. And time to appropriate antibiotic administration is the major outcome. Only 5% of septic shock patients receive effective antibiotic therapy within the stipulated time, and harmful effects of inappropriate antibiotic therapy lead to development of several complications, including fungal infection, and emerging multi-drug resistant infection is causing threat to the intensive and the overall outcome. The question is that, do we need a biomarker? And that's what we are discussing today. And the commonest cause of drug use in ICU is antibiotics, leading to enhanced cost and care and adverse effects. And majority of patients in ICU, irrespective of etiology, receive antibiotics. We all know, rarely we have a patient, especially on ventilator, who is not on antibiotics, whether he has evidence of infection or does not have infection. And the biomarker for antibiotic prescription in the infections has been a bone of contention, whether it is CRP or STREM or other biomarkers, and procalcitonin has been used for a very long time. But the question is, do we know when to use procalcitonin, when not to use procalcitonin? And procalcitonin is a natural biomarker which is secreted by thyroid gland and also by liver, and several cutoffs have been given. And this is a cartoon which says that if the procalcitonin is less than 0.1 or 0.25, withhold antibiotic, 0.25 to 0.5, start or continue antibiotic, and so on and so forth. The question is, are these cutoffs of procalcitonin sacrosanct? And how to utilize this biomarker in clinical practice? And this is what we are going to discuss today. And to discuss this, a meeting organized under the banner of Indian Society of Critical Care Medicine in pre-COVID time in Hyderabad in 2002 during critical care, where several experts were there. 4 young lads, namely Dr. Vijay Hada, Dr. Neetu Jain, Dr. Manjunath, and Dr. Pawan Tiwari. They threadbare reviewed the literature and presented various aspects of utility of procalcitonin during this meeting, and finally this group penned down a document which was submitted to Indian Society of Critical Care Journal, that is IJCCM, and thanks to the editorial team, they have accepted this, and this will be published soon. So in this document, the same gradings and strengths were used as it were used for ISCCM in previous documents, including the document on antibiotics. The evidence was graded as 1, 2, 3, depending upon the strength of evidence The strength of recommendation was A and B. If there was strong recommendation, we all agreed, and it was A. If there was a weak recommendation, where benefits and risks were more closely balanced, it was B. And UPP, if there was no evidence, and still if the group felt that it is a useful in practice. So we'll be discussing all these issues, and I'll be reciting the guidelines, but more importantly, I will request all the panelists to give their frank opinion so that we come out with a meaningful view of the experts. So this is a 32-year-old male who had no comorbidities, presented to emergency with fever since 1 week, occasional dry cough. The clinical examination E4, M5, M6. He had tachycardia, tachypnea, the blood pressure of 80/60, chest examination was normal, SpO2 was normal. Started on inotropic support and oxygen and supplement via mask. The COVID RT-PCR was negative. So diagnosis was kept as sepsis with septic shock. Now my question to Dr. Dhruv Chaudhary to start with. Should baseline, this is a patient who has come with sepsis, with shock. We don't know what is the location, what is the organ involved. Should baseline procalcitonin levels be done in patients with in such patients? Dr. Dhruv, your call.
Good evening, sir. You see, the question which you have put into the here, it looks to me primarily, yes, I do agree with the diagnosis of sepsis. What you have said is that probably what is the site to me, lungs look to be the predominant cause because of the cough and fever which is there. Therefore, whenever these patient comes to us, upfront I will not go for procalcitonin. I will try to look at straight away what is the likelihood. In this case, I will definitely first go for the X-ray chest. But if I don't get any pneumonia patch or any patch on the X-ray, then probably one obviously will like to do the blood cultures, everything which is there at that point of time, because this patient definitely has a severe sepsis. We can see the organ dysfunction. Upfront, usually we don't go if we know the site of sepsis, whether it is urinary or whether it is a lung or anywhere else. But yes, if I don't have a guideline, but clinically there is a strong suspicion of sepsis, because culture may take up to 48 hours, and turnover times now with the availability of 24/7 availability, lab time has come up. That is one place to be definitive of which that I may go for a procalcitonin. But upfront, sir, first I would like to look at the site.
Okay, I got your point. Dr. Kapil Zirpe, do you agree with Dr. Dhruv, or you would like to do procalcitonin right away?
Sir, be frank with you. Thanks for asking me. Be frank with you. Procalcitonin is one of the investigation which is a fancy investigation which everyone does it, but don't give respect to that because of the lack of the evidence, or there is a lot of myths and facts about the use of the procalcitonin. Coming back to your question, procalcitonin, baseline procalcitonin, I always does the baseline procalcitonin in my day-to-day practice. I don't use it. I might not be, I will use it for deciding the antibiotic or stopping the antibiotic, anything. On day one, I need the baseline procalcitonin. Suppose in future, after 3 days or after 5 days, I need to take a call on the antibiotic deacceleration or discontinuation. Might be that value may help me in deciding the further course. So I always, be honest, I always do the baseline procalcitonin in septic shock patient or in sepsis.
Okay, all right. Let me have Dr. Srinivas' opinion.
Yes, sir. What I can say is that we need to do a baseline procalcitonin in these patients with sepsis, essentially to focus on the future strategy of de-escalation of antimicrobials and to assess the response of our antimicrobial therapy. My own view is in the diagnosis of sepsis, to differentiate the culture negative sepsis from a non-septic condition, definitely this would help. A positive procalcitonin should probably provoke a further more detailed investigation for the presence of a bacterial or a fungal infection. And a negative procalcitonin should probably make us look for a viral or a non-infectious cause for the clinical condition.
All right. So amazing, amazing. You see the difference of opinion and such amazing explanations have come up. Dr. Y.P. Singh, I have asked you the next question. What is the role of procalcitonin? PCT I'll announce for the simplicity of it. PCT in the diagnosis of sepsis to differentiate culture negative sepsis from non-sepsis. Dr. Y.P. Singh?
Good evening, sir.
Good evening.
Regarding this second question, whether the procalcitonin is having some role in differentiating between the culture negative sepsis and non-sepsis, definitely it is. Answer is yes. Now, going with that, what Professor Chaudhary has mentioned, Dhruv Chaudhary, that procalcitonin per se cannot be used to make a diagnosis of the sepsis. It is all the clinical examination, your blood labs and your radiological pictures give you a fair idea that what you are dealing with. As Dr. Kapil Jirpe has mentioned, obviously one baseline PCT has to be there, which will be used in a future as far as their antimicrobial therapy continuation and de-escalation. So my answer regarding the second question is that yes.
So Dr. Tiwari, Pawan Tiwari, what is your, I know you have worked in this for this document, but what is your personal take on this? Dr. Pawan Tiwari.
Yes, sir. So basically, procalcitonin, whatever literature we have reviewed and whatever research is available, basically it has moderate sensitivity for diagnosis of sepsis. And as we know that sepsis is a condition where any delay in giving antibiotics will lead to increased mortality. So that component is probably a clinical decision. Probably procalcitonin can be used to support the diagnosis of sepsis. The other part, that is differentiating culture negative sepsis from non-sepsis, again there is a moderate accuracy of procalcitonin, so it can be used to support your clinical diagnosis. But if procalcitonin does not fall on your side, that is you strongly suspect sepsis and procalcitonin tells you otherwise, then I would say you should believe your clinical judgment.
All right. So the statement from this document is a baseline procalcitonin is required for guiding antibiotic therapy to look at subsequent increase or decrease in levels. Most randomized controlled trials have done a baseline value in suspected sepsis patients and utilize it in procalcitonin-based algorithm to limit the duration of antibiotic therapy. Now, the recommendation is the baseline serum procalcitonin levels may be done in patients with sepsis 1B. 1 means that evidence strong, but the opinion of the experts were equally matched. So it was not a strong recommendation, and that is where we are. So we come to the next part of it, that is, we have already partly discussed the role of procalcitonin in sepsis. The statement is that procalcitonin can diagnose sepsis only with moderate accuracy. And second thing about the cutoff, if you can say, the cutoff values for the diagnosis of sepsis are not well defined and need further clarification. That is the evidence. So the recommendation is procalcitonin alone should not be used for the diagnosis of sepsis 1A. Strong evidence and high level of evidence and the strong recommendation, we suggest that PC be used to differentiate culture negative sepsis from non-sepsis 2B. That means the moderate quality evidence and weaker recommendation. So that is where we are as far as this is concerned. So ultimately, the blood and sputum culture was sent, as Dr. Dhruv suggested. Patient started on ceftriaxone and azithromycin. Supportive treatment continued. Patient weaned off inotropes and oxygen in next 2 days. He had actually pneumonia. Day 6, he was asymptomatic. DLC was normal. Now the next question is, I'll again come to Dr. Dhruv. Should procalcitonin be used for antibiotic de-escalation in sepsis?
So this is one place I will straight away affirmatively say yes. It can help us in cutting down the duration of the antibiotics, and multiple studies have been done, which are showing it that even when you use antibiotics as a procalcitonin, it does not negatively affect in terms of outcome. That means if you use it to reduce the duration of antibiotic, mortality is not increased, point number one. Point number two is now further data has shown up that if you use it for the de-escalation, probably your intensive care days admission and hospital days have also found to be reduced. Therefore, unequivocally today, it has become an important part of antibiotic stewardship program in terms of reducing. So unequivocal answer is yes.
Okay. So Dr. Kapil, I come to you for the next question. That is, what level of procalcitonin should be used for discontinuing or de-escalation of antibiotics in sepsis?
Yeah, sir, I will add into the Professor Dhruv's answer.
Sure.
I was involved in a DINA study which was published in 2020 in ICM. It was a multinational study, and one of the major finding of the DINA study was only 16% of the clinicians try the de-escalation on day 3 and subsequently day 5. And that speaks a lot about if you do not have a algorithm or protocol to de-escalate, then you are in a deep trouble in discontinuation or de-escalation of the antibiotic. So, and that also answers the first question. There has to be the baseline procalcitonin value. Now, during the de-escalation or discontinuation, it will help to know what was your procalcitonin. So, procalcitonin, one value doesn't have any meaning in de-escalation. It has to be done regularly. So, if I have the baseline procalcitonin level, then if my levels are more than 80% showing the downward trending, then I may consider the de-escalation or discontinuation. And there is no specific cutoff value. There are so many evidences available, but there are no specific cutoff value. Few of them 0.25, few of them are 0.5. But what we suggest is less than 0.5 microgram per liter or more than 80% declining values of your baseline procalcitonin. You may consider for your de-escalation and discontinuation, and it should not be the only depends on your biomarker procalcitonin. It should clinically correlate. That means patient should be hemodynamically stable, patient should not have a fever, inotrope should be cut down, output is maintaining, and overall patient is clinically better. I think it's a combination of the biomarker and clinical status which decides your.
I think there is very little controversy regarding use of procalcitonin in using the de-escalation or stopping the antibiotic. The question is, Dr. Srinivas, how often should procalcitonin be repeated? Every 24 hours, every 48 hours, 72 hours? That is the question.
There is a lot of variability in how it is being used in different parts of the world. In healthcare systems where everything is funded and everything is taken care of by the government setup, daily PCT CRPs are being done. But I think the middle pathway is probably doing it at 48 hours, but not later than 72 hours. This is my viewpoint.
All right, that's a very, very precise answer. Dr. YP Singh, what is your take on all these three questions?
Sir, I will second whatever the opinion is given by Dr. Dhruv Chaudhary, Dr. Jirpe, and regarding the duration, definitely it is the 48 hour we do use in our ICU, but not less than, not in any patients who is on a ventilator or a sick. We take it a gap of the 48 hour repetition, but definitely cost is one of the factor, a limiting factor in taking these tests on a regular basis.
Dr. Pavan, what is your take on the cutoff that you take for reducing or de-escalation of antibiotics?
Sir, basically for de-escalation of antibiotics, if we have a baseline value, then you would call for more than 80% decline in the baseline value of procalcitonin along with clinical improvement for de-escalation. If there is no below 0.5 or below 0.25, but most of the guidelines, and we have also recommended based on various studies, that it should be a 0.5, and along with that an 80% decline from baseline. Now, if somebody does not have a baseline value, then in that scenario we have to depend upon the absolute value, that is less than 0.5 nanogram per ml for de-escalation.
All right. So the statement is The PCT-guided treatment reduces the duration of antibiotic therapy and duration of hospital stay in adult critically ill patients with sepsis without any increase or decrease in mortality or increase in mortality. Procalcitonin-based protocols are associated with significant overall hospitalization cost savings. So, the mortality benefit has not been documented, but the duration and quantum of antibiotics reduced. The recommendation is that PCT levels can be used to support the discontinuation or de-escalation of antibiotics in patients with sepsis. That is 2A, that is moderate quality evidence, but the recommendation is strong, as our worthy panelists all have agreed to this utility of procalcitonin. Now the other question is, how often should procalcitonin level be repeated after the baseline value? This opinion has already come, but this guideline said that there is no evidence to suggest the optimal frequency of procalcitonin testing. In various studies, the serum PCT has been tested every 24 to even 72 hours for that matter. And about the level, we have already said that PCT levels may be repeated every 72 hours or earlier if clinically indicated 3B. That means the evidence is very poor, level 3, and even recommendation were not strong. So we are not actually sure. As Dr. Srinivas said, that it depends upon the finances and the availability of funds, availability of laboratory, and so on and so forth. Only further evidence will show. The statement is that there is no evidence to suggest that optimal frequency of procalcitonin testing in various studies. Serum procalcitonin has been tested every 24 to 72 hours. So PCT levels of less than 0.5 nanogram or a drop of more than 80% from baseline be used along with clinical judgment for antibiotic de-escalation. Very little, so everything is quite crystal clear so far. So the next question is, what are the infections in which procalcitonin is not effective biomarker? Dr. Dhruv, you are the first batsman.
See, sir, when you see from where, again, it brings down to the question from where the calcitonin is released. We all know it is thyroid, but we also know that a number of multiple other organs are responsible for, which include your WBC, neutrophils in particular. Also, we see that liver, we also see that pancreas, and so on and so forth, the multiple organs. Therefore, by and large, it has been taken as a marker for the bacterial diseases, particularly more correlation is with pneumonia and some amount with the sepsis. So anything which causes pro-inflammation like trauma, pancreatitis, you may have a falsely elevated levels. Therefore, it's not only infections, but it is equally important to know what condition has caused a severe systemic inflammatory response. As far as coming to your question of infections, first I would say it can be elevated, let's say in scrub typhus. We have been seeing tropical fever syndromes. But the places where it has not been seen to be elevated primarily is either fungal infections or viral infections. That is one thing where we are seeing that dominantly its levels are not there. If you see it in the COVID epidemic, a lot of people used to get it done, and we were finding near normal values and how antibiotics were abused. So in short, primarily viral infections followed by your fungal infection, you will not see it to be elevated. Some amount of elevation is also seen in atypical bacteria, but not to the extent the stimulation which we see with the bacterial infections. So the sensitivity and specificity are much, much lower for atypical bacteria like Legionella or other ones. For the Mycoplasma and Chlamydia, it is not elevated.
So, Dr. Zirpe, your call on.
Almost he covered every list of the viral, fungal, and then some malaria or scrub typhus. But one of the most interesting and important examples, like when you are coming across the insisted type of the infections, like in empyema or tonsillitis or sinusitis, where you may not get the procalcitonin in that
value for helping you for the any decision making. So almost the list he has covered and the reason, nothing to add into that.
Dr. Srinivas, your view?
I agree, sir. I agree that when there is a localized or a walled off infection, PCT may be spuriously low. What I also feel is in a country like ours, to discriminate a tropical infection from a bacterial infection probably is not possible with the use of procalcitonin. How procalcitonin behaves in tropical disease is not very clearly known. So there is variability in its response. So that is a situation where there is a manifestation of sepsis, but your procalcitonin may be absolutely normal.
Thank you. So the statement says that it is inconsistently raised in infection with Legionella, Mycoplasma, and Chlamydia, which are the cause of, especially for community-acquired pneumonia, may be falsely negative in localized bacterial infections like tonsillitis, sinusitis, cystitis, uncomplicated soft tissue infections, abscesses, empyema, may be raised in non-bacterial infections like Dr. Dhruv said, scrub typhus, malaria, variable in candidal infections, and may be negative in aspergillosis and mucormycosis. This is a statement, and the recommendation is that physicians should be aware of where the procalcitonin is not reliable. So your opinion is extremely important. So I go to the next case. Anybody wants to comment anything on this case? Because in the interest of time, I have 3 cases. This was a longer case. So second case is a 45-year-old male, no comorbidities, presented to emergency with fever, cough, purulent expectoration, 1 week, dynamically stable. SpO2 was 90% with a respiratory rate of 24 per minute. Started on oxygen supplementation via face mask. Culture sent, shift to the ICU. And this was X-ray. You can see left side. I do not need to describe X-ray because the subject is different. So the question is, diagnosis is severe CAP. Of course, it is written. So attending physician started on amoxiclav and azithromycin, and calcitonin was sent. Now, this is a case of CAP. Dr. Y.P. Singh, should baseline PCT should be done in this particular situation where you have, you know that it is pneumonia. It is severe pneumonia and patient is requiring ICU care. Does it help you in starting antibiotic initiation? That is the question. Dr. Y.P. Singh.
Sir, am I audible now? Yes, sir.
Yeah.
Regarding the question that initiation of the antimicrobials and the use of the procalcitonin, as we all know that in a surviving sepsis campaign also, they says that we are suspecting a sepsis, which in this case, which the patient is coming with a severe community-acquired pneumonia to the ICU. The one has to send the culture reports, one has to initiate the empirical antimicrobial therapy based on the epidemiology and the clinical history. In this case, as it already been started. And the procalcitonin need to be sent, but remember, the procalcitonin is not one of the limiting factor. It is only on the clinical basis, and you need to take your call to initiate a microbial therapy. So measurement of the procalcitonin basically helps, as we already discussed in the past in a couple of the questions. My answer is this: to empirical initiation, one has to go with your timing is more important, and one should not hold the antimicrobial therapy just because of the other investigations, in the waiting of the other investigation, including your cultural sensitivity. What we follow.
Thank you. That's crystal clear answer, Dr. Singh. So, Dr. Pavan, what is the utility and optimal timing for measurement of PCT in this particular scenario when patient has CAP? And you can discuss moderate CAP and severe CAP at the same time.
So basically the utility here in patients of moderate CAP and severe CAP, so anybody who is admitted to hospital or somebody who requires intensive care for his management. Again, the initiation of antibiotics is based on clinical judgment and epidemiologic data as stated by the earlier speaker. So the utility of procalcitonin here is basically again that you'll have a baseline value, and that can be used for your de-escalation decisions later on. The optimal timing, again, if we decide to do procalcitonin, is basically at admission, so that we have a baseline value. Usually, studies and even practically, you have a baseline procalcitonin value within 24 hours of admission in the hospital or in the ICU.
So, do you, Dr. Tiwari, feel that patient who have mild to moderate pneumonia, who is not requiring ICU care, and is not in hypotension, is not requiring oxygen, but he has lobar pneumonia, should we do PCT on the first day or wait for some time? It's a cost factor, you know.
So, sir, basically, if we do a baseline procalcitonin, the only benefit is that we can use this value for earlier de-escalation. Let's say if we were to give antibiotics for a guideline designated duration, that is 5 to 7 days of antibiotics in mild to moderate cap, then probably baseline procalcitonin will not help in the non-critical cases. But if we were to de-escalate earlier, that is before the standard guideline-based de-escalation duration, that is 5-day duration of antibiotics or earlier, then probably we can use this clinical improvement along with the baseline procalcitonin can be used to look at that 80% decline from baseline. Then it can help in shortening the duration of antibiotics.
So this is a little contentious because, you know, one is that atypical organisms cause a significant proportion of pneumonia. As we understand, viral pneumonias are common. We have seen in COVID. And after all, procalcitonin is an expensive investigation. So I come to Dr. Dhruv. What is your take on mild to moderate pneumonia?
See, sir, yes, sir. Sir, by and large, in mild to moderate pneumonia in the clinical practice, we are not as much using this thing. And we are, by and large, going with the practice perspective, I'm saying, with the clinical profiling, because radiology can take a little longer to resolve. But when things start doing it, we usually, in the low respiratory tract infection, but yes, when we are in a doubt, or when we are seeing a relatively patient not responding, then we usually tend to go with the procalcitonin level for two reasons to decide about it, because at that particular point of time, we just seeing it, whether the infection is resolving or not. And again, a single value may not be of a value, then we repeat 48 to 72 hours, looking at the half-life of the procalcitonin. So that's how we are practicing, honestly speaking.
So the statement says that baseline PCT levels have not been consistently shown to reduce antibiotic exposure in community-acquired lower respiratory tract infections. Most guidelines recommend against withholding antibiotics in LRTI or CAP based on baseline. So everybody agrees that they have no value in as far as the initiation or withholding the antibiotic. The recommendation is that baseline PCT level alone should not be used to withhold empiric antibiotic therapy, that in CAP and LRTI 1A. And based on clinical judgment, prompt initiation of optimal empiric antibiotic therapy is recommended, including that in CAP. Both are 1A. So there is no ambiguity about it. So we'll not spend much time on that and go ahead with the next question. What is the utility of optimal timing of measurement of procalcitonin of antibiotic administration in CAP and other LRTI? Partly this question is answered, but there are a lot of ambiguities seems to be there, because do it in the first 6 hours or do it in 24 hours, especially in the moderate CAP. I'm not sure. Dr. Zirpe, what is your take on this question?
We are not using procalcitonin to decide or initiate the antibiotic even in a severe CAP. It is a clinical judgment. We should not wait. So, but I need the baseline procalcitonin value. So I will send it within the first 24 hours to know my baseline value, and then later on I can use it for the de-escalation. That's what I will suggest in community-acquired pneumonia.
So in patients with community-acquired pneumonia, baseline procalcitonin alone has limited utility in clinical decision-making regarding initiation of antibiotics in clinical trials. PCT measurements have been performed at randomization or emergency or hospital admission. So recommendations should not be routinely measured for initiations of antibiotics. Everybody agrees that and can be obtained in severe CAP for subsequent de-escalation. The question is severe. So if indicated, baseline PCT should be measured the beginning. So that is now the last question in this: can PCT level be used to differentiate between viral and bacterial etiology in CAP? Dr. Dhruv has partly answered. I come to Dr. YP Singh. Suppose the procalcitonin is 0.5 versus 2.5. Do you discriminate between viral and bacterial pneumonia? Or it is, let me put it as 10 and 0.5. Dr. YP.
So regarding the procalcitonin level in between these two etiologies, the viral against the bacterial, again, as we have already been discussed, it is a more of a clinical kind, your examination, history taking clinical examination, your labs, they gives you a fair idea on that. But as far as procalcitonin is concerned, if the patient if patient is coming to the ICU, am I audible now? If the patient is to the ICU, I consider it to be in a severe form because patient is not able to maintain the vitals. Hence, patient shifted to the ICU. So in that case, obviously, as routinely, what we do here, we send a PCT on arrival, a patient from the casualty triage in ICU. We initiate our therapy, antimicrobial therapy for the patient, but definitely the clinical examination, primarily going to the detail, looking into the different labs, give you a fair idea between the viral and the bacterial infection.
So, Dr. Tiwari, your call on that. PCT 10 versus 0.25.
So, sir, definitely low PCT will probably rule out infection with typical bacteria, or it will be very highly sensitive for ruling out infection with typical bacteria, particularly gram-negative bacilli. But if we talk about low PCT ruling out viral versus what we call atypical bacterial infection, then PCT is not a good marker to differentiate between a viral infection and the atypical bacterial infection. And again, a low PCT will not rule out a gram-positive bacterial infection also, though 0.25 is kind of very low. But it can anyway not rule out a atypical bacterial infection. So again, in that scenario, we will have to give antibiotics which cover for atypical bacteria.
So higher PCT levels are strongly associated with typical bacterial infection. Baseline PCT levels have varied sensitivity in differentiating. Varying sensitivity differentiate bacterial and viral CAP. There are currently no established threshold values. So this is the final. So this is what the recommendation is. Should not use to differentiate bacterial from viral etiology. The last case is So patient improved 5 days, culture negative, and oral route of administration antibiotic initiated. Should PCT be used to determine duration of antibiotic therapy? That is a question. And patient, now he goes into complications. I have to go a little faster. And he required HFNC. His procalcitonin was 1.2. He developed hospital-acquired pneumonia. He was initiated on piptazo and levofloxacin. Supportive treatment was continued. Patient showed clinical. In this case, should it have been wise to use procalcitonin levels beside antibiotic initiation? And how should PCTB levels to be repeated after baseline and HEP and WEP? So, Dr. Srinivas, quick answer from you.
Yeah.
Use of PCT in HEP and WEP.
How often? I think if there has been a clinical deterioration for a patient whose oxygen requirements have gone up or his lung compliance has reduced, maybe every day is something I will do because sometimes there may be a lag between the clinical manifestations, radiological and biochemical manifestations. So in a situation where a recovering patient has an issue of suspicion of HAP and VAP, maybe daily procalcitonin may not be off the risk.
Okay. Dr. Zirbay, your quick opinion, two-line opinion on this.
What was the question, sir? Sorry.
Use of PCT for HEP and WEP.
I think the answer will be same what we are discussing up till now. It should not be use it for the diagnosis as well as the initiation of antibiotic. We can use it for the baseline value. We should do and follow for the de-escalation in a due course after 72 hours.
All right. So in the interest of time, I'll not read that. Everybody seems to be in agreement, and it grew Pseudomonas, patient improved clinically. Treating team repeated PCT on day 8. Serum PCT was 0.4. Should PCT be used de-escalation of antibiotics, and what cutoff should be used for HEP and WEP? And this has been answered with the guidelines. The procalcitonin should be used as a part of antibiotic stewardship program for antibiotic de-escalation in patients with HEP. And if the patient requires antibiotics beyond the 7 days, this has been given in our antibiotic guideline also. And 80 to 90% reduction from the baseline has been accepted by all, or less than 0.25 or 0.5 has been. So these are the recommendations. Final case, only 2 minutes. 43 years old male, chronic alcoholic, diagnosed with chronic liver disease with portal hypertension, presented with complaints of fever, diffuse abdominal pain, vomiting, and altered sensorium. BP 90/50, ascitic fluid showed the polymorphonuclear leukocyte more than 650. Gram-positive GNB, the diagnosis of CLD with spontaneous bacterial peritonitis and septic shock made. The question is, which I am asking Dr. YP Singh, is what is the utility of PCT in infections among patients with in SBP? Dr. YP. Is there, Dr. YP Singh?
So regarding the procalcitonin, as we have mentioned, irrespective whether we are dealing with the pulmonary infection, we are dealing with the HEP or WEP, the another part, and then looking into the abdomen. So first and foremost part is that it is the clinical, your judgment and your diagnosis which basically makes. But definitely regarding the severity part is concerned, procalcitonin has its role in this part of, infection. So this is my take on that.
So the PCT has been used to diagnose SBP with various sensitivity and specificity. PT has been used for prediction of risk of septic shock and mortality among patients with secondary peritonitis. The PCT guided antibiotic therapy leads to reduction in antibiotic use and hospital stay without any adverse effect in secondary peritonitis. So recommendation is PCT alone should not be used for diagnosis of SBP. PCT may be considered for diagnosis of SBP in combination with clinical features, and PCT can be used for risk stratification among patients with secondary peritonitis. We recommend use of PCT for guiding antibiotic therapy among patients with severe secondary peritonitis. So this was all about what I could cover, and I'll request 30 seconds. Please, you give your final opinion, Dr. Dhruv. 30 seconds. Please unmute yourself.
Sir, biomarkers cannot be a replacement for the clinical judgment, but yes, together they can help us making a more precise management and can be used as a tool for antibiotic stewardship. That's my overall take on this.
Dr. Zirpe.
I agree with Dhruv, sir.
Dr. Srinivas, unmute yourself, please.
Yes, a procalcitonin can never be a substitute for clinical judgment and the hardcore signs of sepsis and septic shock. It is an adjuvant, but it is a powerful tool to aid in optimization of your antimicrobial stewardship program.
Dr. YP Singh.
It is the same, sir. As I said that we are discussing so far that procalcitonin is basically more giving an emphasis for the deciding about the duration and the de-escalation of the antimicrobial therapy. And it should be incorporated as a part of the antimicrobial stewardship in any of the institution.
Dr. Pawan Tiwari.
The most important message should be that procalcitonin levels should not be used to deprive any sick or severe patient empiric and immediate antibiotic therapy. The next thing is that procalcitonin should be used as a part of antibiotic stewardship program.
So, ladies and gentlemen, I have a pleasure of thanking our society, Indian Society of Critical Care Medicine, for promoting academic activity, and this is part of the academic activity. And my immense gratitude to all the participants of this who framed these guidelines. Big thank you to all panelists who actually gave their words of wisdom. And also thank you to Mr. Thermo Fisher, who actually supported the logistics of this meeting. And thank you very much, and have a good day.
Thank you.
Thank you, sir. Thank you for moderating this session with a very important topic about procalcitonin. There's a question in the chat box for Dhruv Chaudhary, sir. Do procalcitonin levels vary with acute kidney injury? Yes, they do vary because of the metabolism, and it itself will be on the higher side. But it can be used for diagnosing sepsis depending upon the serial levels. And as rightly said in the panel discussion about the clinical judgment and clinical scenario, whether it is 2, 10 or 15, depending upon that, we can go ahead to use the procalcitonin level for diagnosing sepsis. Any panel concern to add about this comment, sir? Okay, moving ahead, we'll go ahead for the next session, that is about utility of multiplex respiratory panel PCR in antibiotic selection for VAP. We all know, as we are facing many bacterial infections and many resistant pattern for the infections, and choosing a right antibiotic after knowing the organism is going to impact on the whole for the patient's clinical scenario vis-a-vis the impact on the cost factors. So let's move on to the next panel discussion. For that, for moderating the session, I invite Dr. Kapil Zirpe, sir, who is the Director of Neurotrauma Unit at Rubyal Clinic, Pune, and Professor Dhruv Chaudhary, sir, Dr. Ravindra Mehta, who is a consultant at Apollo Hospitals, Bangalore, and Dr. Camila Rodriguez, as a consultant at PD Hinduja Hospital and Medical Research Center, and Professor Dr. Pradeep Kumar Bhattacharya, sir, who is the head of the department at RIMS Ranchi, and elected president for the ISCM. Over to you, sir.
Hi, hello everyone. Good afternoon. And myself is Dr. Zirpe. I'm from Rubyal Clinic, Pune, and I'm the moderator for today's very interesting, I will say very interesting topic for the discussion, multiplex PCR system for the rapid diagnosis of respiratory viral infection. And with me, there is an eminent panel for giving their opinion and sharing their expertise with us. We have Dr. Pradeep Kumar Bhattacharya. He is president-elect for the Indian Society of Critical Care Medicine. He is a professor and he's from the Ranchi, and I'm sure he's going to add his views in perspective of the viral infection diagnosis and what's their role in a day-to-day clinical practice. We have Professor Dhruv Chaudhary. He's a past president of Indian Society of Critical Care Medicine, and he's a professor of chest, pulmonary and critical care medicine. And I don't think he needs more introduction because we are going to listen him quite well. Then we have Dr. Camila Rodriguez. She's a head of the microbiology from the Hinduja Hospital, and she's one of the most experienced microbiologists and very much connected with the clinician, I will say. And that's what we'll try to get the more and more clinical application of the microbiology part of our system. And we have Dr. Ravindra Mehta. He's from Bangalore. He's a chest medicine professor, and he will also add into the discussion. So without wasting time, we'll start our discussion. Now, all of us know that viral infection, this is a particular season from July to October, we'll get all sorts of viral infection. And just recently we came out of the global COVID hit, and we just, there is a sigh of relief that we are coming out of the COVID. There are admissions are less, and we are entering into the non-COVID. But I don't think we are relaxed. We are overburdened with the most of the viral infection. The H1N1 swine flu is hitting back, and there are so many viral infection. I'm sure in future also we are going to have more and more viral infection challenges. If you see the viral culture, which is a gold standard for detection of the respiratory viruses, but again, it's a very slow and labor intensive and requires the specialized expertise. So we need something which which will give us a quick diagnosis and relief to the clinician for the early control of such endemics, pandemic, as well as the this overload during the peak time. Rapid antigen detection methods are faster, but generally they are missing with the low sensitivity. That's what the COVID is again the same, like we do the rapid antigen, but only 50% of the time we get the positivity with the rapid antigen. Again, though they are less labor intensive, but again they are time consuming, and we have the problem with the sensitivity. Now, multiplex molecular assays, which are generally detects the viral infection from the nucleic acid based test, they give us the prompt results, and they're nowadays becoming more and more popular. I will not say popular; they have their place in day-to-day practice in during such peaks of the respiratory infection, and their sensitivity and specificity is definitely of concern to select which one and why, and that's what we are going to discuss next 25 minutes. But the problem will be again cost, availability. So we cannot apply it or advise it at the every level, whether you should have this type of the diagnostic testing or you should get facility ability. So let's see what our experts add into our knowledge. Now the first question is straight away to the our madam microbiologist. This is again, this is very familiar question. Everybody would like to know what viruses do the PCR based panel detect. Like if I need to communicate with my microbiologist or my lab person, what viruses I need to ask them or to request them, I need this type of the this virus list into cover in your diagnosis. And the terminology like laboratory developed tests, like few hospitals or institutes are developing their own PCR panels which are cost effective and which are selected by those hospitals on the basis of their development. So what's your opinion regarding both, like what viruses we generally cover and what are their advantage, and how we can select which one to go for in your institute? Madam, please.
Thanks, Kapil. Basically, when you look at the viruses for PCR-based panels, most of them are detecting 5 groups. One would be influenza group, the coronaviruses. In addition, so usually there are 4 corona, which we are used to, plus SARS-CoV is another coronavirus. So 5 corona, usually influenza would be A, B, H1N1, H3N2, etc. Then there's respiratory syncytial virus, para-influenza viruses, and adeno. So these are the 5 usual groups that they detect. Also, if optional, are rhino, human metapneumo, and BOCA. So most of these are covered in multiplex PCRs that we are doing because the clinical signs and symptoms of respiratory tract infection, unfortunately, are not pathogen specific, as we all know. And multiplex PCRs essentially match the sequence of multiple targets that are there. The second question you asked me was, what are lab-developed tests? Now, lab-developed tests are offered by a hospital lab. They have been designed, they've been manufactured and sort of used within the hospital lab. Usually, they are in-house, they are much cheaper, but the downside is that they are not FDA approved. So when you have a lab-developed test, you need to have the lab needs to do 4 basic methods to validate that test. They need to have a limit of detection, you need to have accuracy, you need to have precision, and you need to know what is the analytical specificity. So it's much cheaper. And actually, for example, in this particular time when COVID, H1N1 was actually replacing COVID to an extent, we found we actually had to develop our own in-house, which was really a quarter the rate of the multiplex panels that are available. So you need to know the flavor of the month or the season so that you can quickly home in. And we developed a H1N1 with COVID, which was easy to do. And that was our lab developed test. We also, I mean, the conventional platforms all of us know are really excellent in the sense they have such rigorous testing in terms of quality control. They're usually approved by, regulatory bodies such as WHO, such as FDA, such as the CE. And they also give you a assurance that their quality control is really up to the mark. They have extraction control, they have calibration control, and they're all inbuilt. So, like you asked me, lab tests, you have to make sure that all these controls are being done regularly and they are inbuilt into the system. And
Madam, sorry to interrupt you. What you will guide us. So we know that we are resource limited country, and that's the fact. It's not possible for except the tertiary care centers or those corporate hospitals who can afford. They can very well go through whichever the available PCR multiplex techniques. But then, if suppose they are, like you mentioned, they are reducing your cost burden by almost quarter or 50% of this thing during the peak days like these three. And I know that in Pune just now H1N1 is rampant, so I can make them more comfortable. I just want these 5 viruses in that panel. So how you will advise for all of us how we should select and how to go ahead with selecting the panels?
Basically, we need to have a pre-test probability. We need to know that this patient possibly fits the bill of, say, H1N1. The epidemiology needs to be in place. For example, when we realized early June that we were getting much more H1N1, we quickly bought in a test that was targeting H1N1 and SARS-CoV-2, which was literally, I think, 2,000-3,000 rupees compared to, the panels that, believe me, they're really good. And if you cannot develop an in-house panel, at least go for FDA or CE single test validated, depending on the epidemiology that you are currently seeing at that point in time. So you don't have to worry about what the lab develops. You can actually get kits that are single plex or dual plex, so those are available now. And, then you needn't waste money because, whatever anybody says, money is a huge concern that our poor patients are paying or the hospital is paying or the government is paying.
Yeah.
So we have to keep that in mind. And to be honest, picking up, how are we going to handle that further on in the talk? But I think knowing what is actionable is really important.
Yeah, I agree, and that's what the point of discussion, that it is possible. It is possible to have your laboratory developed tests. They are cheaper. They are easily developed. You need to know your epidemiology and just develop it. Just go ahead. It is possible. That's what the message I would like to convey through Madam to everyone. Now, moving to the next thing, I think Professor Ravi Mehta is around. Dr. Mehta, you are around? Hello?
Yeah, I am there, Kapil.
Yeah. So the next question now, after the diagnosis and after the how to select which panel, the frequently asked question again, how long does the test remain positive after the infection? Because even during the counseling, the relatives ask after the 8 days, is virus is active or is still my patient has a H1N1 infection? And then if we do the test on the request, it comes positive, but clinically patients are better. So how to explain this phenomena? And is there whether it is related with whether the presence of the nucleic acid which gives you the positivity, does it mean that virus is still viable? Because it is related with the treatment part also. Like for example, if suppose someone comes to me with the OPD and diagnosis of the H1N1, I started on a Tamiflu and after 5 days he's clinically better, I would like to omit it. But he somehow repeat the test and he says, doctor, still my test is positive. Why you are so early to withdraw the treatment?
Right. So the question is very relevant because when you enter the realm of a test, you need to know when to exit also. And this exit part is still a problem from the understanding and the treatment point of view. A lot of this data obviously came from COVID-19, and the extrapolating to other viruses has been part of looking at the few studies which have been done. So I think a lot on the scientific front, it's a question of the virus itself, the viral load, what is the extent of infection. Then the second part of it is the host defenses, that how much time does the host take to clear it. And third is persistence of a signal, which is maybe reflecting an inactive or a dead virus, but it stays over there because of the sensitivity of the test. So host factors, viral factors, and test factors all play a role in this particular quandary. And the data unfortunately goes to a level where it makes it more confusing than clear, because these tests can be positive up to 90 days. And this is from literature. On a personal experience, when we looked at COVID and we did a fair amount of bronchoscopy in COVID, once the fear went away, we could find Lavad signals up to 65 to 70 days, BL signals. So whether the virus is sitting in the upper respiratory tract, it's sitting in the lower respiratory tract, is this signal actually relevant? And as you said, does it actually mean an infective virus? All those are questions which come to mind. So the short answer is that it can remain positive for long, especially in the immune compromised people and those who don't clear it. Most now we believe that with the studies done for actual viral loads assessed in these patients, most of them are substantiating that it is inactive or non-infective or dead virus, so not to worry about. So on a practical front, still the isolation / infectivity guidelines will go on general stuff like such as X, Y, and Z depending on the virus. So this is the way it is. These tests typically represent what we're going to face with highly sensitive tests, which actually give us a great signal in the beginning, but we don't have a great exit strategy, and a lot of clinical judgment needs to be exercised to interpret the positivity after long durations of time.
Yeah, Ravi, though it's a very straightforward and simple answer is that it may remain positive, but not necessarily the virus is infected. I came across recently the VVIP person who is a comorbid 80-year plus, and his COVID was positive still after 2 months, and he was supposed to undergo the laminectomy. And the question is, shall we take that risk of this thing? So finally, we advise the viral cultures, but again, it will be the time consuming. So this is practically very relevant. The virus may remain dead and still you can get the positive test, but the infectivity is lost. But my question is, okay, he is not infective. Does he fit for any procedure, or does he fit for any major operation?
So I think if we talk of COVID in particular, because before that we never cared about it, right? We never really bothered about flu, H1N1 and clearing for surgery. After a certain time, 7-10 days, they were fine. And they had to go through something, they had to go through it. When it comes to COVID, I think post-vaccination, this entire original thing of outcomes being bad for procedure and surgery is totally revisited, I think, at this point. So on an average duration, if they're clinically non-infective, on a further testing front, if they have at least the basic marker CRP is coming down, they are reasonably vaccinated, then anytime after 7 to 10 days, we're saying go ahead and do surgeries depending on the surgical requirement. Obviously, elective surgeries will get deferred to 2 weeks, but something which is semi-elective.
So you will prefer the CRP and the infective marker versus viral culture in such cases for the major surgery?
Yeah, so currently what I can tell you is what is gone. Certainly this IL-6 and all that stuff is gone. D-dimer is something which you should most of the time not look at only, is what I would say, and my colleagues can comment on it. A declining CRP is desirable before you clear for procedure. And that too depends on the procedure. Endoscopy, bronchoscopy, we don't worry so much. It's clearly about a cut procedure where there is an inflammatory reaction of the body. You don't want to test the waters till we know more. But definitely, original fear of 4 weeks, 6 weeks, 8 weeks, I think is now consigned to history.
Okay. Roderick, madam, you'd like to add anything? It only gives a positive test. It doesn't differentiate in between the live and the dead virus.
Absolutely. I couldn't agree more. And I think now we ourselves are trying to sort of revisit this question. When we, from a perspective of surgical prophylaxis, for pre-surgery screening, we have decided that since we must do a test, let's do a slightly less sensitive test. And we are, from Monday onwards, we're going to go just for RAT. In patients who come for screening, and a RAT, knowing its imperfect sensitivity, should be fine to rule out patients who are really infected and are asymptomatic.
Yeah, that's what the UK guidelines also. UK follows the same. They do the only RAT now for the pre-operative or anything if they would like to know. So we'll move further. The third question, Pradeep, is to you. What is the clinical significance of these results? How you look at, if you get your registrar will give you the report that this virus is positive, this virus is negative, and how you will judge clinically. What is clinical significance? Sometimes they are positive, false positive. Sometimes they are too many viruses are positive.
Kapil, because as we all of us are discussing that they are very sensitive and give high level of positivity comes with this biofire testing. So as a clinician, I think we must keep in mind that syndromic testing that definitely allows the clinicians to rapidly diagnose whatever organism the patient is suffering from. But you have to keep in mind that you are using it properly. First thing is that a proper use, and second thing is correct interpretation of the result in the context of the patient's clinical condition. And the third important thing which I would like to say that we should avoid overuse of these testing, because as a clinician, we should always keep in mind the patient's clinical condition. That is more important rather than 100% believing on diagnostic, because again, any diagnostic testing, what you are doing, that also needs some kind of a stewardship. So these 3-4 important things, if we keep on mind, I think BioFire is a very, very good asset as far as management of patients who are suffering from different kind of disease and diagnosis of different organisms are concerned.
Yeah, well said, Pradeep. Pradeep, what I mean to say, sometimes what happens, patients are clinically absolute fine. They're in the ward or they are in an emergency, and your viral panel is positive. So not necessary every that positive results suggest that it's active infection. Might be it is a dead virus, what we discuss, or sometimes it is a suboptimal infection. No need to treat that. Second thing, false positivity is inevitably there is a one virus will come positive. Not necessarily you should correlate clinically. Like I still know that in 2019 February, one of the viral panels says coronavirus positive. At that time it was not there. Nobody was aware. So it's a routine seasonal coronavirus. Not necessarily it is a SARS-CoV this thing. So I retrospectively start at that time we never thought okay, this was patient is all right. So okay, this is one of the virus and clinically no need to significant. So there are so many things with the viral panel we need to keep it back of mind. False positive doesn't indicate it's a viral active, not necessarily it is active infection. False positivity is just there. Out of 10 might be one virus will come positive. You need to see whether that virus is really significant in your clinical practice, and not necessarily your panel will cover whatever the viruses you are targeting. Sometimes your panel is not listed that virus, and that virus is typically positive. So you need to keep a high suspicious of index and correlate clinically. So with this, we'll move to the next question to the Dhruv. Dhruv, is the positive result is indicative of the current active infection? And does it rule out the possibility of the another concomitant infection or superinfection? Now it's a very tricky and a very clinical, and you are the only right person to answer this, being a chest physician and working in wards and ICUs.
Thank you, Kapil. First of all, I think what I will start this answer, what Dr. Bhattacharya said, and you summarized it. One, we must remember when we are talking about what we mean by current active infection. Now, when you are looking at the respiratory virus panels which are coming out, one thing which is very important is they're not talking about bacteria. And when you look in terms of concomitant infections, especially in the setting of influenza, a lot of bacterial superinfections can be there, which can be, if we are only using respiratory viral panel, we can miss. That is point number one. Second point, which is important, is that sometimes disease may not itself present. As you know it, patients may have an acute exacerbation of asthma. They may have an acute exacerbation of obstructive pulmonary disease. Or what we have seen this time is patients may not be, but the underlying chronic disease has become destabilized and it has become decompensated. Therefore, they can present in multiple ways. And at that, if person is symptomatic and is acutely worsened of any of the condition, and then the virus comes positive, For me, probably it is related to that, unless and until I have any other factor to explain. So I think that will answer to you one. Second is the question of timing of sampling and the quality of sampling. They two are also very, very important. If you do, let's say person has become asymptomatic and then you are trying to do, it could be obviously we are looking at the molecular fingerprints. The molecular fingerprints may stay positive, and depending upon the type of testing you are using, like COVID classical example, if you used to use with the RT-PCRs, initially we have a 35 cycles, then we used to say 40. But if you go with a gene expert testing for the COVID, it used to be 45 and it's negative here and a positive there. I think that is again an important thing. And a lot of people will continue to harbor infections, which are the positivity. Ideal would be a viral culture, which is easy theoretically to talk than practically to do. So clinical plus these asymptomatic are the people. And commonly in adults, at least, we see these things with the, sometimes with the rhinoviruses. Boca is again, which is very commonly seen. And also we can see with the rhinoviruses, though we can't differentiate all the time between rhino and adeno. So depending upon the type of virus which is there, but answer to your question of a superinfection is that bacterials are not there, especially in the setting of influenza. Giving you again an example, we had a VIP's brother brought to us with a pneumonia. We did a biofire panel. Within 2 hours, we knew he had an influenza A, and along with it, he had a staphylococcal infection. But there, that panel was of a pneumonia panel. That was not of an upper respiratory viral panel. And finally, we need to know, sometimes there is a probability of these things staying there. So we do not know. Presence we know, we don't know the quantitatively how much is the amount. Because whether it's a colonizer, it just stays sitting out there as asymptomatic versus this becomes difficult. But yes, bacterial superinfections, if we are only using respiratory panel of this thing, can be missed. And again, one of the data which has been shown in a study, they had 108 cases, we followed it up to 1 year. Even in symptomatic cases, in 50% they missed it. Therefore, correlate clinically, but if you are not finding, you are very sure of the infection, you recheck it. If again it is a negative, then I will definitely lower and go for the bacterial thing. But answer to your question is, it is the clinical context which we need to see and look at it. And symptomatic cases can be negative in spite of their high sensitivity. Therefore, be careful.
You have touched almost every aspect of the clinical practice. Like first thing, how sample is collected. What the time of the sampling, what method you are using, the sensitivity specificity. Then not necessarily your virus is positive doesn't mean that there is a concomitant bacterial infection. Though it is a viral panel discussion, we need to know that most of the time there is a mixed type of the infection. There is a super added or super infection is always there with the bacteria. We need to know that this viral infection may not pick up. You need to have another diagnostic method to get your that bacterial panel, and you need to adjust your antibiotic and antiviral accordingly. I think that's what the this question to you and your answer was absolute to the
What
point.
it is helping us is, Dr. Kapil, is that it is helping us in cutting down unnecessary antibiotics which is being written.
Yes, yes.
The flip side is the cost. That is why people are going from the biofire, which is expensive. Gene expert is relatively cheaper to that. That's why they are going with the inbuilt house testings to cut down the cost.
No, even the first question where we were selecting the which multiplex PCR panel, few panels require the preparations and few doesn't require. One should know that. Otherwise, your sampling may be not the adequate sample or the right sample, and which may divert you from the actual infection. So one need to know everything about such tests and then utilize in a clinical practice. And that's what the purpose of the today's discussion. So we are coming to the end of this panel discussion. I would like to have quick bites from all our 4 panelists regarding how you look at this respiratory viral panel in your day-to-day practice. Is it worth to have? Is it practical? Or you will take it with the very selective group of the patients, or your advice will be something different? We'll start with the Pradeep, then Dhruv, then Kamila Madam, and then Ravi.
Kapil, because now it is time of summation, I'd like to say that laboratories must implement strict measures to ensure that these all syndromic panels are being used responsibly through optimal clinicians ordering practices. First thing. Second thing is that prohibit somehow the repeat testing should not make it a money-making machine. And continuous education of the clinician on assays is useful for limiting and doing this test on regular basis. And the fourth important thing is that diagnostic stewardship is our best hope to maximize the benefit of this syndromic approach.
Dhruv?
You see, I'm using it quite often in my clinical practice, more so both to get three answers. First answer is when we start looking at it, a particular, like people start coming upper respiratory infections, or people start coming with the running nose, or people start coming with the increased incidence of pneumonia. I need to know what it is causing. Is it simply COVID? It is influenza or something else? I think to begin with, as part, unless if you are not doing an epidemiological surveillance, it is very, very important for us, A. Second is that because certain drugs, like if I get an influenza, I know I have a medicine available with me, I can treat them, preferably within 48 to 72 hours, and I can cut down the antibiotics to begin with. Therefore, that is the second thing. It can help me deciding antivirals. Similarly, if I have an adenovirus, I again have a pseudosovir available with us. So drugs are available. If I get a person has got a COVID today, and all data, we did it in the Delta also, and I'm very happy that ultimately data has proven that early use of antiviral probably is far more happier in 3 to 4 days rather than using it later on. And finally, where we are using in the intensive case settings is when patients are come to us with the pneumonia and past history of a little viral infection. So it defines which epidemic we are dealing with. As you are talking in terms of Pune H1N1, you're again seeing it. Influenza, you are again seeing it. So we need to shift gears in terms of management, shift gears in terms of public health responses. So it is helping me out in that, in terms of making early diagnosis, management, avoiding antibiotics where it is there, and also as a health planner, policy maker, taking up the policy decisions. So that way it is helping us comprehensively. But yes, I do agree, they need to be used judiciously. And we are very clear on the lab that not every resident writes it. It needs to be certified.
So, Dhruv, just to add to the I will ask the very quick question. Is it the all throughout year phenomena or seasonal?
No. It again, you see, if you see the viral infections, clinically how we used to diagnose syndrome plus multiple people coming up in and then disappearing. So commonly it is a seasonal thing which we are seeing, except in the case of COVID. Even in the COVID also, you will see peak and troughs going on and endemicity is there. But by and large, usually it is a seasonal phenomenon.
Agree. Madam.
I would look at efficacy 5 ways. One is technical efficacy. Clearly, these have got a better turnaround time. I'd look at diagnostic efficacy, look at, actually being able to diagnose the virus and limiting additional tests. I would look at therapeutic efficacy by allowing to change to appropriate antivirals once we know, for example, if it's influenza, whether the need for Tamiflu could be assessed. And from the therapeutic efficacy, I would also look at limiting or instituting infection control processes in the hospital, depending on what we do. And I would look at outcome efficacy, look at length of stay. At this point, I don't know whether in India, correctly, we can address this in terms of the cost. And lastly, I would look at societal efficacy. So basically 5 efficacies is what I would address in these. And I think that's it.
Perfect. Ravi.
Yeah, so to wind up in a very interesting fashion, first of all, it's clinically, I think it's excellent science. You really enjoyed it because this world of virology was alien to us until this all started. So on a pure sense, it makes a lot of sense. As diagnosticians, we want to know both for accurate diagnosis and to limit therapy, which has been brought out. Thirdly is the fishnet approach. The fact is that when people come in sick, and some of these have got both bacterial and viral components, you're actually in a position to not only figure out which one is there, sometimes they can be confusing, but a lot of the times very helpful. And the same time set the stage for resistance in the bacterial spectrum. But it's a fishnet you're throwing because ultimately clinical care is not pure and we have all these issues. Fourthly, the specific subsets which benefit are these immunocompromised folks. The immunocompromised folks, really you need focused therapy. You cannot throw everything from pneumocystis to CMV at them. And so these panels combined with other appropriate tests help us to cone down therapy and impact on outcome, if nothing else, prognosticate them. And then other complex subsets such as recurrent pneumonias and so on, it helps to put things into perspective. The flip side is what we talked about, a science in evolution. Costing is an issue. We still need to figure out the right subsets, and we need to put them in the right clinical perspective. But indeed, provocative science, which is making a lot of sense in the right subset, in the right patients.
Yeah, I would like to continue this discussion for another half an hour, but the timelines are not allowing us.
Kapil, I'm very happy that probably what Dr. Camilla said and what I was saying, there was a lot of commonality actually. That's how we are looking at it.
Yeah.
And
That's what I'm trying to summarize, Dhruv. What I gain it from this discussion is that, yes, there is a place of the respiratory virus panel in your day-to-day practice. Maybe it's a seasonal. Like viruses and the bacteria are becoming more smart and smarter. Why can't we apply those smartness in our day-to-day practice? These panels are not helping us to select the or diagnose the particular virus, but they are more helping you to cut down your antibiotic, cut down your additional investigation. Cutting down might be the some days in a ICU and a hospital, and it itself is resulting into the cost-effective affair rather than seeing the only cost of the that particular test. So there are so many aspects of this thing. And the last part I really like from the Dr. Ravi is that we need to target those immunocompromised patients. We cannot offer them the 10 antibiotic and the 10 viral infections or antivirals and just hoping that something will this thing. If we are able to diagnose, yes, it was H1N1, then naturally you can cut down the rest of the 9. So I think every one of us is gained by this discussion, and might be next time we will request the organizers to get another 15 minutes extra to sum up in a very good manner. So I take this opportunity to thank all of you, and really I appreciate your time and your expertise and your knowledge
Thank
too.
you.
Thank you.
Thank
Thank you. Thank you.
Thank you.
Thank you, sir. Thanks for an energetic discussion, and thanks for putting the inputs about the rightly use for the time. Moving ahead about the investigative parts, I would invite Dr. Sachin Gupta for enlightening us on biomarkers about the past, present, and future. Dr. Sachin Gupta is care at Narayana Super Specialty Hospital in Gurugram. Over to you, sir.
Today I would be speaking on biomarkers, past, present, and what are the future ones that we are looking at. We all know that sepsis is a life-threatening organ dysfunction, and this is caused by dysregulated host response infection. Roughly, there are 30 million cases of sepsis which are occurring almost every year. And 1 out of every 17 patients in the hospital has sepsis. And when we talk about ICU patients, almost 25% patients will contract sepsis during their course of illness, and roughly 50% of these patients will not make it at the end of the day. So this is the gravity of sepsis that we are talking about. When we talk about sepsis, remember, every 3 to 4 seconds, someone would be dying because of a septic insult. And so we need to detect this very difficult to treat illness, or I would say very difficult to treat syndrome, as early as possible. And for this, we require a biomarker. The World Health Organization has defined biomarker as an objectively measured characteristic used as an indicator of a normal or pathological biologic process or a pharmacological response. It has also been suggested that biomarkers should be as sensitive and specific as possible. They should measure with good precision and reproducibility. They should be readily available, affordable, and also responsive to minor changes and provide quick and timely results. So when we talk about biomarker, we should understand what is an ideal biomarker. So they should be highly sensitive and specific for sepsis to allow the differentiation between infectious and the non-infectious causes of inflammation, organ dysfunction, and shock. They should also be linked to various pathophysiological processes like inflammation, coagulation cascade, tissue damage, tissue repair. They should be present at the onset or even before the appearance of clinical signs of sepsis so that we can have a prognostic value. They should be very easy and safe to measure with very affordable price range both to the patients as well as to the healthcare facility, and should be biological plausible, right? So when we know all this about an ideal biomarker, but still we don't have a single biomarker which is very enough to measure the sepsis insult. Reason? Sepsis is a continuous disease and it changes its phases from colonization to infection to systemic infection, and that too of various levels of severity. It is a heterogeneous syndrome. The consequences of sepsis may vary from one patient to another, and the clinical definition is very vague. We are still relying on certain signs and symptoms to define sepsis, and bacterial pathogens which trigger sepsis are numerous. So we cannot actually, say which insult or which bacterial infection will cause what kind of response in a particular individual. So when we talk about biomarkers, they are categorized into three broad categories: diagnostic, prognostic, and therapeutic. When we want to differentiate between infectious and non-infectious sepsis, or between bacterial and viral and fungal infection, they will come under diagnostic category. When you want to risk stratify these patients, you want to predict the outcome, that whether this patient will survive or what is the chance of a negative outcome in this patient. We also want to predict the complications and what are the chances of development of multi-organ failure. How can we do a discharge? So what are the discharge criteria? Do we need to escalate the therapy or de-escalate the therapy? Here comes the prognostic markers. And therapeutic markers will be: how do you do an antibiotic stewardship? Can you diminish the antibiotic overuse? You can also look at the emergence of multi-drug resistant pathogens, and so therapeutic biomarkers. So if you look at septic biomarkers history, now in 400 BC, Hippocrates first defined sepsis in an individual. Then hectic fever was defined by Machiavelli in 1500. Osler first understood what is the response of a host when there is a septic insult. Lactate has dated back to 1843. Then Schottmuller gave the first scientific definition of sepsis, and so on and so forth. So 1992 we had the sepsis 1 definition, in 2001 we had the pyro model, the sepsis 2, and now we are looking at sepsis 3 model, which is 2016. And during this course of time, various biomarkers have come, like CRP, IL-6, then the SIRS-CAS paradigm. We are also looking at HLA, procalcitonin, STREM1, omics, and now we know that procalcitonin has also been incorporated into the antibiotic stewardship program. So if you look at markers of sepsis, there are n number of markers, but can we utilize all of them? What is the relevance? What is the sensitivity and specificity? So I would be touching a few biomarkers in my talk. So if you look at the earlier ones, the earlier in 1980s, and so we were looking at the hyperimmune scenario, and we were looking at high dose of steroids, or how do you cut down this immune response. And so the levels of cytokines or the cytokinemia was considered as the main pathology behind any septic insult, and all the therapies were targeted towards it. So serum levels of IL-6, TNF, and IL-8 were studied a lot, and they were found to be increased in patients with sepsis. Raised serum levels also have been shown to be associated with development of organ function and mortality. The IL-6 has received the maximum attention. Even during the COVID era, we know that IL-6 was done right, left, and center. There have been various other conditions like major surgery, trauma, exacerbation of autoimmune disease, transplant rejections, viral infections, again, where these cytokine levels will go up. And so increasing levels have been associated with poor prognosis, but the problem is they're still not able to differentiate between a bacterial or a viral or a fungal infection. Yes, it will tell you that there is some amount of inflammatory process which has triggered in the body, and so cytokine levels are released. CBC has also been used as a biomarker of sepsis. Yes, it has a very rapid turnaround time. It is easily available, very easy to conduct in all the laboratories, and it is available to the clinician. But again, it is not specific for sepsis. It does not provide any information or etiological diagnosis for sepsis, and their values can also be influenced by various clinical conditions. Then C-reactive protein. Now we all know that C-reactive protein is an acute phase protein. This is synthesized in liver. The IL-6 mainly stimulates the synthesis, and this binds to the bacterial polysaccharide and chromatin, and finally it activates the complement pathway, and it also increases the immune inflammatory response in bacterial infections. So when we look at the diagnostic use, it is mainly used as a marker of inflammation, and the normal concentration varies from 5 to 10 milligram per liter, which keeps on increasing as we age. The higher levels like late pregnancy, mild inflammation, even viral infections can have values up to 40 milligram per liter. But when you have more active inflammation or a bacterial infection, the levels will be higher from 40 to almost 200 milligram per liter. But when you talk about severe sepsis or patients of burns, the CRP level will be very, very high, more than 200. And this is because it's an acute phase reactant. It can also be used as a follow-up marker where you can keep measuring on a daily basis or probably on an alternate day basis the CRP levels, and it will tell you about the effectiveness of the treatment if the CRP levels are on a downward trend. This was an article where it looked at CRP as a marker of infection in critical ill patients, and what they found was when the healthy subject CRP was done as compared to already diagnosed infected patients, the CRP levels were very high in infected patients as compared to the non-infected ones, and it showed that it is a marker of sepsis, and the ROC curve was also highly sensitive when we talk about any inflammatory process going on in an individual. There are certain limitations. As I said, it's a non-specific marker of inflammation, so it does not tell you about which organ or organs are affected. Again, it can also be used to assess the cardiovascular risk status if they are made in the absence of acute inflammation. So if when there is no inflammation, we can still look at this certain advantages of CRP, but still CRP as a marker of sepsis is again a very, very non-specific marker. Then the most used, most studied, most written marker of sepsis, procalcitonin, and this is a hormone of calcitonin. This is normally produced in the C cells of the thyroid, where it is and then eventually it is converted to calcitonin. The normal levels are undetectable, and so it is less than 0.05 nanogram per ml. Bacterial infection, it stimulates the procalcitonin production, and so endotoxins and cytokines, they cause PCT to be produced in many tissues of the body. And so the concentration keeps on rising, and it goes above 0.25 nanograms, almost 5 times the normal values. Then it indicates significant relevant bacterial infection. And when we say the levels go more than 2 nanogram per ml, there is a high risk of severe sepsis or septic shock. So when we talk about procalcitonin, as I said, it is produced by numerous organs whenever there is a bacterial infection. So if you can look at this image, in healthy subjects, only this thyroid is the production, and very minimal production happens in the lung. But when there is presence of bacterial infection, right, when there is presence of bacterial infection, almost all organs of the body produce procalcitonin. So thyroid, white blood cells, spleen, lung, liver, kidney, adrenal, brain, spine. So almost every organ starts producing procalcitonin. That's the reason the procalcitonin level rises within 3 to 6 hours, and the half-life is 20 to 24 hours. It helps in early identification and risk assessment. So whenever there is an elevated level, even if it is more than 5 times the normal, it suggests significant bacterial infection in the subset. When you look at the relevance of this biomarker, so there have been various interventional studies which have been done. So they have found that Procalcitonin is suggestive of infection like meningitis, upper respiratory tract infection. Patients with pneumonia, COPD, acute bronchitis will have very high procalcitonin levels. Septic shock, severe sepsis, we all do this marker to diagnose it. Post-operative complication and ventilator-associated pneumonia. So these are the indications where the role of procalcitonin has been looked very strongly. When you look at certain observational studies like bacteremia, endocarditis, there still have been the advantage of procalcitonin is there, but pancreatitis, certain abdominal infections, we are still looking at whether procalcitonin is suggestive of infection or not. But bloodstream infection, pyelonephritis, neutropenia, so almost all the infective etiologies that go through the body have shown that procalcitonin levels rise in these conditions. So when we talk about the use of procalcitonin, diagnostic uses, obviously we want to diagnose and risk stratify. We want also to look at the differentiation between viral infections like meningitis also. We also want to monitor the therapeutic response to antibacterial therapy and reduce the antibiotic exposure. It helps in diagnosis of systemic secondary infections after surgery and in patients with trauma, burns, and multi-organ failure, and in infected necrosis in acute pancreatitis. When we do a prognostic marker, so there is a proposed application of serial procalcitonin measurements, so that you want to choose the timing of initiation, you want to look at the prognosis, you want to look at prognosis of critically ill patient with systemic infection, you also want to see when do you need an antibiotic therapy and how can you shorten the duration, and also as a independent graft failure predictor after renal transplant. It has been shown to be advantageous as compared to the other biomarkers because it rises very early and it stays in the system for almost 20-24 hours. So you have a good time frame to measure procalcitonin. Now, this was a randomized trial where they looked at what is the role of procalcitonin in determining the duration of antibiotic in septic patients. And when serial procalcitonin was done, it was found that there were more proportion of patients who eventually did not require antibiotics, or the antibiotics were de-escalated early as compared to the control group. In this pro-rata trial where they gave antibiotics based on procalcitonin versus a control group, in almost all indications, which is community-acquired pneumonia, ventilator-associated pneumonia, abdominal infection, UTI, blood cultures, the procal guided therapy was of shorter duration as compared to the conventional one. When we look at the procalcitonin for diagnosis of infection and to guide antibiotic decision, it was found that if you're serially measuring your procalcitonin and if the levels fall down to almost the normal level, that is around 0.05, you can stop your antibiotic even, and the patient will not be infected, because this is a marker that the infective process is settling down and the release of procalcitonin from other body organs is not happening. So on the basis of level, you decide whether to continue the antibiotic or to stop the antibiotic. A meta-analysis was conducted which looked at serum procalcitonin and C-reactive protein, and they found that ROC curve of PCT was very good as compared to CRP in predicting. So it was more sensitive in predicting the bacterial infection, and they found that it was very good for differentiating bacterial infections for viral infections. Although the cost is high for procalcitonin as compared to CRP, but still the definition or the determination of this inaccuracy was much better in procalcitonin, which helped in a better decision making. And then there have been n number of articles looking at the utility of procalcitonin, whether in infection or inflammation or to guide your antibiotic therapy. And there have been various procalcitonin algorithm as well. The Surviving Sepsis campaign in 2000, in every session, so even in 2021, they have utilized procalcitonin in two of their recommendations. One, they recommend against using procalcitonin when you want to initiate your antibiotic. So procalcitonin should not be used as a marker of to determine when to initiate your antibiotic. Rather, it should be used as a marker to de-escalate the antibiotic. So these are the two areas where Surviving Sepsis utilizes procalcitonin. There are certain limitations, although as I said, it still does not differentiate completely between a viral fungal infection. When you have a mycoplasma infection, there is no response, and we even find high procalcitonin in non-infected etiologies like severe burns, major surgeries, or certain systemic processes. There are relevant causes of false positive and false negative results. We all know that CRP response is blunted in fulminant hepatic failure, but the overall clinical relevance of renal dysfunction, chronic liver insufficiency, and corticosteroid treatment on procalcitonin is negligible. Patients with CKD active infections will have a higher level as compared to those without infection. So CKD per se patients will have a higher procal levels. Now, talking about certain future biomarkers, there are quite a few, although they're all certain are in the market, certain are still in the phase of research. So one of them is soluble triggering receptor expressed on myeloid cells, so which is named as STREM1. The other is SUPA. The third is the ProADM, pre-sepsin, and so a little bit more. And when you look at the value of these, so they are both used as prognostic and diagnostic marker when we talk about STREM1 and in various indications like sepsis, pneumonia, meningitis. For ProADM, it has been used as a prognostic marker, specifically in pneumonia. The SUPAR again has been used as a prognostic marker in sepsis and tuberculosis, and pre-sepsin has been studied a lot and it has been used as a marker for sepsis. And there have been various levels and values on which the sensitivity and the specificity has been compared. For example, for STREM 600 is generally considered as a good value on which the sensitivity is around 80%, and there are values for other ones also. So let us look about STREM1. This is a member of immunoglobulin family. Its expression on the phagocytes is upregulated by exposure to bacteria and fungi. And the soluble form, so that is the reason it is called as S. S stands for soluble. So soluble form is found in pleural fluid, bowel fluid, urine, plasma, and CSF. So when you look at certain literature, so there was a systematic review and meta-analysis where they looked at what is the accuracy for sepsis diagnosis and systemic inflammation. They found that the sensitivity and the specificity was around 0.8%. If you can look here, so this represents on the ROC curve, the sensitivity and specificity was around 0.8%, and they concluded that STREM1 had moderate diagnostic performance in differentiating sepsis from SIRS in adult patients. But as a single marker, as a solitary marker, this was not sufficient enough for sepsis diagnosis. Then there was one more trial where they looked at STREM1, where they wanted to distinguish systemic inflammatory response syndrome between survivors and non-survivors, and they found that it wasn't useful because there was no increase in the STREM level as compared to the healthy subjects. The healthy subjects had little higher levels, and when the patients had SIRS or severe sepsis, the levels did not increase much, and they concluded that in their study with SIRS or sepsis, STREM1 was not elevated compared with healthy controls, and so they said it should be carefully reviewed before using this molecule as a septic biomarker. The second molecule is soluble urokinase type plasminogen receptor, or the SUPAR. Now, this is expressed on various cell types, including neutrophils, lymphocytes, monocytes, macrophages, and vascular endothelial cells. During the inflammatory disease process like sepsis, the UPAR, that is the urokinase type plasminogen receptor, is cleaved from the cell surface by proteases. It releases a soluble form, and so it becomes SUPAR. Now, if you look at the literature where they looked at what is the role in the first week of treatment in the ICU, they found that in septic patients, the level was really high as compared to the non-septic patients, and even on the ROC curve, the SUPAR had a higher sensitivity and specificity, but they said that it is a stable and a robust marker in critical ill patients to assess disease severity and mortality risk. And if you have low SUPAR levels, they are highly predictive of ICU and overall survival. So it was a prognostic marker when it came to sepsis definition. Then came the Triage 3 trial, where this was a cluster randomized clinical trial where they looked at the value of SUPAR in the emergency department. What they found was there was no difference in the Kaplan-Meier plot between the control group and the group where SUPAR-based treatment was initiated. And they found that it wasn't telling anything about the overall mortality. And they said that it did not affect short or long-term all-cause mortality among unselected acutely admitted patients. And they said further research is required. This was one of the other mini review about from John Lee Vinsa about SUPAR as using as a prognostic marker, and they said that SUPAR levels vary in the types of patient population studied, the basal conditions of the patient, and the methods used. And so they said that the precise pathogenic involvement of SUPAR and of its different forms during sepsis are not well defined, and it does not appear superior to the existing biomarkers like CRP and procalcitonin in diagnosing sepsis. The other biomarker is proadrenomedulin. Now, this is a 52 amino acid peptide with immune modulating metabolic and vasodilator activity. Its widespread production in the tissues help to maintain the blood supply in every organ, and it also has an bactericidal activity, and it can be used for evaluation of sepsis diagnosis, prognosis, and in monitoring of such conditions. There are articles suggestive that it can be used in severe sepsis and septic shock patients with community acquired pneumonia, where on the ROC curve the sensitivity and specificity was around 0.75 or 0.78%, and they said that if you are focusing on CAP, the pro-ADM levels correlated with the severity of illness and death, and they said that this marker can potentially be clinically useful for prognosis in this patient, specifically if you are looking mild to moderate disease pattern. Now, this was another study where they looked at two biomarkers, SUPAR and pro-ADM, as hospital mortality prognostication. And when they combined it with other markers like SOFA, Apache, procalcitonin, CRP, they found that they were reasonably sensitive and specific in comparison to the other biomarkers. And when you're combining all these biomarkers, if you're combining Apache with pro-ADM, the area under curve was almost 0.82, which is a good sensitive marker if you look at. The another marker is pre-sepsin. Now, in 2004, a new biomarker, which was SCD14 subtype, which is named as pre-sepsin, was found, and it was looked at the diagnostic and prognostic marker for sepsis. Now, CD14 acts as co-receptor for the detection of bacterial lipopolysaccharide. By activating an inflammatory signaling cascade on contact with the infectious agent, this CD14 has a role of recognition molecule against the microorganism, and during inflammation, the plasma protease generates soluble CD14, and one of them is called pre-sepsin. So in the immune response to sepsin, the serum levels of pre-sepsin are elevated even before procalcitonin or IL-6, and it has been proposed as a potential biomarker for the diagnosis of sepsis. When you want to compare it with procalcitonin, if you look at the diagnostic accuracy, the best diagnostic cutoff for pre-sepsin was around 600 picogram per ml, and at that level, the specificity, sensitivity and specificity was 78.95%, which is not bad. The best diagnostic cutoff in terms of sensitivity and specificity for Procal was 0.18 nanogram per ml, which corresponded to 89.47, so which was much more than the pre-sepsin. And when you talk about prognostic accuracy, so analysis of a 60-day mortality showed that there was superiority of pre-sepsin compared to Procal. At first evaluation in ED, the pre-sepsin levels were higher in non-survivor septic patients than survivor. No such relations were found with procalcitonin. And the close correlation between pre-sepsin initial levels and in-hospital mortality suggests that its potential usefulness for early recognition of high-risk septic patients is there, so that we can be more aggressive with this subset. Since then, there have been a lot of articles. Also in the LBOS trial, the pre-sepsin was done, and they found that there was a mortality prediction was better. In a Korean population also, it was better. Then CD64. Now, this is again a high affinity immunoglobulin receptor, which is expressed at low concentration on resting neutrophils, but it rises precipitously whenever there is an inflammatory cytokine response. A biphasic expression pattern is observed, which means there is an initial rise after 2 hours and a more pronounced rise after 6 hours. And once the inciting stimulus is removed, that levels keeps on decreasing up to 48 hours. There are articles which have looked at what is the role of CD64. This was a meta-analysis where they looked at various studies which were involved, and they found that they were pretty good on the ROC curve, almost 0.85 to 0.89. And they said that the result of this meta-analysis demonstrate that CD64 expression on neutrophils is a reliable biomarker for the early diagnosis of bacterial infection, since it has good overall diagnostic performance. Then a new molecule which has come in is the pancreatic stone protein. And now this has also been looked at a marker for sepsis. So this is what is released during pancreatitis, and then it was extrapolated to other inflammatory condition. And when they looked at before the septic insult and during the septic insult, they found that PSP levels were better and the area under curve was 0.65 before sepsis and even after sepsis as compared to the conventional ones, which is procalcitonin and CRP. And they concluded that a single measurement of the REG gene of PSP concentration within 24 hours of ICU admission stratifies these patients of sepsis according to the severity of infection and the risk of death. There are quite a few articles which support the role of pancreatic stone protein as a biomarker. But still, there is no single biomarker which can be used as a sacrosanct of for defining sepsis. And so, because none of them have high accuracy, we will require a magic bullet marker, and until then you will require combination of markers. So you require a combination which improves your diagnosis, prognosis, and treatment efficacy. And these three best performing markers, so these are CRP, procalcitonin, and neutrophil count, are probably considered to be better in terms of predicting the above three things, which is diagnosis, prognosis, and treatment efficacy, with the ROC AUC of 0.88. Now, this was a review which was written by Professor John Lee Visa, which said that none of the biomarkers present, so he looked at almost 178 biomarkers, and they said none of the biomarkers has sufficient specificity or sensitivity to be routinely applied in clinical practice. Procalcitonin and CRP have been most widely used even with limited abilities to distinguish sepsis from other inflammatory conditions. And what are the problems? So we don't have a gold standard. Many patients in ICU will have culture negative infection, making it again challenging to distinguish between infections and non-infectious mimics. There are comorbidities which will affect the levels of these and interpretation of these biomarkers. The disease is heterogeneous. The various studies are observational studies, and so the sample size is small. We don't have a pre-test probability in terms of a specific cutoff, and the control groups are also inappropriate. So this is what we are expecting, that suppose a patient from a post-operative patient comes from on a general surgical ward develops fever. So in 2 minutes, his bedside sepsis panel should alert that he has infection. In just 7 minutes, we say, yes, this patient has Klebsiella and is identified from a blood sample. Antibiotic sensitivities are provided. Appropriate antibiotics are started. Renal panel, a bedside renal panel will tell us that he is at high risk of developing a renal failure, likely to require renal replacement therapy. And so immediate transfer to ICU is warranted. Urine output starts to fall, and there is a blood volume biomarker level which tells that this patient is going in a fluid overload. There will be an acute respiratory risk panel which tells us that this patient is going towards ARDS. All these suggest that the renal replacement therapy is started even before the creatinine levels are rising, and then you also have a lung protective agent marker which is there. So this is what our expectations are there from the biomarker. But we need to understand that there are certain questions which each biomarker is asked and still we are not able to answer. So for example, what is the pre-test probability for the diagnosis of that we are considering? For example, procalcitonin, we are looking at, do we have sepsis or not? And that's the role of procalcitonin. But there is low or high pretest probability alone can only guide decision, and still procalcitonin has not been able to answer this question. Now, if you look at the outcome benefit of a marker, so SUPAR has been looked at, and still we say that if you have a low SUPAR level, then the probability that you will survive the hospital and the ICU stay is there, but still it has not been confirmed in various studies. So to conclude, biomarkers are useful tools, but the correct time of doing them and their interpretation is very important to know. They are costly. Their value is only when we do repeated measurements. None of them have shown to completely differentiate between an infective and a non-infective condition. They're still semi-quantitative in nature as far as their implication in clinical practice is concerned. We should all understand we have n number of markers, but a fool with a tool is still a fool. So please don't just use a biomarker to diagnose, use your clinical sense. Biomarker can be an addendum to your clinical sense, and still most of the biomarkers are non-specific in nature, and their ROCAUC is still not very good. So always use your clinical sense. Thank you so much.
Thank you, Dr. Sachin, for taking us through all the biomarkers available and the use. As we all know that sepsis causes impairment in the immune system. But what was the experience with the immune regulators in ARDS secondary to H1N1 infections? So I request Dr. R. Manimaran for taking us through the experience. And this specific session has been sponsored by Biocon. I welcome Dr. Manimaran. He is a chairman at Candence Group of Hospitals in Chennai, and his area of expertise is critical care and pain management. Over to you, Dr. Manimaran.
Welcome one and all for my topic on immune system changes in sepsis and my personal experiences with immune regulator in ARDS. I'm Dr. Manimaran Rajendran. I'm a practicing critical care physician. Now going to the word sepsis. Sepsis is synonymous with decay, which was used 2700 years ago in Homer's poems and subsequently used by Hippocrates, Galen, ETZs around 600 BC to 700 BC. Now we've seen how the definition of sepsis have evolved. From systemic inflammatory response, sepsis, severe sepsis, septic shock in 1991 to 2016, where we've completely done with severe sepsis because there's nothing called less severe sepsis at all. That's how the word sepsis evolved from 2700 to today. Let's now go to the different kinds of sepsis. Is a bacterial sepsis, viral sepsis, and the fungal sepsis. Though they might have their unique characteristics, but they trickle down to 4 basic points. One is the patient is at different degrees of immunosuppressed. They are fatal if improperly treated. They are associated with inflammatory organ damages. They're biphasic in nature. When we say biphasic in nature, what do we mean by biphasic in nature? There is an inflammatory phase, there is an immunosuppressive phase. It was believed that the immunosuppressive phase always follows the inflammatory phase, but then the recent study says they might coexist. They might happen in different stages. There might be some immunosuppression and then inflammatory stage on a later time also. Now, going to what is an inflammatory stage? There's an excessive inflammation, the release of pro-inflammatory mediators, cytokines, activation of the immune cells, the antigen-presenting cells, the cell injuries, the pyroptosis, coagulation, abnormalities, the activation of endothelium leading to the microvascular thrombi, and now coming to the immunosuppressive stage. The release of anti-inflammatory cytokines, apoptosis of the B cell and T cell, there's a T cell exhaustion, there's upregulation of PD-1 and PD-L1 axis, reprogramming of the APCs, reducing of the HLA-DR, expansion of the TREG cells and MDSCs. Now going to the current management. What is the current management strategy we have? Early diagnosis is the main way to actually have a better outcome. The surveillance of early recognition. Once these criteria of sepsis is met, you start the resuscitation. The resuscitation, it starts with an antimicrobial culture. That is the first step. So there is two places, two culture, the empirical start of antimicrobials within the first hour, there's a golden hour, the fluid resuscitation to start within the third hour, the vasopressors if needed. Once you're done with the first and third hour, then we go to the definitive management. The definitive management includes the fluids, the vasopressors, targeted antimicrobials, corticosteroids, the glucose management. The sepsis deranges the glucose, the body's glucose levels, the venous embolism prophylaxis, because we saw there are a lot of microemboli possibilities, the stress ulcer prophylaxis. Stress management, sepsis management. Timing is critical here. The 0 to 6 hours, 6 hours to a day, and 1 to 2 days. At 0 to 6 hours, you identify the suspected sepsis using the SIRS scores, QSOFA. The SOFA is replaced by QSOFA now because we wanted to do it as quick as possible. We initiate the broad spectrum antibiotics as quick as possible, assess the need for source control, administer intravenous fluids, vasopressors if required. Within a day, we start them on a low dose corticosteroid in a high risk patient if they have a refractory hypertension. Achieve the source control, use evidence-based adjuvant care. We are coming to the evidence-based adjuvant care on a later slide now. And for the 1 to 2 days, if the persistent shock, add corticosteroid if you have not already added. Consider narrowing the antibiotic according to your 24 hours culture sensitivity and the 48 hours culture sensitivity. Continue evidence-based adjuvant until the resolution of illness. Now, this is alarming. There's 213 people who dies for every 1 lakh people admitted with sepsis in India. That's the Lancet study says. That's what the Lancet study says. Sepsis management. What do we need to improve? Why do we need a sepsis management? Sepsis is just not associated with high health economic costs, but also the high mortality. In a study says 40% of the septic patients admitted in the ICU have a 28-day mortality. Out of that, 38% dies within first 2 days of the ICU admission. That means our first 2 days are so crucial, and we'll have to let's go to the biomarkers. What are the biomarkers? Different biomarkers for sepsis: CRPs, LDH, IL-6, tumor necrosis factor alpha. Now, the role of immunomodulators in the management of sepsis, like we already said, that's an adjuvant, there are proven adjuvant therapies, there are adjuvant therapies in the research. Let's go for the different modalities which can be used as an adjuvant therapy. Steroids, the Forerunner, the Ulonistatin, the Thymosin alpha-1, the HAT therapy, high-dose vitamin C, tocilizumab, IVIG. Tocilizumab and IVIG have been used exclusively and been extensively in the COVID in the recent times. The HAT therapy, hydrocortisone, ascorbic acid, and thiamine, intravenous immunoglobulin therapy, all these are different choices of immunomodulation therapies in sepsis, ARDS, and acute pancreatitis. Now coming to my molecule of interest, itolizumab. It's an anti-CD6 monoclonal antibodies. The antigen presenting cells go and activate the T cells through its ALCAM, and this itolizumab it stopped the ALCAM expression on the CD6, thereby reducing the activation of the T cells. The activation of the CD6 by its ligand ALCAM, the stimulation of T cell proliferation and pro-inflammatory cytokine secretion. The itolizumab binds to the SRCR domain of the CD6, thereby reducing the inflammatory process. Now coming to the different immunomodulators, the corticosteroids, tocilizumab, and the itolizumab. The corticosteroids, it's a potent anti-inflammatory activity. It decreases the neutrophil infiltration. It decreases the edema. It's non-specific, specific broad spectrum. Coming to the difference between itolizumab and the tocilizumab, the itolizumab binds to the CD6 receptors and blocks the ALCAM-mediated T cell activation, while tocilizumab binds to the IL-6 receptors, block the IL-6-mediated signaling of the immune cells. And the downregulation of itolizumab includes IL-6, IL-2, tumor necrosis factor alpha, and IL-17, while tocilizumab blocks signaling of the IL-6 alone. The duration of action is longer with itolizumab because of the upstream effect on the pathway, and the tocilizumab is shorter due to the more downstream action on the pathway. This is a pictorial representation of the antigen presenting cells where the ALCAM expresses itself through the CD6 and activates the T cells without the itolizumab. With the itolizumab, the ALCAM is not able to express itself through the CD6, and the activation of T cells is decreased. So this is how these are the outcomes of utilization of the itolizumab. The CRPs, D-dimers, LDH, serum ferritin levels significantly decreases compared to the baseline. There is an IL-6 and tumor necrosis factor alpha also decreases 48 hours post infusion. There are quite a lot of studies which actually supports this. We ourselves in our department have presented a paper on the clinical course of the critically ill non-COVID-19 ARDS patient. We did not include the COVID patients using itolizumab. versus conventional treatment. We recently published a case series which comprised of patients with moderate to severe ARDS, the PaO to FiO2 ratio less than 200, chest x-rays of 10 patients who showed diffuse bilateral peripheral infiltrates, and this patient tested negative for COVID-19. All the 10 patients were admitted to the intensive care unit necessitating intubations, ventilatory supports, and were monitored for PaO2, FiO2, and PaCO2. Not just the PaO2 by FiO2 or their discharge date was noted, but their inflammatory markers like CRPs, D-dimers, IL-6, and ferritin were also noted. All 10 patients were treated with anticoagulants and antibiotics. 5 patients received itolizumab on D2. I'll come back to the why D2 on a later slide. These are the cases. The case 1, the case 2. The case 1 was discharged after 18 days. The case 2, I'm coming to the discussion, the comprehensive discussion later. This is the case 2, which got discharged on D9. The case 3, which got discharged on day 16. The case 4 was a 69-year-old male admitted with hypertension. He was discharged on day 16. And coming to the last case 5 was a 75-year-old with a comorbid diabetes mellitus and hypertension. The patient was treated with steroids, antibiotic, and everything. The radiological improvement on D5. The patient was discharged, and this was the shortest duration of all the cases which I had. And the patient was discharged on D7. All the other 5 cases were managed with standard medications, with steroids, anticoagulants, antibiotics, without the addition of itolizumab. 4 of the 5 patients made out of the ICU, but we lost 1 patient due to MODS. This is the chart explaining how the CRPs, ferritins, IL-6 were there. My experience. A total of 10 patients between the age of 40 to 75 with comorbids such as diabetes mellitus, hypertension, hypothyroidism, seizure disorder was enrolled in the observation study, and the course of the illness was documented till outcome were met. Among the 10 patients, 5 patients received immunomodulator itolizumab along with other medications such as antibiotic, anticoagulants, while remaining 5 patients did not receive itolizumab but were treated with other medication as mentioned above. All the patients were treated with itolizumab, recovered, and got discharged. 1 patient which did not receive itolizumab did not make out of the ICU. The prognostic markers like IL-6, D-dimers, ferritins provided a real view of the clinical course, not just the patient getting discharged or the number of days the patient spent in the ICU. They reflected an improving PaO2 by FiO2 ratio, and we were constantly monitoring the PaCO2, and it was reducing with the itolizumab. Now coming, why D2? The best time to administer itolizumab would be the pre or early inflammatory phase. That's when their shortness of breath, their hypoxia starts, the abnormal chest imaging shows up. Now to the conclusion, due to itolizumab CD6 specific activity and its ability to prevent cytokine storm, early use of itolizumab is promising, preventing severe inflammatory conditions such as sepsis and pancreatitis. This case series highlights the necessity of a well-designed clinical studies to investigate the advantages and the safety profiles of the itolizumab in the treatment of life-threatening IL-6 mediated inflammatory response, with the prognostic markers such as standard for assessing the clinical responses. Thank you one and all for your patience.
Thank you, Dr. Maran. It was an excellent and very precise discussion. Moving ahead, I would like to invite Dr. Parikshit Prayag for explaining us about immune dysfunction in typically organ transplant patients. Dr. Parikshit Prayag is a consultant at and transplant infectious diseases at Dinath Mangeshkar Hospital. His areas of expertise are transplant infectious diseases, gram-negative resistant fungal infections. Over to you, Dr. Parikshit.
So hello everyone, and thank you so much for inviting me to this prestigious forum. Over the next 25 minutes or so, I'm going to be talking about immune dysfunction in solid organ transplant recipients. So we are going to be considering, the various factors that lead to immune dysfunction in these patients. And at the end of the day, how does it increase the risk of various infections, and which are those particular infections whose risk is increased because of these underlying immune dysfunctions. So when we consider, or when we use the term an immune suppressed patient, that's actually a very, very large spectrum. So right from the mild state of immune deficiency that is caused by pregnancy, up to someone who has undergone a haploidentical stem cell transplant for AML, or someone who has undergone a liver transplant and then has had to face an episode of rejection, then has received therapy for that episode of rejection. This is a very, very wide spectrum. So it is very important to know which arm of the immunity is affected. When you use the term immunosuppressed patient, it's essential to know what arm of the immunity is affected. And that is essentially going to determine the particular infectious risks in these patients. So these can broadly be classified into patients in whom the neutrophils are affected. So patients who have neutrophilic dysfunction. So for example, patients with AML have qualitative as well as quantitative neutrophil dysfunction, whereas someone who has been on, let's say, azathioprine for an autoimmune condition and then develops neutropenia because of the drug, this patient has quantitative neutrophilic dysfunction. Then you could have someone whose humoral immunity or B cell immunity is affected. You could have someone whose T cell immunity is affected or cell mediated immunity is affected, and you could have mixed defects. So depending on the type of immune suppression, these patients are at risk of different infections. So if you consider patients who are neutropenic, patients who have underlying hematological malignancies or who have neutropenia because of therapies, which are the infectious etiologies that we need to consider? So definitely we need to consider the typical bacteria like Staph aureus, Streptococcus, Pseudomonas, Klebsiella, but very importantly, we need to consider fungal infections. So when we talk about neutropenic patients, definitely consider fungal infections, Aspergillus, other molds, Candida, mucormycosis, and so on. When you talk of patients who have humoral dysfunction, so let's consider a patient who has undergone splenectomy or who has received therapy which can suppress the B cell immunity. Then you have to consider infections with encapsulated organisms. So Streptococcus pneumoniae or Haemophilus, Capnocytophaga, these are encapsulated organisms. So infections with encapsulated organisms as well as PCP. When you think of patients whose cellular immunity is affected, then you have to consider intracellular pathogens. So for example, mycobacterial infections or Brucella, Bartonella, Listeria, Salmonella, Histoplasma, some of the endemic fungi. So these are organisms which are intracellular. So when you talk of T cell dysfunction, consider infections with intracellular organisms. And then many of your patients may have mixed defects. So for example, they could have a certain underlying condition like AML, but they could have received steroids for some other reason. So many of these times, patients will have mixed defects. So they may be their B cell as well as T cell arm may be affected. They could be neutropenic as well as, on some therapy which can affect their T cell immunity. So you have to consider mixed defects, and then the differential becomes very, very wide. So with this introduction, let us go over and see the immune dysfunction in solid organ transplant recipients. So when you talk about solid organ transplantation, so the surgery itself is just a time point in the patient's life journey. So this is a patient who has lived with chronic kidney disease for a number of years, has been on dialysis, or who has had alcoholic cirrhosis for a number of years, has had many complications from alcoholic cirrhosis, has had repeated infections, and then undergoes a liver transplant. So this is a journey. So it has to be taken in its entirety. So when you talk of immune dysfunction in solid organ transplant recipients, this immune dysfunction could be because of the underlying disease. So chronic liver disease or chronic kidney disease itself can predispose patients to infections or can cause alterations in their immunity, or autoimmune disorders. So consider a patient who has interstitial lung disease or has some autoimmune condition due to which his lungs are affected and he is undergoing a lung transplant. So immune dysfunction in these patients starts before the transplant itself. It's not just the transplant or the immunosuppressant drugs that these patients are going to receive. Immune dysfunction starts with the disease itself in many of these patients. Then comes the immunosuppressive therapy. So then you have induction immunosuppressive therapy, agents like ATG or alemtuzumab or basiliximab, and you have maintenance immune suppression. So calcineurin inhibitors like tacrolimus, cyclosporin. You have antimetabolites like mycophenolate and azathioprine. You have sirolimus-like drugs and steroids. So these agents can definitely cause immune dysfunction and increase the risk of infections. And then you have other factors. So for example, rejection itself can be associated with a lot of immune dysfunction. The therapy which is used for rejection, certain other viruses which can be immunomodulatory. So all these factors can lead to a lot of immune dysfunction in solid organ transplant recipients. So let us consider these factors in greater detail. Let us look at immune dysfunction in relation to the underlying disease. So as I mentioned, the underlying disease itself can predispose patients to infections and can alter their immunity. So someone who has chronic liver disease, so someone who has long-standing cirrhosis, these patients have neutrophilic dysfunction, so reduced migration or reduced phagocytosis. So qualitative neutrophilic dysfunction, what I was talking about. These patients can be at increased risk of bacterial translocations, so increased intestinal permeability, portosystemic shunting of blood, reduced intestinal mobility, dysbiosis, bacterial overgrowth. All these factors can mean increased bacterial translocation. These patients have been in the hospital in and out, many times. They've received many antibiotics. Maybe some of them have had episodes of Clostridium difficile associated diarrhea. All these things are going to contribute. Lymphocyte dysfunction, monocyte macrophage dysfunction, alterations in the complement system. So all these factors mean that even before the transplant, your patient with cirrhosis is going to have immune dysfunction. So these patients who have underlying cirrhosis are at increased risk of bacterial infections, fungal infections like Candida, Cryptococcus, even before the transplant. So it's not just the transplant that is going to make them immunosuppressed, or it's not just the transplant that is going to set in the immune dysfunction. Or your patients with chronic kidney disease, and we have all seen that, patients with CKD and patients who are on dialysis are at increased risk of infections. They have both T cell dysfunction as well as B cell dysfunction. So they definitely are at increased risk of bacterial, viral, as well as fungal infections. So even before the transplant, these patients have increased risk. Or as I mentioned, patients who undergo transplants for autoimmune conditions, interstitial lung disease. So the disease itself, the therapy of the disease, has already made these patients immunocompromised or immune dysregulated before the transplant. Then let us see what happens when this patient undergoes a solid organ transplant. So now we are going to consider immune dysfunction related to the immunosuppressive therapy. So let's first talk about induction immunosuppression. As I mentioned, most centers use agents like ATG or alemtuzumab or basiliximab for induction immune suppression. So let us talk about ATG first. So if you talk about ATG is something that induces T cell depletion. Although its effect is not exclusively on T cells, it does have some effect on B cells, but its main effect or its profound effect is on T cells. And this effect is long lasting. So patients who have received ATG can have T cell depletion or T cell dysregulation for up to a year. This is usually dose dependent. So the higher the dose, the more profound is the effect on T cells. So what does it translate into? What does this T cell dysfunction translate into as far as infectious risks are concerned? As far as bacterial infections are concerned, ATG does not really increase the risk to that extent. However, when these patients receive ATG, the overall factors are such that these patients are already at an increased risk of bacterial infections. So, they are in the hospital, they have just undergone a transplant. So they are on other drugs. So all these factors mean that, they are already at an increased risk of bacterial infections, but it's not per se because of the ATG. Whereas viral infections like CMV, BK virus or EBV, definitely there is an increased risk with ATG as well as PCP. One very interesting thing is that ATG can cause false positive assays for histoplasma antigen. Just 3 months ago, we had a patient who had undergone a living donor kidney transplant. And then, 1 month after the transplant, he actually had to face an episode of rejection for which he received ATG. And then after that, he developed bilateral pulmonary interstitial infiltrates. And the transplant team had sent a histoplasma antigen because this patient was from Uttar Pradesh. Now, this histoplasma antigen came out to be weakly positive, but his clinical syndrome was not fitting into histoplasmosis. That is when, we did a lung biopsy. We also sent, BAL CMV titers, blood CMV titers, and this patient actually turned out to have CMV pneumonitis. He was, his donor was CMV IgG positive, and the recipient himself was CMV IgG negative. And for a week or two before this episode here, he had missed his valganciclovir doses. So this was a case wherein there was a false positive histoplasma antigen because of ATG. But to summarize, ATG is a T-cell depleting agent. Effect can last up to 1 year, mainly increases the risk of viral infections when it is used in the setting of anti-rejection therapy. So when it is used as therapy for an episode of rejection, then it can increase the risk of fungal infections. But otherwise, mainly it is viral reactivations. Alemtuzumab. Alemtuzumab is an anti-CD52 antibody. Again, it's a T-cell depleting agent, but like ATG, it does have some effect on B cells. Its effect on T cell, again, is very long lasting. So these effects that it exerts on T cells can last up to 3 years. Now, alemtuzumab is popularly known as AIDS in a bottle. So by that, we can conclude that, its immune dysregulation or the immune modulating effects of alemtuzumab are similar to someone who has AIDS, so end stage HIV. However, if you look at the infection profile, it's a little bit different from patients who have AIDS. So you will not see a lot of infections like MAC or non-tuberculous mycobacteria or salmonella or listeria. What you typically see in a patient with AIDS, you will not see with alemtuzumab. Again, you will see mainly viral reactivations, and when it is used as anti-rejection therapy, you will see fungal infections. So in that sense, these are very similar agents, ATG and alemtuzumab. So what is common? They are both agents which cause T-cell depletion. Both have long-lasting effects, ATG up to a year, alemtuzumab up to 3 years. And both can increase the risk of viral reactivations when used as induction immune suppression. And when they are used as anti-rejection therapy, they can increase the risk of fungal infections. Whereas basiliximab is a non-T-cell depleting agent. It in fact binds to the alpha chain of the IL-2 receptor. Again, like ATG and alemtuzumab, it can increase the risk of viral reactivation. So be aware of someone who has received basiliximab, the risk of CMV, EBV, as well as hepatitis reactivations. So this was a very interesting patient that we had recently. This was a patient with living donor renal transplant. 3 months after his transplant, he had an episode of rejection, which was treated with ATG. And 1 month after this, he presented with fever and diarrhea for 10 days. Initially, his stool C. diff assay was positive, and also a norovirus PCR on the stool was positive. He initially received oral vancomycin, did not respond that well, received oral teicoplanin as well as nitazoxanide. Then the diarrhea reduced to a certain extent, and then it became bloody. That is the time he underwent an endoscopy, and this is what we found. So we found necrotic masses or necrotic looking lesions in the duodenum and in the gastric body. So look at his overall profile. He is someone who has undergone a living donor renal transplant and has received ATG for rejection. So again, as I mentioned, when this patient has received ATG as an anti-rejection therapy, we are worried about fungal infections. So we are mainly worried about viral and fungal infections when you look at the patient profile. When you look at the clinical syndrome, then I am more worried about fungal infections. So, my number one differential when I look at this patient would be something like mucormycosis. But guess what? He turned out to have post-transplant lymphoproliferative disorder with EBV. So again, he had received ATG as induction immune suppression as well as for rejection. And then he had very high copy numbers for EBV. So he had post-transplant lymphoproliferative disorder, which was EBV positive or EBV associated PTLD. So it's very important to consider what this patient is on, what this patient has received, what is the clinical syndrome, and so on. Now let's go over to immune dysfunction caused by maintenance immune suppression. So Let us look at calcineurin inhibitors. Calcineurin inhibitors are used very commonly in the setting of maintenance immune suppression. So again, these are T cell selective. So they inhibit T cell activation, and they also inhibit the production of interleukins, interferon gamma, as well as TNF alpha. These are associated with opportunistic infections. However, they do not increase the risk of fungal infections to that extent. And I'll come to that. The main reason is that they also exert some antifungal effects, or they have some antifungal properties. But if you look at tacrolimus and cyclosporin, again, mainly I'm worried about viral reactivations. How do they compare with each other? If you look at the risk of infection or sepsis or CMV, then there is not a huge difference. This is an old study, but again, what they found was that between tacrolimus and cyclosporin, there was not much difference. So both are comparable, maybe slightly increased risk with cyclosporin. As I mentioned, despite their potent immunosuppressive action, they have certain antifungal attributes, especially against Cryptococcus candida and Aspergillus. So that's why they are not agents which are associated with a disproportionately high risk of fungal infections. Now, interestingly, if you look at calcineurin inhibitors, this antifungal effect against Cryptococcus is actually exerted at high temperatures. So that's why you will see very peculiar syndromes in solid organ transplant recipients. So you will see a syndrome known as isolated cutaneous cryptococcosis. And why is that? Our skin temperature is low. So at this low temperature, calcineurin inhibitors will not exert this anti-cryptococcus activity or effect. And that's why you might see isolated cutaneous cryptococcosis. So overall, if you see, they do not increase the risk of fungal infections, but despite their antifungal properties, they really do not change the incidence of fungal infections also to a large extent. So you will still see a similar incidence of cryptococcosis in solid organ transplant recipients, whether or not they are on calcineurin inhibitors. But presence of calcineurin inhibitors or receipt of calcineurin inhibitors influences their clinical manifestations. So the incidence might remain the same, but their clinical properties will change. For example, you see far less CNS disease in the SOT population as against HIV patients. You will see more skin and soft tissue infections and a lower mortality. So again, to summarize the calcineurin inhibitors, tacrolimus and cyclosporin, they are agents which have effects on T cells and are associated with viral reactivations, not a lot with fungal infections. Now, antimetabolites, mycophenolate and azathioprine, they inhibit DNA and an RNA production. Now, azathioprine's mechanism of action results in suppression of all hematopoietic cell lines. You will see cytopenias associated with azathioprine. MMF more profoundly inhibits the proliferation of T and B lymphocytes, but it does not have a significant effect on hematopoietic or neutrophil populations. Again, both these increase the risk of viral reactivations. Risk is slightly higher with azathioprine. So let's look at this patient, a 40-year-old male with living donor renal transplant 15 months ago on MMF, tacrolimus and steroids. He was found to have BK virus-induced interstitial nephritis, a problem that we see to a fair extent in patients who have undergone renal transplants. Again, BK virus in this population behaves slightly differently. So for example, in the BMT patients, you will mainly see a hemorrhagic cystitis, whereas in renal transplant recipients, you can see interstitial nephritis and also affection of the graft. So once you have found BK virus associated interstitial nephritis, in which order will you hold the immune suppression? As I mentioned, the most profound effect is of antimetabolites. So antimetabolites should be held. Again, after discussing with the transplant teams, because for everything that you do in the world of transplant infections, you have to balance the benefits and the risks. So talk to the transplant team and if possible, hold the MMF. Next step would be trying to reduce the dose of tacrolimus. And initially you would treat this patient with IVIG if required cidofovir. Cidofovir again is a double-edged sword here because it itself can also be nephrotoxic. But the point here is that once transplant recipients get bad viral infections, then the first thing to hold or the first agent to hold would be the antimetabolite, MMF or azathioprine. Now we all know the perils of steroids. Again, they are associated with a number of infections, viral, bacterial, fungal, again nocardia, TB, PCP, and so on. So that just compounds, or that just adds to our problem. Sirolimus. Now, sirolimus is a very interesting drug because although it is used as an immunosuppressive agent, it actually does have some anti-infective properties. So it can have some anti-CMV action. It also has some in vitro activity against Candida and Cryptococcus. So if you look at the immunosuppressants, then this is the relatively better drug. So for example, if a transplant recipient has a really bad fungal infection or has a really bad CMV infection, and he cannot do away with immune suppression at that point of time, this is the time you talk to your transplant team and ask them whether the option of sirolimus is possible. So again, sirolimus does have some anti-CMV as well as antifungal properties, mainly Candida and Cryptococcus. So do think of sirolimus in a situation wherein you have a bad fungal or a CMV infection, and it is not possible to reduce immune suppression beyond a certain extent. So there are, as I mentioned, there are other factors which are also associated with immune dysregulation in these patients. So again, rejection itself is associated with a lot of immune dysfunction. The therapy that is used for rejection. So again, let's recall the fact that alemtuzumab and ATG, when they are used in the setting of anti-rejection therapy, they can also increase the risk of fungal infections. So these are again factors which are associated with immune dysregulation. Then these patients can get infected by immunomodulating viruses, CMV, COVID. We have all seen in the last couple of years that COVID can be an immunomodulating virus. So can CMV. So these factors again add to the immune dysregulation in these patients. So that's why formulating a differential in a transplant patient or formulating an infectious differential in a transplant recipient is a tricky process, because there are so many factors that you have to consider. You have to consider their pre-transplant history, epidemiological data. In the early stages or in the early post-transplant period, you have to also get all the donor details. You have to consider pre-transplant serologies. You have to consider the timeline. At what point of time am I seeing this patient after his transplant? What prophylaxis is the patient on? So what can he break through with? What were the surgical details? What immunosuppressive agents is the patient on? As we have been talking about this, whether he's on antimetabolites. If yes, what are the doses? Have these doses changed recently? Is he on calcineurin inhibitors? If yes, what are the recent levels of these drugs? Then what clinical syndrome am I dealing with? So once you consider all these factors, then you will be able to formulate a differential, and then you have to work them up accordingly. So in summary, there are various factors which are associated with immune dysregulation and increased risk of infections in the solid organ transplant recipients. The effects, mechanisms, and the risks associated with immune suppressants have to be carefully studied. So ATG and alemtuzumab, think of T cell depletion, think of long-lasting effects, think of viral reactivations, think of fungal when they are used as anti-rejection drugs. Then if you look at the antimetabolites, MMF and azathioprine, think of them as drugs that you will try and hold when the patient has really bad viral infection. Tacrolimus and cyclosporin, again, think of them as drugs associated with viral reactivations and not a very high risk for fungal infections. Sirolimus, think of it when you have a patient who has a bad CMV infection or a bad fungal infection, and reduction of immune suppression is not possible. So again, we have to familiarize ourselves with their mechanisms and the kind of immune dysregulation that these drugs cause. So that's why approach to a patient who has a transplant related infection or a transplant recipient who has an infection, the approach to this kind of patient is different. It's a complex process. It should be multidisciplinary. So you should involve your transplant teams. You should involve the infectious diseases consultant. You should involve your microbiology department. Talk to an immunologist if required. Involve your pharmacist as well. So multidisciplinary approach is the key. So again, thank you very much for your patient listening. And I truly look forward to the rest of the session. And once again, thank you very much for inviting me to this prestigious platform. Thank you.
Thank you, Dr. Parikshit, for an excellent talk. So we have come for the end of the day, and I thank you for attending this program, and I thanks all the panelists and faculties for their plenary sessions. It was an excellent talk, very descriptive, descriptive as well as precise, with the good take-home messages. Tomorrow, again, we are going to meet for more interesting topics. So I thank you all again.